Okay, good morning, everybody. Welcome to the 2021 Palliative Care Interdisciplinary Education Services Winter Conference. That's all about you. Today is a day to encourage you, support you, reward you in this one of the most difficult winters that us as Canadians have seen due to the pandemic. So the idea today is to really encourage you and give you what you need to do your fabulous work as palliative care, healthcare provider in the continuum of palliative care. So to start with, I want to thank everybody who is here, especially Ontario Health for the support with the funding of this committee. And I would like to remind you that all the housekeeping is in the chat. Please go there and read the housekeeping. If you have any doubts, just write in the chat and one of us will be answering you. And without ado, I would like to call for the message of Anthony Rota, who sent a few words of encouragement and support to what you fabulous palliative care tribe does all the time. Oh, Michaela, could you please play Anthony Rota's message?
Hello, Annie. Bonjour. Bonjour. This is Anthony Rota, Member of Parliament for Nipissing, Timiskaming, and Speaker of the House of Commons. I want to take this opportunity to thank you for including me in this training and this time where palliative care workers are coming together to share everything they've learned. And one of the things that I find very interesting about this meeting today is that you're sharing best practices, and that's something that's very important. Aujourd'hui, spécialement avec la pandémie, c'est très important qu'on apprend un de l'autre et on continue à grandir ce qu'on connaît. So to all of you, I want to thank you for taking the time to take this training and discuss and learn from each other and get the best practices out there so that our people dying and in palliative care have the best care possible. And that's something that takes dedication and it takes a certain skill set that I admire very much in all of you. So to all of you, on behalf of Parliament of Canada, thank you for being here today and taking these courses and sharing with each other the best practices.
Oh, you just have to unmute there, Monica.
So now we are giving the floor to Darren Renault, the chair of the board of Near North Palliative Care Network, who is now the payment transfer agency for the Palliative Care Interdisciplinary Education Services Nipissing subregion. Darren?
Good morning, everyone. Welcome, and to start things off before I do my opening message, I have a message from Brian Kaitor, who he's the interim regional lead for Ontario Health North. He is also the Chief Executive Officer of Northwest LHIN and Northeast LHIN. So Brian's message is, the number of Ontarians entering their last stages of life is expected to increase appreciably as the baby boom generation continues to age. From research, we know that coping with the growing demand for services and support affects hundreds of thousands of Ontarians. Their extended networks of family, friends, caregivers, and countless institutions. That's why it's so important for palliative care partners to work together. I want to congratulate the contributions of providers from all sectors for helping people of the North have dignity at end of life, including home and community care, visiting hospice, residential hospice, hospital, long-term care, congregate care, pharmacies, paramedicine, primary care, palliative pain and symptom management consultation services, pastoral care, funeral home services, and patient and family, Indigenous and Francophone representation. So I think Brian has covered off all of the groups, but his encouragement is very much appreciated with this. Now on to my kind of opening. So as board chair, this is kind of my perspective on palliative care. So opening, I want to say, Ani, hello, bonjour, ou l'écoute. Welcome everyone to this year's conference. Like many of you these days are now filled with time spent on video and virtual meeting spaces like this. I encourage you to treat this space with honor and respect, to be present in the room. This is the new evolving way we live and connect community. And the temptations of distraction from our desk are immense. Be present and mindful. I want you to take some time, write on a sticky note or the top of your notepad that you're taking notes with, and write down the phrase, "Are you being mindful?" Keep this visible for your day with us. So that little reminder is not only for the respect that this conference and its speakers deserve, but for a lead into what I as board chair want to relate in opening this conference. Mindfulness in palliative care and our lives being of service to others. Demands on our focus and attention are at unprecedented levels right now. For many reasons, and not just the pandemic or whatever the buzz phrase the media is using for it today, much is pulling our focus in such divergent directions, and the demand for instant response and reaction, or our perception of that demand, is a weakening force. Here's a quick mindfulness check. For the next week, watch your email, your text messages, instant messages, etc., and reflect on each one. Yes, every one of them. Make a judgment call and decide if you need to respond immediately, thus interrupting whatever you're engaging in. Ask what would be affected if I waited 15 minutes or 30 minutes or an hour. This reflection is just a short pause. After a week, how many messages truly required an immediate response? For perspective, it takes on the average less than 15 minutes to eat breakfast, 30 minutes to eat dinner, or 1 hour to have tea with a friend. You see, we have sacrificed quality time for quantity time. It's a myth that we can multitask. What we do is task switch very quickly. Are you doing that right now? Are you in this conference and on your cell and working on your computer? And what? What is negatively being affected by dividing our attentions? Are you being mindful? Personally, I am Anishinaabe. The 7 grandfather teachings of respect, love, truth, bravery, wisdom, generosity, and humility are the gifts I try to use each day. When I use the lens of these teachings and ask, what if I did not? The answer inevitably is a much poorer outcome. Each of these teachings must be used with the rest. To leave out one is to embrace the opposite of what is left out. Some of you may be seeing where this fits into palliative care, and some may be stretching to understand. So let's take a look at our warriors, our palliative care volunteers, workers, and supports. This is the front line. Put the 7 lenses on and look at them from respect, love, truth, bravery, wisdom, generosity, and humility. Now, are you starting to see the path that these warriors live and subscribe to? What would be the effect if they dropped one of those teachings? Is this not an immensely powerful observance? The 7 grandfather teachings really does carry us and give us a clarity lens into this. They're values. It's a value proposition. So what I'm seeing in the changing world around us is an erosion of these foundational values and a resulting fatigue and apathy, not in palliative care, but in much of what surrounds us in palliative care. I see it in the daily interactions with government, with agencies and stakeholders. Ask yourself, are they using the 7 lenses? Look at what we see in public pieces, publicity pieces, social media, and traditional media. Are they using the lenses? Look for what lens is missing, and that will tell you volumes about what you're looking at. I guess what I'm doing is issuing a call to action from all of the warriors here. You are all warriors, or you would not be here in this conference. The need for palliative care and the related services is undeniable. It is growing, and all indicators, leading or trailing, show that this is only gaining momentum. Look at the 400% growth of services delivered by Near North Palliative Care Network in the last few years as but one measure. We need to look at the world, and specifically palliative care, through the 7 lenses. There's no room for competition in compassion. Yet we see it every day with system members and providers, with committee members and hidden agendas. Use the 7 lenses and see what's being dropped. That will give you the valuable information you need. When working recently with my Inuit First Nation brothers in Nunavut, I learned a valuable lesson from their 8 Inuit societal values, which are very similar to the 7 grandfather teachings. One of the values is an Inuit word called Pilamaksarnik, or loosely translated, it means doing the right things right. Powerful teachings when you explore it. In determining if we are doing the right things, the 7 lenses will help. They will also help us to know if we are doing them right. This is by no means easy work, to shift our way of living and engaging in life. It is the right thing to do. Are we doing it right? Pilamaksarnik. So be mindful. Attend this conference with pride. Embrace learning about doing the right things right. Chimigwich.
Thank you very much.
And it's back to Monica.
Thank you very much, Darren. So now Michaela will play the message of the chair of the Palliative Care Interdisciplinary Education Committee. Michaela, the screen is yours. Welcome, everyone. My name is Monica do Couto Moni, and I am the chair of the Palliative Care Interdisciplinary Education Services Nipissing Subregion, organizer of this winter conference. I want to give sincere thanks for the words of support and encouragement we received from Anthony Rota, Speaker of the House of Commons and Member of Parliament, Nipissing-Timiskaming. From Brian Titer, Regional Lead of Ontario Health North and CEO of Northwestern and Northeastern LINs. From Darren Renault, Chair of the Board of Near North Palliative Care Network, responsible for the management of the conference funding. For the media with us today, and for the massive support and attendance to this year's conference by our member agencies and countless non-member agencies across Ontario. Wow. It's a great pleasure and honor to have you with us today and to see hundreds of faces of each of you, brave palliative care professionals. I also want to extend our welcome and thanks to our conference presenters, Jonathan Faulkner, Vice President of Operations, and Alana Corkery, Account Manager of Pallium Canada. Dr. Inês Fátima Dina, Medical Doctor specialized in palliative care, and Tara Moffat, Palliative Pain and Symptom Management Consulting for our region. Eugene Dufour, Master of Divinity of King's College at the University of Western Ontario, who will talk a little bit about bereavement and grief for healthcare professionals in pandemic times. Our member agency colleagues and my staff and placement students at Near North Palliative Care Network who helped organize this event for you. This year, we gather to think about best practices in the continuum of palliative care. A continuum is made of people united in harmony. The best practice and the transformative power in this continuum is you. You will hear a lot today about being mutually considerate, supportive, and compassionate with your superiors, peers, staff, and patients. About being gentle, understanding, and patient with yourself, especially during hard times. About building together the best workplace environment one can get with our personal attitude. Palliative care is evolving fast, and you have the power to make it better in every action you take. Today, I want to share a message of trust in you and hope in our common future. Never doubt the power of the small, the power of a million acts of kindness repeated daily by all of us in the grassroots. This creates a culture. You work in palliative care because you are kind and you want to help. So, bring your kindness daily to work. Let it shine before your superiors, peers, staff, and patients, and see smiles of gratitude and respect multiply around you. Never forget who you are. You desired to help people when you started your beautiful journey in palliative care. Well, you and your colleagues are people too, and deserving of one another's support. Let us not allow rivalries, cynicism, mistrust, judgment, and exhaustion take the best from us. Let us never act below ourselves and always take the high road of compassion and solidarity at every moment. Together, we can and will build best practices in the healthcare system. A continuum of kindness and mutual consideration is at the heart of system change. You matter, and you make a world of difference to those around you. One small act of kindness and one small smile at a time. Thank you, and hope you enjoy our day together at the 2021 Palliative Care Interdisciplinary Education Services Winter Conference. Enjoy it. Thank you, Makila. And now I would like to introduce Scott Taylor to all of you. He is our IT director of the board at Near North Palliative Care Network, and he will be giving technical support to the panelists. So Scotty, could you please bring Jonathan and Alana, the first panelists?
Hi there, everybody.
Hi, Jonathan. How, Alana? And thank you, Scotty.
Good morning. Thank you very much, Monica. And it's an absolute pleasure to be here. Thank you for having us today. My name is John Faulkner. I'm the Vice President of Operations here with Pallium Canada. And I'm joined today by my colleague, Alana Corky. She'll be predominantly managing the chat and answering any questions that you may have during the course of this presentation. I will leave some space at the end of the presentation to answer any questions that may come up, but given we're online, I think it'll just run a bit more smoothly if we work through the full presentation at the start. I'd like to begin by first acknowledging that I'm speaking to you today from the city of Ottawa on the traditional unceded territory of the Algonquin and Anishinaabe people. And thank you again for having us here today. So today I'm going to talk to you about a few different things spanning the full work of Pallium Canada. I'll give you a little bit of an overview of our approach and sort of the theory behind the work that we're doing to help build palliative care capacity among primary healthcare and generalist level healthcare providers. I'll speak to you about our Learning Essential Approaches to Palliative Care LEAP course, which I'm sure many of you are aware of, and give you some updated statistics and what's happening with that course. I'll also talk to you about our transition to online and what's happened there, what's happened because of the COVID pandemic, and some of the success and challenges and learnings that we've had come out of that. And then lastly, I want to talk to you about an exciting new initiative that we're starting. And this is a key part of our whole sort of theory of change around building palliative care capacity across the country. And that's the Compassionate Workplace campaign. So I'll speak to you a bit about that work that we're doing there. To start, I'll just want to give a little bit of background for those who may not be familiar. Pallium Canada, we're a nonprofit, national nonprofit. We actually just got our charitable status this year as well. We were founded over 20 years ago now, actually. 2020 was our 20-year anniversary. We had to cancel a number of planned celebrations of that major milestone for us. And we operate as a social enterprise. And I'll come back to that in the conversation a bit later, but it's an important part of the work that we do and the theory that we have around accelerating the capacity building, accelerating adoption of palliative care education and training. We're known as an education provider, but our focus is really on building palliative care capacity and transforming health practices and the health system. We are research driven. We are involved in research and conduct active research on our own work and in collaboration with others. And as I said before, we're working on a community side as well, trying to build capacity and empower communities to support some of their own palliative care needs where they can. We really believe that that this foundational palliative care capacity is essential across the entire country. And so our fundamental goal is to expand this access and expand the quality and availability of palliative care service for all Canadians. And we do this through the community that we've established over the past 21 odd years. So we really see ourselves as a community of clinicians and educators and researchers and administrators, involvement with Aboriginal leaders and volunteers. It's a whole community of thousands of people across the country coming together to make this thing happen. It's not just the 20 odd people that are employed with Pallium Canada. It really is that network and that community that makes all this work. I'll talk a little bit about sort of our approach and our theory of practice. Again, this will be familiar to many people on this here today. But our theory is that palliative care and our vision is that palliative care is everyone's business. We believe that everyone from community all the way up to specialist level palliative care teams have a critical role to play in providing palliative care. We believe it begins early at the point of serious illness diagnosis. We want that palliative care approach started then and started early, key conversations, etc. We're focused on providing core competencies for frontline healthcare professionals. Our role is not in building specialist level palliative care capacity. We really are about bringing those essential competencies, skills, knowledge, tools to all frontline healthcare providers so that they can provide better palliative care to the patients that they see and start that palliative care journey earlier. We believe in a holistic approach to palliative care. So yes, dealing with the physical, but also cultural, psychological, social, and spiritual needs of the patients and families. And really the role for the community and where we're trying to build community capacity is to create this wraparound effect for patients so that they're supported. Patients and families are supported when and wherever they are in need. And so this is where the two come together for us, with the patient and the caregivers at the center, receiving formal support where they need from healthcare and healthcare services, but also being able to access support within their community. We follow what's known as the Compassionate City Charter as our sort of theory of practice around compassionate communities. And this theory basically says that we want people to be able to access the support that they need, whether it's in school or the workplace or places of faith or in their neighborhood. That's where people need the support where they live and operate every day. And you'll see some of that come out in how we're implementing our community work. So I'm going to jump into LEAP, and this is our sort of our core product, our core work that we do with to deliver the palliative care approach and deliver education around the palliative care approach, I should say. As I say, I think many of you are familiar with LEAP. It's designed as a workshop competency-based style course. It's accredited with both of the physician colleges. Different courses are accredited differently, but we have accreditation for different specialties in different areas, but they are accredited, well-recognized courses that have been around for many, many years now. They've been designed to help promote teamwork and support interprofessional collaboration and connections between those providers. What we hear often, certainly before the pandemic, is that a LEAP course is the first time that some people meet face-to-face. They've been working together virtually or making referrals to each other, et cetera, but this is the first time they've had a chance to come together and actually meet different members of the team. It's been heavily adapted to different care settings, and I'll give you an overview of that in a second. And importantly, it's been developed by Canadian experts in Canada, for Canada, in the Canadian context. We believe strongly in that. We know it's an important piece of how we provide care in this country. I can't say enough about the network of over 900 palliative care clinicians and nurses, educators, social workers who support the delivery of LEAP. This doesn't happen without their dedication and hard work and effort, and their work over the past year in particular has just been outstanding. And the majority of our products are available in both English and French. So not every LEAP course is available in French currently, but the most common ones are. And we meet about 90% of our francophone education requirements with those courses. So, and we continue to expand our translation of courses and products and resources into French. So this slide really speaks to what I call our systems approach to building palliative care capacity. LEAP Core is up in the top left corner here. Is really our most well-known and common course, and certainly has the highest volume. But we learned pretty quickly that if we are delivering palliative care in a hospital or an emergency room setting or in long-term care, the language, the protocols, the availability of time, the processes are different. And so when we went to deliver a LEAP Core course into an emergency department setting, it just didn't make sense. An emergency doc or an emergency room nurse was saying, I don't do that, or I don't have time for that, or that's not how that works. And so that's what these adaptations are, is they're taking the fundamental principles and competencies in LEAP and making them available and more relevant or practical to the care setting or the disease specific issue, etc. Oh, I'm sorry. No one told me that I was not sharing my slides. My apologies. Do you have me now? Okay. I'm so sorry. You didn't miss any great graphics to start. The good stuff's coming up. So, as I was saying, so this is the slide that speaks to all the different variants and varieties of LEAP courses that are available. And as I was saying, so this is part of our systems approach. This is making sure that we have content and training that is relevant and contextualized to the specific healthcare professional or learner based on the work that they're doing. And I'll talk more about some of the courses that are in development, but we continue to expand and grow this suite of courses to meet different healthcare needs as they arise. And so this is a big part of our success story. So since we launched LEAP and started measuring and counting the data in late 2014, we've had over 31,000 actually now healthcare providers take LEAP, and we've delivered LEAP from coast to coast to coast. As you can see, we've gone as far north as Pond Inlet up in Nunavut, and this was a fantastic partnership we've had with the government of Nunavut for a couple of years, delivering an adapted, modified version of LEAP up for PSWs, nurses, and physicians working in Nunavut. Because LEAP has been predominantly until this year delivered in face-to-face workshops, you see a similar spread and distribution of where those courses are happening. And I think that's an important piece for us, is the community aspect or the local aspect of delivery of LEAP is really a key part of its success. And that's true whether we're delivering online or whether we're delivering a course in person. But our facilitators, the 900 plus of them across the country, are the experts in their local region as well as palliative care. And so they're able to adapt the content to that local context, talk about how certain processes may work locally where they're different in different parts of the country, and introduce people to members of the palliative care team or the local palliative care network. So we see this distribution. It just makes us smile in terms of the uptake of LEAP across the country. And this is the map of the facilitator network that I was speaking about. Just an incredibly passionate, dedicated group of people who are making palliative care education available across the country, and it's wonderful to see. And their dedication over the past year has been, as I said, nothing short of spectacular. So we also, as I mentioned, are very involved in research. So we're not satisfied to know just whether or not LEAP works, but we want to understand how well it works. And in fact, we want to understand not just is it a good course, but is it actually helping to influence and drive practice change? And so, as I mentioned, we have those 20 interprofessional sessions, or variants of the course, I should say. We have 1,800 different LEAP sessions that have been delivered, 31,000 healthcare providers. And what you're seeing on the right is some results of research that we've done on over 7,000 learners who took the course between April 2015 and March 2017. And we see pretty much across the board statistically significant increases in knowledge, in comfort towards providing palliative care, and in attitudes towards the delivery of palliative care. Importantly, we're getting good feedback on the course. So the vast majority of learners say that the course met their learning needs. And for anyone who's taken a LEAP, you'll know that we also do what's known as a commitment to change. So we ask learners at the end of the course to make a commitment to change based on what they've learned in the course, something they're going to do simple that when they get back into their practice, I'm going to make this change. We follow that up 4 months later and ask whether people were successful in implementing that change. And what we see is that 72% of those commitments are actually successfully implemented when they're made. And that's for us is that leading indication that we're actually starting to influence and influence a change in the practice of healthcare providers working in palliative care. And this is where we're going with our evaluation into the future. So we're looking now at longer term follow-ups to understand how practice change has actually been happening. And we're developing and we'll be releasing soon some short quality improvement toolkits to help people actually implement and make those changes. So we've got tens of thousands of data points of commitments that people have made about changes they want to make in their practice. And we were able to mine that data and say, all right, here's the opportunity for a quick toolkit to support people in making those changes, because here's where the low-hanging fruit is. And that's how we use our research to advance and drive the next evolution of products and supports and tools and resources. I'm going to switch gears now to talk a little bit about LEAP Online. And LEAP Online is something that we've been working on for a while. We were, like everyone, forced to accelerate that when the pandemic hit. And so we, in the matter of about a few weeks, were out the door with the first iteration and pilots of our LEAP Online course. And I'll show you some metrics on where we are today. It's quite astounding in terms of where we've gone in the past year. A little bit about the course. So it is fully online. It consists of 2 components. So it's what we call a flipped classroom or hybrid model. It has 16 interactive self-learning modules, and these are modules that learners can complete at their own pace over a course of days or weeks. It also has 6 hours of online facilitated webinars, and these are a special cohort of our LEAP facilitators who've taken some additional training on how to facilitate online. We currently have coming up on 300 of our facilitators who are taking the training and ready to teach online. And all of that is facilitated through our learning management system, Pallium Central. The course itself is accredited for 24 main pro credits with the CFPC and with the Royal College for 12 hours accreditation. Just like every other LEAP, it is built by palliative care, Canadian palliative care experts, and the same outputs or results for participants. So everyone gets a LEAP certificate, and they also get an electronic copy of the palliative care pocketbook. And people will also have access to our upcoming app. So we're launching a new app, which is just in final review with Apple and Google Play stores. And this app will provide access to the ability to take courses on your mobile device directly. And it'll also includes access to free practice resources and educational tools and supports, symptom guides, etc., directly in the app. And that'll be free for everyone to download as soon as it's live. It should be live in the next couple of weeks. I won't spend a lot of time talking about this, but these are the topics covered in the different self-learning modules. And the theory here is most of the didactic information that you need to know to provide a palliative care approach is provided in these modules. The webinars are really case-based. It's about discussing and applying the knowledge that you've acquired from those self-learning modules in person and in practice. As I said, 250, now we're actually getting closer to 300 online facilitators. Each of the facilitators is a certified LEAP facilitator that then takes a short online orientation on how to teach online. They then do a co-facilitation and an audit to learn how to put that into practice, and then they're off to the races in terms of being able to deliver LEAP online courses. And this is where we are. So we've delivered 72 sessions of LEAP online since March 2020. We have 46 sessions booked into the future, and actually that number has grown since we put this slide deck together, with close to 1,500 healthcare professionals that have been trained, and across majority of provinces and territories, people have been able to access that training. So this, for us, if you'd asked me back in March if we were going to have over 100 online sessions this year, I would have said no way. And so this is just an incredible testament to, I think, the demand and desire for palliative care training. As we heard in some of the introductory speeches today, it's just absolutely critical, and more people are looking for palliative care, and more healthcare providers are looking for training in palliative care. But it also is an absolute testament to our delivery partners who help us to organize and plan these courses, and to our facilitators who are stepping up and going above and beyond to make sure that these sessions can get delivered. This is what some of the online modules look like. So they play almost like a video with some interactivity, polling and questions within, the ability to zoom in on different diagrams, etc. And they remain available to you. So you can come back if there's something you forgot or something you need to refresh, you can come back in and jump into the resources at any time to refresh your memory on things. This is some of the metrics of the course. So we have the ability to do real-time data tracking on the course itself. And what you're seeing here is just some of our basic metrics of the professions that are taking the course, the regions where people are taking the course. We're seeing the outputs in terms of knowledge quiz results. So we're seeing similar results that we see to LEAP online. And we're seeing, stellar reviews and ratings of the facilitators in terms of the facilitation that's happening in the online webinars, which we're really pleased about. And I think one of the biggest things for us, and one of the biggest trepidations, was, will we be able to maintain a good interactive discussion and learning experience? One of the things that we know has made LEAP so successful to date. And pretty much across the board, we're able to say, yes, we have. So the feedback we're getting from participants is really strong, and they're really enjoying the facilitation. I think many of them are surprised with how interactive the webinar discussions are. And this has been consistent from the start. So I think certainly people are getting more used to this type of communication and learning and engagement. But we've been seeing this from the start. So again, it's a testament to our facilitators, who are doing a phenomenal job of providing this education in an engaging and interactive way. This is our current online portfolio. So we have LEAP Online, which is really LEAP Core Online, but we want to be clear about it. We have Paramedic, which is delivered online, and we have a few different versions of that. So Paramedic was already a flipped classroom or hybrid model. And that course can be delivered with both an in-person workshop. Also, that workshop can be delivered online. But we also have a fully online version of Leap Paramedic, which is delivered through just self-learning modules and self-learning case studies. That's a pilot we're running with PCIES in British Columbia. And we have close to 500 people running through that pilot now. The early results on that are that it's an excellent experience for them as well. So we're pleased with that. We are just going to pilot with an online version of Leap Long-Term Care. We are running starting this month, actually, a version of Leap In-Depth done online. We're doing that in partnership with McMaster University. And so Leap In-Depth is that continuous learning for people who've taken a leap before, and it does deeper dives into topic areas of palliative care. We have delivered facilitator training online. We haven't done a lot of those during the pandemic, but we have the capability to do it. And we are just finalizing a Leap Lung. So this is as I was speaking about the specialty areas before, this is taking a respirology focused course online. And so we're just finalizing that. Also in development and getting close are Leap Pediatric, which will be a flipped classroom and will have an online capability, as well as a course for community carers or caregivers. And then last but not least is a Leap personal support worker. And so this is one of our learnings about the adaptation for online. Palliative care education for us has always been interprofessional. And we believe strongly in interprofessional education. We see the benefits, we hear the feedback from our facilitators and our learners all the time. When we go online though, it changes the dynamic a little bit. So now we have people taking self-learning modules online, and without the facilitator and the group to contextualize all of that information, it makes it more challenging for people to understand their specific scope of practice. So Leap Personal Support Worker is taking our self-learning online modules and adapting them to be more specific to the PSW scope of practice. We continue to create a pathway for PSWs to come in and take a facilitated webinar session to complete their full certificate and get and participate in that interprofessional learning environment, that interprofessional learning workshop. But the information that they're introduced to online up front is scoped more to their scope of practice, so that we avoid confusion and the challenges that can come with that. So it's part of the dynamic as we've gone online, that we've seen the need to be more profession specific in terms of how some of that information is provided. It's also changed our delivery model fairly fundamentally. So historically, pretty much the only way to access a LEAP course was if a partner organization, hospital, a LIN, et cetera, ran a course, partnered with us and put a course on for staff or people within the community that they work in. With the transition to LEAP Online, it's afforded us the opportunity to run courses ourselves. It's something we call direct delivery. And this is where Pallium just organizes a course, puts it up online, and makes it available to people. This has been incredibly successful for us. It was something we tried with in-person courses, and it was challenging because the major cost barriers and logistic barriers to setting it up, renting a hotel room, conference room is an expensive endeavor to be able to run, a single course. So with the transition to online, we're able to organize these courses, and it's allowed us to then make it, readily available for people to take this course whenever they want. So there's basically a LEAP course now running once a week without any questions. It provides a heck of a lot of flexibility for people to take that course. We're able to facilitate access to the 940 facilitators that are working for Pallium, or working with Pallium, I should say. We offer free training for the facilitators to orient people online, so it's not something we've charged for. We've just sponsored that training. We offer specific Zoom training on how to set up and run the session. So technology is one of the major fear points of our facilitators for sure, as well as our coordinators and partners. And so our support team has become pretty adept at setting that up and training people. We also have live Pallium staff who are there to support the launch of those webinars. So they're there to help make sure things get set up and running. And then they're there on a 911 basis if something goes wrong or something goes awry. So they're working evenings and weekends along with people across the country to make these courses happen. I showed you some of the data and stats, and all of that's available to partner organizations, helping to understand the impact that your training is having, as well as promotional content and material, et cetera, to make that happen. And I think this is a key point for us now. We have the capability to do as much or as little as you need us to do in delivering a course. So if you want to say, Pallium, you just do it all, you set up the course, organize it, find me facilitators, and give me some dates. All you have to do is get 20 or 25 people to show up for the course, and we can do that. Or we can turn it over to you and say, here's the content, here's the access to the facilitators. Go nuts, set it up at your own time and your own schedule, and we're here to answer questions if you need help. But we can work with partners in different ways to help make this run, and that's part of the flexibility that we've figured out is so important over the course of the pandemic. So that's Leap Online. We're really excited about it. It's working well, and we hope many of you or your team have an opportunity to take advantage of that. I also want to talk about some of the other things that have come out of this past year, and this has been part of our COVID response. So early in the pandemic, we realized that certainly we weren't going to be running any LEAP courses for the next little while. And so we figured, okay, what does the healthcare community in Canada need, and what can we do to support that? And so this is one of the things that we did. So we launched and made available the online palliative care module. So this is a subset of the modules that people get or take when they're doing a LEAP online. We made those available in late March, so March 31st, 2020. And in the course of just a few months, we had 11,000 learners across Canada and quite frankly around the world take advantage of those modules and engage and take training. And I think this just speaks to the demand for palliative care training capacity. To put this into context, 11,000 learners in 3 months is 3 to 4 times what we would typically see even at our busiest time. So it was quite a response from the community. We also, with partners, were able to launch a series of webinars, both in English and French. We've now done over 23 of these webinars. They've evolved over time, so they're focused on topics that are relevant to healthcare teams who were leading the response. Early on, it was about PPE use. As the pandemic progressed, we got into psychological impacts. We did one recently in French about virtual delivery of palliative care. So we've continued to evolve the topics as the pandemic has evolved, and we continue to deliver these. So more will be coming. These are free for people to participate in. And again, we've seen an incredible response with over 6,100 people attending the webinars. We've had two times that and a bit better in terms of people registering, and then over 23,000, and it's actually higher than that now, YouTube views of the recorded webinars. So those are all available for free on our website and continue to be. And we've also launched in partnership with the CSPCP, the Canadian Palliative Care Exchange. So this is an interactive platform to allow people to have asynchronous conversations online about topics related to COVID-19 and palliative care. There are over 700 members. It's an interprofessional platform. It's not just for physicians. It is secure, so we've secured it so that people can have difficult conversations if they need to in there. We're obviously not sharing patient information or anything inappropriate, but we've closed it off so that it's not just Google searchable on the internet, so that we have a bit of privacy there. And we have over 30 active discussions that are happening on different topics around palliative care during the pandemic. And these are, this really speaks to some of the key learnings that have come out of our work, both with online and from our COVID response. So I've said it before, there really is just a continuing and growing demand for palliative care education in this country. We're seeing it firsthand. The way that learners access education is changing. It has changed, and we certainly expect that face-to-face education will come back. It remains relevant. We've heard from a number of partners that these are the value that they see in face-to-face education, and this is, for facilitators, this is why they're comfortable facilitating this way. We've actually had face-to-face courses delivered during the pandemic, but it has changed, and so online is going to continue to play a much bigger role in how education is provided and accessed, and we don't see that stopping. So our vision for the future is to have all of the variants of our courses available for some version of both online and face-to-face education, so that people have the choice in terms of how they want to deliver that and how they want to access that. We also have seen, because of the advent of online, really new opportunities for national knowledge sharing. So that's happened through our webinars. One of the most successful ones that we've had, and there's actually a recent research publication that's come out of it, was on managing medication shortages during the pandemic. And so this was a panel discussion that we had with our via webinar with healthcare providers and pharmacists from across the country, who were talking about what they were experiencing in terms of shortages, how they were managing, what alternatives they were using. And we've heard anecdotes of how that was then, the next day taken in and used in a discussion internally about how to problem solve an issue. So that type of national knowledge sharing, capturing that tacit knowledge is so powerful. And we see that happening continue through webinars, but also through, bringing national cohorts together in LEAP Online, and having those discussions in the facilitated webinars. We don't want to lose that ability, though, to stay local and regional when it's desired. And so I showed you that map earlier of, almost 2,000 sessions across the country. We know that local adaptation of the course is so critical for so many communities. And so we can run a national LEAP online, and we can run a local LEAP online, or we can run a local LEAP face-to-face. It's whatever meets that specific learning need. The frequency and flexibility is a key one for us. So having a course available every week provides people a lot of options. And so if you plan to attend a LEAP session on January 15th and something comes up because you're in clinic that day, you can move to next week or the week after, and it's not a problem. And so we provide that flexibility. It's also opened the door for different sectors or segments of the palliative care space who've struggled to access training in the past. So home care, long-term care, places that are resource strapped and had challenges in getting 15 or 20 people off the floor for 2 days to take a LEAP course, are now able to put 2 people in this week and 2 people in next week and 2 people in the week after that. And so that flexibility has been has really actually done things that we didn't expect it to do when we first got started. So that's been really wonderful to see. And the last piece for us, the key learning here is just the importance and the power of partnerships. So none of what I've described so far has happened in just by Pallium and in isolation. Our webinars have been supported by a number of different partners. So Boehringer Ingelheim has supported our webinar series, as has Health Canada, as has Caisse de Dépôt in Quebec. And we've also, in delivering those webinars, worked with CSPCP to help bring together best speakers, and we've worked with PCIES and Société de Santé en Domicile in Quebec as well. We have an exciting new partnership with Li Ka-shing Foundation, who's helping to support the rollout and delivery of LEAP Online. And we have ongoing partnerships with community partners, BC Centre for Palliative Care, Hospice Palliative Care Ontario, who are helping us with some initiatives I'll talk about in a moment. And this is just a snapshot of a few of our key partners, and I'd be remiss if I didn't recognize the 100+ of palliative care delivery partners who we work with across the country, who are the ones that are helping make all these courses and trainings happen. I do want to share with you and everyone at this conference a unique opportunity. So through our partnership with the Li Ka-shing Canada Foundation, we're able to offer a 50% reduction in the price of registration for any LEAP online course. So there's a discount code there, 50 off, and then PCN, and you can log in and sign up for any course or any session, or share this with your network for people who you want to sign up or want to take a LEAP training. And when you go through to payment, you'll get a 50% off the price for that session. So this is the power of partnerships and things that, as a small social enterprise, we're not able to do by ourselves and without the support of others. So that's LEAP. That's our LEAP training. I want to switch gears now. I want to talk about the work that we're doing in the community. And this, as I mentioned before, in our sort of theory of change, is about creating that wraparound effect for the patient and the families to make sure that they're getting the support that they need, whether it's in the healthcare system or within their community. And we know that communities can do a lot to support people where they live, where they work, where they're going to school, etc., through whether it's caregiving, whether you're supporting them through a grief experience, or someone who's dealing with serious illness themselves. And what we've done, recognizing the complexity of a community, is take a bit of a complex approach. So we have a variety of different resources that we're developing or have developed. And the goal is to reach people where they are. So we started with our startup toolkit. And so this is a really turnkey resource that someone who wants to start, excuse me, a compassionate community can take and run with, and just gets them started fast in terms of setting up a workshop, a community engagement focus group. It gives them the agenda, it gives them the PowerPoint deck, it gives them the outreach letters to talk to mayors and civic leaders, etc. And that's been downloaded over 3,000 times across the country since we launched it almost 2 years ago now. So we've seen strong uptake from that. We've launched a Compassionate Communities Exchange. This is similar to the CPC Exchange that I spoke about earlier, but focused on compassionate communities and just a way for people to access and gather information. We have the Compassionate Workplace Campaign, which I'm going to spend a fair bit of time talking about. And then we have a variety of different toolkits that are very close to completion. So we're working on an evaluation toolkit. That's a project we're doing with BC Centre for Palliative Care and with Hospice Palliative Care Ontario, trying to create a national evaluation toolkit for compassionate communities. We'll be launching soon a sustainability guide. So this is step 2 from the startup toolkit, and really brings together a suite of well-established, proven resources on community capacity development. So how do I set up my organization for long-term success, my compassionate community for long-term success? We're also working on a program about care mapping. So this is community care mapping, helping caregivers and families identify all of the resources and supports that help them provide the care that they provide, and allow them to communicate about that effectively, allow them to identify areas where they need to shore things up and manage risk. What happens if my neighbor gets sick? Who then is my backup plan, etc. So this builds out of off of work out of the US around a group called Atlas of Caring. I've done some excellent work on this, and this is us bringing it to the Canadian context and adapting it, making it available in Canada. And then finally, a faith community toolkit. So this is a partnership we have with the Canadian Conference of Catholic Bishops to develop our first faith community focused toolkit around palliative and end-of-life care. And so this is about educating about what palliative care is. It's also, in some cases, about dispelling myths about around things like MAID and feeding tubes and what isn't assisted death. And then allowing our faith partner, in this case, the Catholic bishops, to bring in an ethical decision framework to support people in their spirituality, etc. So we're excited about this one, and it's going to be available in parishes across the country soon. And I think provides a framework for us to then be able to work with other faith communities as well. So that's the complexity of sort of what we're doing in the community space. And it really is, as I say, about helping us get to people where they are as much as we can. We can't be everywhere, but this is us putting up multiple products in multiple spaces to support people where they need. And key for us, an area where we identified that we thought we could have an impact is in the workplace. And so that's why we've gone into with what we call the Compassionate Workplace campaign. Again, I think I'm speaking to an audience that probably understands this quite well, but we know we have an aging population, and we know that is impacting the workforce. And that because we have that aging population, we expect to see more serious illness, more caregiving burden, and more grief in the workplace over the coming years. We know that when one person dies, 5 people are affected in the workplace. And we know that grief, when not managed and not supported, has major impacts on productivity, on mental health and well-being, and even on decision-making by management in terms of allocation of work. The burden on care providing or caregiving in the workplace is very real. So 35% of the Canadian workforce is providing some form of unpaid and informal care. And this is not childcare. This is dealing or supporting someone who has a serious illness. We know the majority of those caregivers are 45 years or older. And because of that, many of them are our managers and our leaders and the experienced employees that we rely upon. So the impact of losing them or losing their productivity is actually amplified in the workplace. And so the net of this is that the Canadian economy is losing over $1 billion a year due to the burden of caregiving, and is losing the equivalent of over 500,000 full-time employees due to that conflict and conflicting demands. So as I was talking about before, but 85% of managers report that when an employee is grieving, it affects their decision-making on the work that they assign to that employee. Do I bring this person in on an important project? Do I trust them to ride the forklift that day? Those types of things are happening in real time with people who are grieving and struggling. And so the goal of our campaign is really to drive a culture change and to create a more compassionate workplace environment where those Canadians who are dealing with these issues are able to receive the support that they need. Importantly for us, it's internal to the organization. It is about the internal organizational culture. There are a lot of programs that exist and supports that exist in the workplace, such as employee assistance programs, these types of things, which are excellent and can connect people to professional supports where they need them. But that happens outside the workplace, and it doesn't make it easier to come back. And it doesn't make it easier to show up to work each day all the time because you're separating the two. So this is about bringing this inside the workplace and building a culture of awareness and understanding of these experiences that they're happening, decreasing the stigma associated with it, raising awareness of the resources and supports. So, including things like an EAP program. And really, and this is key for us, prompting and enabling these supportive conversations. So, how do I create a culture where an employee or a colleague is comfortable approaching someone who's just lost a loved one and asking how they're doing and having a conversation with them, whereas currently today too many people just avoid that conversation. we've done the research, or we've scanned the research, I should say, and we know that more compassionate culture is good for morale, retention, reduced absenteeism, basically all the things that we want to see in a workplace. This will improve a lot of those metrics around culture. We've designed the campaign around three sort of types of tools or resources. So the first is around communication materials. The second is about activities, and these are really where the stigma reducing pieces come in. And the last piece is around tools. So how do we facilitate and support employees, but also the organization themselves with setting effective programs and policies in place to support people dealing with serious illness and grief. This is a visual of our pre-pandemic version of the campaign. I will let you know that we launched this at absolutely the worst time you could possibly launch a new product for the workplace. So this was going to pilot in mid-March of 2020. We managed to complete a couple of our pilots, but it's been a challenging time to gain traction. I think in our conversations with employers and workplaces so far, a ton of interest. Everyone gets it. They understand what the need is, but the real world capacity for an organization to implement a new wellness campaign of any type right now is pretty limited, as many organizations are just trying to figure out, how do I open my office doors safely? So that has been a challenge, but we're persistent. We'll stick with this. So we believe strongly in the need for this, and we will be sticking with it. We have done some adaptation to move a lot of this online so that we can support both currently and into the future, a portion of workers and employees that we know will stay virtual and stay remote. So that has forced adaptations on this product as it did for our LEAP courses as well. This is just a sense of what the tools themselves look like. So the communication resources include a variety of things, social media posts, PowerPoints, email templates, etc. The stories, and this is one of them here, are really sort of the heart of the campaign. And so these are short 200-word stories that can be blasted out or sent in a quick email, just to contextualize the experience and make it real. And these are based on real-world scenarios, real-world type experiences. They cover a variety of different sort of subject matters. So some of them could be about someone who's grieving. Some of them are about someone who has caregiving responsibilities. We have some that are contrasting the manager experience versus the employee experience on the same issue. And we have a couple of new ones that we've brought in around COVID and those types of sensitivities, because again, it's a little bit different. And these can be used as a conversation starter within a team. So you can go to a team meeting, read and review the conversation, the story, and then have a conversation about what would we do? How would we respond as a team? How do we want to respond as a team? There's a discussion guide for whoever's facilitating that discussion. There's some tips on what's an appropriate response. And then there's an opportunity to include resources. And so we've got some resources within the campaign or external that we reference to, but an organization also has the ability to insert reference to their own wellness programs and those types of things that are there. We have activities. So this one is a simple knowledge quiz that we use, and it's got the correct answer for whatever the question is to help with an education basis. And this is obviously fully available online. It's a great way to kick off a campaign. We also have a variety of different activities, a couple of which are sort of poster based. And so if I jump back, the poster in the back there, My Care Experience, the concept there is, either virtually or in person, you put this poster up and you have some small Post-it notes, customized Post-it notes where someone can write down, I was a caregiver for my mom. My sister was a caregiver for me, whatever that is, and be able to put that up on the board. And you can envision the power of this when you've got a 200-person organization, you've got 75 or 80 sticky notes on a board talking about the fact that half the organization is or has been caregiving. And we have a similar one around grief and loss. And then we have a you'll see down in the bottom left-hand corner a black ribbon campaign. And so this is a simple way to acknowledge that someone is grieving a loss or grieving an anniversary of a loss, etc. So campaigns around like that to destigmatize and sort of normalize those experiences. And then a variety of tools. And so this is one of the most popular tools that we've seen. It's simply safe things to say. What do I say when that person is caregiving or they come back after a loss? How do I start that conversation with them? And so this is a really popular one, but we also have more sophisticated ones in here, including a guideline for an organization on dealing with an employee death. What are the high-level steps that an organization needs to take in order to deal with that appropriately? And that can be, that's designed to be flexible and allow any organization to make use of it and integrate it into their existing policies. So we're not prescriptive in terms of thou shalt have this in place. It's really saying you need to figure out what your communication strategy is. And here are the parameters you need to think about when you think about who needs to be communicated to and about what and when. And here's where you may need to get some external support before you put that communication in place. Similarly, we have a planning guide for employee work modification. And we're not talking about legal duty to accommodate here. We're talking about, you know, how do I, if someone is grieving or has caregiving burden, how do I sit down with my manager and figure out an appropriate accommodation strategy? That can include and will include things like, how much of your story can I share with the team? And actually, let's craft that message together, because people are going to have questions and I as the manager need to know what I can share. Or do you want to stay in contact while you're off? And how are we going to facilitate that communication while you're away? So very practical things that are too often missed in these conversations. Certainly in my experience as a people manager, I can think about examples where I could have had those conversations and done them better. So I'll finish off here just a little bit of a nod to COVID-19. So we acknowledge that COVID-19 has obviously drastically changed the workplace. It's also changed grief in the workplace. People are grieving not just the loss of life that we've seen in the pandemic and regular loss of life occurring during the pandemic, but also the grief of things like the lifestyle that we once knew and the inability for people to grieve in the same way. And all of those complex things that we hadn't thought about before, but suddenly we were faced with head on. And so we've adapted our approach for this Compassionate Workplace campaign to include new stories that raise awareness around some of these complex issues about COVID-19 and grief and loss. We've also brought in some new videos, basically a small webinar series recorded webinar series on grief and grief in the workplace. And then we've adapted some of our resources to include tips on how to support people virtually when we can't be face-to-face and having those types of conversations. So, and so that's us. I mean, that's our new normal in terms of the workplace. We know what we saw in the pandemic is really a spotlight for the workplace in terms of grief and loss for what we're expecting to see over the coming 15 years as that Canadian population ages. And so for us, we believe that the Compassionate Workplace campaign is essential, and we believe it's something we really need to be getting into place sooner rather than later. If we wait until this is a crisis again to address it, it's going to be too late for many workplaces and employees in Canada. So thank you very much. This is us. If you want to reach out and connect after this conversation, and happy to open the floor for any questions.
You guys don't be shy. Jonathan and Alana here and have your questions right now.
Jonathan, there was a question in the chat about whether or not we'll be adding the remainder of our suite of courses to an online format. Maybe you can speak a little bit to that.
Yes, so the short answer is yes, we will be. The complex answer is just timeline to have that happen. We have a number of courses that you saw on the slides there that are currently in development. We hope to have most of those completed early this spring, and then next year is going to be our big time to complete the transition of a lot of those courses. So I think what's been fascinating for us is with the transition to online, we're not creating new content, so it's a little bit faster for us than it's been in the past in terms of creating new versions. But that's absolutely the goal, is we want to have every version of our LEAP courses available for different models of delivery, whether that's fully online, fully face-to-face, or hybrid flipped classroom models. That's the goal, and we're working towards it.
Perfect. And can you also maybe go back to the slide with the discount code? We've had some questions about resharing that, so that might be helpful.
Absolutely, and we'll make sure Monica has this to send around in the post-conference as well.
There's a question in the chat right now. As a community care worker, am I able to register for any of the LEAP courses offered, or are they only available to those they are specifically designed for?
So our recommendation is to take the course that best suits your learning needs. So LEAP Online, or LEAP Core Online, is designed predominantly for people working in the community. So it meets the learning needs of the vast majority of healthcare providers. But one of the courses that we are developing, and it actually wasn't up on the slides today, I apologize, is a specific home care version of LEAP Online. And the difference there is simply going to be adjusting the case studies slightly to recognize that, you know, a home care provider or a home care worker may not be going back to a clinic, or they may be going back to their car. And so, you know, they may not be working in a team environment, they may be working fairly independently. So that's the adaptation that we're making there, and we're working with some home care experts on that tweak to the course.
We have a question from a facilitator, and says, as a facilitator, I wonder if and how I'm may be able to help out with the online delivery if there's a need outside of my local area.
So absolutely. So one of the things that our facilitator engagement lead, Stephanie Ferris, does is she manages interest in teaching courses. So she sends out a blast to anyone who's trained to teach LEAP Online and looks for availability for upcoming sessions. And if you specifically want to put your hand up, contact Stephanie directly, and she'll definitely help you get in. Thanks for the support.
For the Compassionate Workplace Toolkit, love the idea. How do we link different workplaces to access the toolkit? So
you can contact our support desk, or contact us directly, and happy to have a conversation with any workplace about how what the need is and how to make it fit. There is a cost associated with the Compassionate Workplace campaign. That's our social enterprise model, so we're trying to make this sustainable, but it's not prohibitive. It's basically the price of a cup of coffee per employee per year. So we think that's a pretty solid investment in culture.
We have a question. What is the Li Ka-shing Foundation?
So Li Ka-shing Foundation is a private philanthropic foundation. It's actually based out of Hong Kong. It does have a Canadian arm. That's the group that's funding us. It's actually the second largest private foundation in the world, behind the Bill and Melinda Gates Foundation. And they have done historically a lot of work in hospice palliative care. So they fund a large number of hospice organizations in Hong Kong and an area there. And they've done a lot of work with universities and such in Canada here, including University of Alberta and University of Ottawa. And we're incredibly proud that they chose us in terms of partnering here in Canada around palliative care education. So,
How can we arrange to do a course for volunteers?
So we're happy to connect, and Alana can help you with that if you're looking to do one of our existing LEAP products. We're also doing a LEAP caregivers course. This is more focused on family caregivers, so I'm not sure if that's the type of volunteer work that you're doing, and we're building that program in partnership actually with the Champlain Palliative Care Network here out of Ottawa. They have a fantastic course that they've developed for caregivers, and we are working with them to adapt that to make it available online and make it available nationally across the country. So we're excited about that initiative as well, but I'm not sure if that's the fit that the person's looking for, but you know, a LEAP course for the people working in a hospice volunteer, for example, might be the right fit.
Have LEAP courses been offered in the North Bay region? And if so, which ones?
So absolutely they have. I'd have to check our data to see which ones, but certainly some LEAP cores and LEAP minis would have. And we have some wonderful delivery partners across Northern Ontario, including some who've done excellent work adapting the delivery for work within Indigenous communities as well, bringing in their own expertise to strengthen the training that much more.
And the Near North Palliative Care Network has been one of those partners. So thank you very much, Monica and team. And that seems to be it for the questions that have, oh, what city province are you based out of? So we are based out of Ottawa, Ontario.
Yeah, but we have a team that's across the country. So about half of our team is full-time virtual out of Toronto or Toronto surrounding. And we have one of our new hires during the pandemic actually was a West Coast account manager out in BC. So we're growing, truly national now.
And that seems to be all of the questions, unless anyone would like to ask anything else. And then you're always free to reach out to either Jonathan or myself for any additional information or specific course information, including learning objectives, that type of thing. And we're happy to address those with you. Great.
Thank you. Thank you again, Monica. Thank you, everyone. Enjoy your day. It looks like an exciting agenda, and have a wonderful day. And Monica, I give you the conference manager's dream of 8 extra minutes.
Yes, thank you so very much, Jonathan. As I teased you on the phone, you are a pro. Thank you very much, Alana and Jonathan, for the fabulous presentation. And we hope to see you back again in many other times for new workshops for our agencies here. Wishing you a wonderful Friday. And now we are going into interval. Grab your coffees, everybody. And we will be back at 10:30 with Dr. Gina and Tara Moffat for a special workshop on pain and symptom control for liver cancer. Wonderful. Once again, thank you, Jonathan Faulkner, Alana Corkery from Pallium, Canada.
Thanks so much, Monica. Take care.
So everybody, we will have an interval now. We will be playing the message from and the message from the chair of the board on video during this time. If you would like to leave your comments on the chat, or if you need IT assistance, please contact us in the meantime while we organize to have Dr. Gina and Tara Moffat with us at 10:30. Thank you very much. See you then.
Hello, Ani, bonjour, bonjour. This is Anthony Rhoda, Member of Parliament for Nipissing-Temiskaming and Speaker of the House of Commons. I want to take this opportunity to thank you for including me in this training and this time where palliative care workers are coming together to share everything they've learned. And one of the things that I find very interesting about this meeting today is that you're sharing best practices, and that's something that's very important. Aujourd'hui, spécialement avec la pandémie, c'est très important qu'on apprend un de l'autre et on continue à grandir ce qu'on connaît. So to all of you, I want to thank you for taking the time to take this training and discuss and learn from each other and get the best practices out there so that our people dying and in palliative care have the best care possible. And that's something that takes dedication and it takes a certain skill set that I admire very much in all of you. So to all of you, on behalf of Parliament of Canada, thank you for being here today and taking these courses and sharing with each other the best practices.
Welcome, everyone. My name is Mônica do Couto Moni, and I am the chair of the Palliative Care Interdisciplinary Education Services Nipissing Subregion, organizer of this winter conference. I want to give sincere thanks for the words of support and encouragement we received from Anthony Rota, Speaker of the House of Commons and Member of Parliament, Nipissing-Temiskaming. From Brian Titer, Regional Lead of Ontario Health North and CEO of Northwestern and Northeastern Links. From Darren Renault, Chair of the Board of Near North Palliative Care Network, responsible for the management of the conference funding. For the media with us today, and for the massive support and attendance to this year's conference by our member agencies and countless non-member agencies across Ontario. Wow. It's a great pleasure and honor to have you with us today and to see hundreds of faces of each of you, brave palliative care professionals. I also want to extend our welcome and thanks to our conference presenters, Jonathan Faulkner, Vice President of Operations, and Alana Corkery, Account Manager of Pallium Canada, Dr. Inês Fátima Dina, Medical Doctor specialized in palliative care, and Tara Moffat, Palliative Pain and Symptom Management Consulting for our region. Eugene Dufour, Master of Divinity of King's College at the University of Western Ontario, who will talk a little bit about bereavement and grief for healthcare professionals in pandemic times. Our member agency colleagues and my staff and placement students at Near North Palliative Care Network who helped organize this event for you. This year, we gather to think about best practices in the continuum of palliative care. A continuum is made of people united in harmony. The best practice and the transformative power in this continuum is you. You will hear a lot today about being mutually considerate, supportive, and compassionate with your superiors, peers, staff, and patients. About being gentle, understanding, and patient with yourself, especially during hard times. About building together the best workplace environment one can get with our personal attitude. Palliative care is evolving fast, and you have the power to make it better in every action you take. Today, I want to share a message of trust in you and hope in our common future. Never doubt the power of the small, the power of a million acts of kindness repeated daily by all of us in the grassroots. This creates a culture. You work in palliative care because you are kind and you want to help. So, bring your kindness daily to work. Let it shine before your superiors, peers, staff, and patients, and see smiles of gratitude and respect multiply around you. Never forget who you are. You desired to help people when you started your beautiful journey in palliative care. Well, you and your colleagues are people too, and deserving of one another's support. Let us not allow rivalries, cynicism, mistrust, judgment, and exhaustion take the best from us. Let us never act below ourselves and always take the high road of compassion and solidarity at every moment. Together, we can and will build best practices in the healthcare system. A continuum of kindness and mutual consideration is at the heart of system change. You matter, and you make a world of difference to those around you. One small act of kindness and one small smile at a time. Thank you, and hope you enjoy our day together at the 2021 Palliative Care Interdisciplinary Education Services Winter Conference. Enjoy it. Just to let you know that Dr. Gina and Tara Moffat are already here, and we will start in 4 minutes the presentation of Dr. Gina and I will with you guys now the program. There you are. Dr. Gina and Tara will be talking about interdisciplinary palliative care, case-based learnings and evidence-based practice, pain management in end-stage liver disease, of cross-sector teams in complex pain and symptom management. So in 3 minutes, Dr. Gina and Tara will be with you. Thank you. Okay, everyone, we are starting the seminar again, and with you, Dr. Gina and Tara Moffat with their presentation. Enjoy it. So if you would like to now.
Oh, sure. Right,
We'll get
front row and
closer. There
center.
we go.
Yeah, look at
Yeah.
this.
Oh, wow.
Don't tell Mr. Ford.
No.
Yeah. Good
We
morning.
got our masks on.
It's true. Good morning, everybody, and thanks for having us. We'll do some brief introductions, but first and foremost, just want to thank the PCIEF. Did I do the proper acronym? Okay. for asking Dr. Jenna and I to be here today, and in addition, sort of put something together and share our most recent experiences in working together and in cross-sector support. And so grateful for that opportunity. I don't know if you want to add to that or not.
No, just happy to be here and appreciate everybody on this snowy day joining in. Hopefully we give you a message that that we communicate well and that applies to all the work that we do in our community and in other communities as well. And thank you to Monica. I wish you guys could see where we are. It's just lovely.
Oh yeah, we're just like we're in treat like royalty right now. So this is really nice.
Yes.
The other thing that Dr. Jen and I both sort of thrive on is sort of interactive discussion, and super happy to have questions and comments and constructive feedback, because that's all part of the big learning process and moving things forward. We're just going to kindly ask that maybe you put your questions in the chat box, or maybe wait to the end of the presentation and just hold your thoughts, simply because with this many people on sort of an interactive session, it can get kind of troublesome sometimes trying to have some good communication. And I think we have somebody from the Near North Palliative Care Network sort of monitoring our chat box as well as some questions. So thanks to the team for doing that. And I think we'll get started. So excuse us while we're sort of familiarizing ourselves as well with Monica's computer. Hey guys, we muted ourselves there.
No, Dr. Gina muted us. She's technically challenged.
Okay, I'm gonna, oh, I can't use that.
There,
So change slides?
like
Yeah.
this. Slide
And then I can click.
just here.
Okay, thank you.
All right.
Okay, so this is really just the title of our presentation, which many of you would have seen in the program anyways. Lucky for us, we had sort of started thinking about this presentation in terms of bringing sort of an end-stage liver disease case forward, and that was because it had a lot to do with interdisciplinary teams and the importance of communication. But subsequently, since then, we've also thought about some additional cases that we thought would be value added in terms of bringing to the table. And so you're going to see that we are going to be talking about pain management in terms of complex pain and end-stage liver disease, but in addition, the importance of cross-sector palliative care teams and how sort of communication and collaboration are at the sort of the center point of that. And then more importantly, that the patient and the family are at the center of that. So anyways, we'll get started. We have no really disclosures that we need to be talking about. Certainly myself and Dr. Jeanette, no. Relationship with commercial interests, don't even have time for that. So we'll just keep going. As not applicable to myself or Dr. Jeanette, but certainly important, I guess, at each of these presentations to disclose. Some objectives that we thought we would come out of this presentation is to understand the relationship between the necessity between multidisciplinary care and palliative care, and how those two are really sort of interrelated. And then understand the importance of multidisciplinary palliative care in the attainment of patient-centered outcomes for patients, particularly in complex pain management. And this is not isolated to these types of cases, but certainly we're going to use some of these cases as an example. End-stage liver disease, ALS. And ultimately, the biggest thing that we wanted to sort of accomplish, and Dr. Jen already alluded to this a little bit, was talking about interdisciplinary communication and collaboration. But really that all comes down to a comfort in asking for help. And that's not for people who are new to this kind of business, whether it be healthcare or palliative care, but really for even people who have been working in this kind of work for many years. There needs to be a humility in asking for help, even when you have extensive experience. So hoping that that's one of our outcomes for us today, as well as many of you. That's Dr. Jenna is going to just talk about multidisciplinary team care.
Right. So we chose the three cases that we chose because those situations tend to highlight the fact that we do need interdisciplinary care. However, almost every case that we all deal with does require some elements of that interdisciplinary care. So I just made this slide. It actually uses the WHO definition of palliative care. And if you remember aspects of that definition, some of the core values are to relieve pain and suffering and other symptoms, to affirm life and to look at death and dying as a normal process. We elect not to hasten or postpone death, but we are aware that that is the end of most of our situations. The important things here that I chose for out of that definition for our particular talk are that the care in palliative care integrates physical, psychological, and spiritual aspects. They're all very important. And I know that our speaker this afternoon is going to deal with those 4 rooms. Our care offers a support system to patients to help them live actively. So our goal is to provide the patient with symptom management as well as all the other frameworks surrounding them to allow them to live their lives to the fullest. It offers a support system to the family, very important as well, to allow them to cope during illness and with bereavement. So during the illness, we're providing information, education, assessing their needs and providing support. And then with bereavement and during their illness, we're using, for example, their near-death palliative care network to provide the support that the family needs in that situation. The 2 things that I find really important in that WHO definition are the fact that they advise that we use a team approach to address the needs that are identified for the patient. So this is not one person trying to do everything, because that's impossible. That's not what we're here for. We are here to help communicate, collaborate with one another, and that's going to be the theme of our talk throughout this whole conversation that Tara and I are going to have with you, that we really need to make sure that we are using a team approach, that we leave our egos and any sort of politics aside, and the patient becomes the source of where we choose what we're going to do. Finally, the goal in palliative care is to enhance quality of life. And that includes all aspects of life, whether that is the fact that you eat or don't eat, the fact that you're able to go out and ride your bike, or the fact that you're able to go and visit your grandmother, whatever that is that makes your quality of life important and what enhances your quality of life, that's what we're trying to do. Okay, good, yeah.
Hi, Dr. Jenna. Sorry, just a request if you can just speak a little slower. That would be great. Thank you.
Okay, Michaela, I'm going to try, but you know, my brain and my... I will definitely try to do that. All right.
Okay, I gotta find, I'm just working with this fancy mouse, guys. Okay, so when Dr. Jen and I were sort of pulling this presentation together, we had met a few times and talked about how do we sort of want to identify what multidisciplinary, good, not even good palliative care, but excellent palliative care, right? Because we can give good palliative care, but really what we want is excellent palliative care for everybody. And that's going to look a little bit different for everyone, right? And that's going to also depend on what the patient and family identify is great palliative care for them. So one of the things we thought about was actually a bicycle wheel, and in terms of those spokes going into the bicycle wheel, and what are the important pieces that kind of wraps care around that particular individual and family. And while one of these things may be more important than the other, depending on what the patient identifies, we want to really focus on the piece around access. And so when we talk about, you know, leaving our egos at the front door and we look at this wheel, I challenge you all to sort of think about this wheel as we move through each of the cases and through the conversation today. And we will come back to this wheel in a little bit as well, talking about, you know, palliative care expertise and what are secondary level providers, talking about the importance of family, talking about nursing, and in the context of where the patient is and maybe where they want to be, whether that be home, hospice, or hospital, because certainly there are people who choose or would like to die in the hospital. When we talk about the rehab team, we're talking about OT, PT, SLP, and respiratory therapy. We're talking about primary care providers, whether it be your family doctor, the nurse practitioner, or, you know, the palliative care physician could be the most responsible provider as well. When we're talking about our LIN colleagues or our Ontario Health team, however we want to identify that right now in the new political context, and all those resources that are associated with the LIN. We're talking about spiritual care. We're not just simply talking about any sort of religious affiliations, but we're talking about sort of those big pictures about what gives people meaning in life and how they identify themselves with self-efficacy, etc. So really sort of think about those things when we're talking about the cases. We're going to talk a little bit about the background of the cases to start. Then we're going to talk a little bit more about interdisciplinary palliative care, end-stage liver disease, ALS, as well as complex pain. And then we're going to come back to those cases and how it sort of fits into this spokes of care. Anything you want to add to that?
No, we specifically, if you feel that there's anything else that needs to be added in that we haven't put in, for sure, we'd like you to let us know. Please put it into the chat and we'll discuss it after. The issue for us that I just wanted you to notice was the fact that the spokes go both ways. So that interaction is really important, and that the patient is at the center.
Okay. Where's my little fancy mouse? There it is. Okay. So for those of you who don't have the benefit of sort of seeing our presentation, maybe you're just sort of dialing in, I'm going to take an opportunity just to read the case one. And we tried to make this as sort of anonymous as possible, recognizing that I'm going to kindly request that although the North is so large, it's a really, really big geographical area, it is a small community in terms of people knowing other people. So I'm going to kindly request that if you recognize some of this case, or if it resonates with you a little bit, make sure that we're maintaining our confidentiality with the personal health information as much as possible. Okay, so case one, Jane was a 60-year-old female diagnosed with stage 4 lung cancer with mets to the abdomen. Was complaining of worsening pain in her back and abdomen, declined any sort of palliative chemo and radiation. Oh no, she actually had some multiple radiation, I apologize, for pain and symptom management. So to give you a little bit of background, we added in a piece here around sort of what her sort of course was. About 1 month post-diagnosis, she had admission to the cancer center for a gross amount of hemoptysis. So essentially like bloody sputum, coughing up lots and lots of blood, resulting in a cauterization of her vessels in the lung, and then an additional 5 fractions or 5 treatments of radiation to her lung and abdomen for symptom management. About 2 months after that, she was admitted to the North Bay Regional Health Center for a pain crisis, and then shipped to the cancer center, so at HSM, for 1 really high dose of radiation treatment for pain and symptom management as well. 1 month later after that, she was admitted to the hospital for post-radiation pneumonia. She was started on some antibiotics and prednisone, and then was sent home. Maybe some other past medical history that you might find relevant is that she has a history of hepatitis C. She had a hysterectomy, post-ectopic pregnancy, a small bowel resection, and a non-determinate autoimmune disorder. There we go. Okay, so when the team met with Jane, usually, generally speaking, we complete an ESAS, or an Edmonton Symptom Assessment Scale, rating her symptoms from anywhere from 0 to 10, 0 being none at all, and 10 being the most severe. So you can see there on the ESAS that it's quite an interesting ESAS to look at. So pain was anywhere from 7 to 10 in her abdomen, and a 10 and a 10 in the right shoulder and upper back. Her fatigue was 10 out of 10. Nausea was 0 out of 10. Depression, anxiety, and well-being were all rated a 10 out of 10. Drowsiness, she was unable to rate, but from the clinician's perspective, was significantly drowsy during visit, and still administering a benzo, so meaning like lorazepam, for anxiety related to escalating pain. So she had this sort of ongoing fear that her pain was going to get worse. So she was sort of preemptively treating her anxiety with an anxiety medication. Shortness of breath was 0 out of 10 at rest and 3 to 4 out of 10 on exertion, which was really interesting when you sort of first met this lady, because sort of looking at her, you would sort of think to yourself, wow, she looks really, really short of breath. But for her, 0 out of 10 at rest was reasonable, and 3 to 4 out of 10 on exertion. Bowels were 0 to 10 at that time. However, she had significant increase in pain with having a bowel movement and constipated stools. So she was required to keep her bowels soft to loose. Really important in terms of initial palliative care assessment from certainly our palliative care team perspective is to sort of understand what current services are either in the home or available to the client, and kind of why as well, why those certain services. So at that time, she was having some daily nursing. She had a care coordinator, thank goodness, because I believe firmly that everybody should have a care coordinator. MRP was the family physician. I can't see everything on here that you guys have there. Oh, hold on 1 second. I'm just going to grab my notes here. Oh, yes. And radiation oncology. She lives with a really supportive husband. who certainly was very forthcoming in that he would do everything possible to try to maintain this lady at home. She had a few animals, cats, and I think she also had a dog actually at the time, who were essentially her children. And she identified it as very, very spiritual. Okay, so that's kind of our case one there. Did you want to add anything to that one?
No,
No, you're
that
good?
was- yeah.
Okay.
Mhm.
Where's my notes here? Okay. Case 2 was John. So John was a very interesting case personally for myself, personally and professionally. So 65-year-old guy diagnosed with a high-grade transitional cell carcinoma. I had a partial bladder resection, a prostatectomy, and was on BCG therapy. 6 months after his diagnosis, he ended up in the emergency department complaining of significant abdominal pain. He had swelling, he had fatigue, he was weak, and he was diagnosed at that time with hepatitis. 6 months later after that, he called his family doctor and he was complaining about vomiting, so persistent vomiting, persistent diarrhea, increasing abdominal swelling, swelling of his legs. However, at that time, despite the advice of his family doctor, he declined having some routine blood work as well as some imaging to sort of undergo some investigations at that time. 2 months after first reaching out to his family doctor, he started having increased weight loss. He had some more swelling. His abdomen was getting even bigger. The nausea and the vomiting was persisting and actually getting worse, and as well as the fatigue. He declined to go to the emergency department. And again, that was on the advice of his family doctor because he had called the clinic to share his concerns. And despite the advice of the family doc, he didn't want to go to the emergency department for investigations. However, he was agreeable to have some blood work, and that showed that he was having increased liver function tests. 1 month later, after that, he had, again, some more abdominal pain. He had more swelling. There was more weight loss. He had persistent leg edema. He continued to decline the emergency department for investigations. And it was sort of you can see a pattern of behavior here in terms of his thoughts around seeking out medical attention. Some other maybe relevant past medical history for you to be aware of is he also had diabetes mellitus type 2. He was in a motor vehicle accident about 20 years ago, and he was also experiencing some chronic pain, or what he had told the clinician was a chronic pain diagnosis. Okay. So again, completed an Edmonton symptom assessment scale with him. His pain was 6 out of 10 and in his knees bilaterally, and actually his penis. So diving a little bit deeper into this guy just to try to find out where his pain was and where his pain priority was. Initially, it sounded like it was abdominal pain, but really it was actually in his knees as well as his penis. His fatigue was 10 out of 10. He complained that he was unable to sleep and barely napping through the day. His nausea and vomiting was 0 out of 10, despite getting a history that he was having persistent nausea and vomiting for months. His depression and anxiety, he did not rate, and he became quite verbally aggressive about talking about his illness. And so I guess one of the things I should probably mention is, generally speaking, as a palliative care clinician, whenever we're talking about depression and anxiety, I also talk about illness understanding, as well as, what currently gives that person joy and what are they most fearful of. And so when we started having that conversation, that was when he became verbally aggressive. And in fact, this guy has a history of smoking cannabis as well as cigarettes. And so offered to take him outside. And while he had a cigarette, we completed the rest of the visit actually outside on his front porch. And that seemed to sort of de-escalate him. For drowsiness, he didn't rate. He was falling asleep during the visit, though. It was very obvious that he was very drowsy. Shortness of breath, it was 0 out of 10 at rest or with exertion. Again, when he was ambulatory and seeing him get up and walk around, one would probably suggest that he looked quite short of breath, but he did not feel that way. And his response for his bowels were that they were not an issue. So his current home care services, he had absolutely none. Interestingly enough, when you look at sort of that course of illness over the past year and a half, he had no services at all. He had a family doctor that he was sort of loosely involved with, and he would identify that he didn't maybe have a great relationship with his family doctor. He lived alone with his dog, who was his family. No running water, he had an outdoor wood stove for heat that was not really usable in the winter for him. Given his functional decline, he would have to be able to go outside, chop wood, and actually put it in, and he's unable to do that. He had power through a gas-powered generator, so he would have to be able to go and get fuel for his generator, and no neighbors. He lived out in the bush in the middle of nowhere. Okay. There it is. Hey.
So before Tara goes to case 3, just if you consider the cases that she's presented to you for Jane as well as for John, you can see that both of these cases and the one coming up with June, there's a lot of multiple issues in terms of the requirements for multidisciplinary team involvement. And I'll just remind you, as Tara mentioned, to just keep track of that bicycle wheel that we presented at the beginning. And while you're maybe looking at the case, just think about where and who would you have gotten involved in these cases.
Okay, so our last case is June, and June is an 80-year-old female with an ALS diagnosed in spring of 2020. So a little bit about the background of June. She presented with progressive weakness, predominantly on the left side in her lower extremities, with reoccurring trips to the emergency department at the North Bay Regional Health Center for those same symptoms, as well as some symptomatic hypertensive crisis. Her systolic blood pressure would be anywhere well over 200, and her diastolic blood pressure would be well over 100. And a lot of the times when she was presenting to the emergency department, she was very fortunate enough to have a daughter, which we'll go through in a little bit, who also had a background in nursing. And so a lot of these presentations to the Emerge were sort of with encouragement from her daughter. She had an extensive workup, and ALS was confirmed by a neurologist, and a referral was made to a tertiary center in the south with ALS expertise. So interestingly enough, up until the spring of 2020, this lady was living fiercely independently at home in her own apartment. She had no home care services, and she was on no meds except for a multivitamin. And so when I talk about her being fiercely independent, I don't mean that in the terms of that she wasn't agreeable to have any services in. She was actually an extremely high functioning 80-year-old woman who in fact was volunteering extensively out in the community, helping other seniors who were not as fortunate as her. So some other past medical history, she was diagnosed with a hypertension in the spring of 2020 when she started to present with this weakness. She had an appendectomy and exploratory laparotomy and an elective cholecystectomy at that time, and wondered about maybe some osteoarthritis. And that was really just through dialogue with her family around, she had been complaining of some joint pain for many years and would just take some Tylenol, but no definitive diagnosis for that. Okay, so with June, we needed to use a little bit of a different assessment method given her communication abilities. So we used a bit more of a Wong-Baker Faces Pain Scale with a sort of a modified ESAS with the family who were quite involved in her care, and we'll go through that in a little bit. So her pain was really around a 6 out of 10 in her knees bilaterally. Oh, and her we're laughing here because that is not true. She did not have a penis. Apparently, we did not review that one before. I apologize, guys.
A little bit of comic relief. It's all good.
Yes, we need that in palliative care. We were literally talking about that before this. Anyways, fatigue was around 10 out of 10. Nausea and vomiting has not been an issue. There was some concern around depression and anxiety. We didn't rate that, and the family didn't rate that, but spoke about having some appropriate tears when saying her final goodbyes to her family members. So just before, a few days before the palliative pain and symptom management consultant arrived in the home to help in terms of some consultation with some symptom management, this lovely lady was having some really good visits from extended family members and using some different communication techniques, but she was still verbal at the time, and doing her final goodbyes to those family members. And so very appropriately tearful given the state of her illness, and will continue to cry with talking about her family and about things that she's going to be missing that she was looking forward to. For drowsiness, we did not rate, but certainly she was falling asleep during the visit. Appetite was perceived by family to be around a 10 out of 10. Shortness of breath, 7 to 10 out of 10 with repositioning. And with any sort of care. So any hygiene care that she was having, whether that be sort of her morning care, her HS care, or her nighttime care, as well as some repositioning throughout the day to sort of promote skin integrity, she would become quite dyspneic. And in fact, for this particular lady, having her BiPAP on actually made her shortness of breath and anxiety much worse, and an element of fear. So she would get this sort of deer in headlights look when the BiPAP machine would be on. And so the family just decided to remove it and actually not use it. Bowels had not been an issue. She was day 4 with no bowel movement, and she had not eaten in 4 days, and sort of quote unquote from family, therefore she has no food to poop out, so bowels are not an issue. And so we're going to talk a little bit about that later as to why that's important for us to know. And some educational opportunities there as well. Okay. Oh, and her current home care services. So she, at that time, fortunately, she had some daily nursing. We had PSWs. When I say if available, and that's, I think, for any of us in the North that can resonate with this, it depends on the health human resources. So certainly we can put daily PSW in sometimes twice a day, but the reality is if we don't have the human beings to provide that care, it wasn't predictable for this particular family. She had a great care coordinator, family doctor, daughter was a nurse, the granddaughter was actually in the nursing program, and the daughter-in-law was also a healthcare provider. She had an extremely strong faith and identified as Catholic as well. Okay, oh my goodness. Do you see the mouse anywhere? There we go. Okay, so Dr. Jen is going to talk a little bit about palliative care philosophy.
So all 3 of those cases, if you were paying attention and they sounded like very complicated cases, that's because they were very complicated cases. Thanks, Monica. They exhibit for us what we're trying to talk about in this particular conversation, which is the fact that a multidisciplinary team is required for all cases, but there are many situations in which it's essential for quality of life. If we want to meet those goals of the WHO definition of supporting the patient, supporting the family, and providing good quality of life, meeting the patient goals of care, that we need to do this. So if you think about those 3 cases, in those cases, if care is provided by an interdisciplinary team with the patient at the hub, almost all the spokes in all of those cases were essential. So we're going to talk about the individual cases when we go forward, but just keep that in mind. The other important points that I wanted to bring up was that the patients, the families, the palliative and non-palliative healthcare providers have to communicate and collaborate with one another in all situations, but specifically in these particular cases, in order to meet those patient goals. If we're not talking to one another somehow, whether it's by phone or by fax or by text, if we're not talking to one another about what's going on in the patient's life, we can't meet that goal of keeping all the spokes on that wheel in place and having that wheel move forward. And we can't give excellent palliative care without excellent multidisciplinary care. We may be able to give good palliative care. We may meet some patient goals, but we may not get to the point where we're actually providing the care that's required. The important thing is that the patient is at the center of the wheel. And no matter what we are able to provide or not provide, the patient is affected. It doesn't matter what we're doing or not doing. So if we're not achieving, if one of those spokes reaching out, if one area of that wheel isn't being met, the wheel is going to be wobbly and it's not going to move the way it should move in order to provide a good journey for the patient. So generally, basically, if you have well-planned, integrated, multidisciplinary care, and the reason we chose these 3 cases is you can see, I'll give you an example for the 3rd case with the BiPAP. If the patient is referred, I'm not talking about June specifically, but if you have a patient with ALS and they're not referred in a timely fashion, or they don't make use of the ventilator equipment pool and they don't get their BiPAP when it should be, when they're able to get used to it, and they get to the point where they're very much more short of breath, the BiPAP does become very difficult for the patient to use. So we really need to pay attention and anticipate what we think is going to be required, and then try to put those services in place. And we're all necessary. Every part of that wheel is required.
Okay, I think Dr. Jenna did a good job in sort of talking about the wheel and about how if one of those pieces is not integrated or at least thought of or have access to, then you can see that there's going to be a collapse in those spokes. And that's when we get that sort of wobbly journey. And we may be able to get there. We may be able to complete that journey. It might be relatively okay, but wouldn't it be that much better and that much smoother if those spokes were actually, in fact, working properly and our wheel was moving nice and fluid? So we're going to talk a little bit more about that again when we get through the cases.
Sometimes the patient may be, for example, in the second case that Tara spoke about, where John wasn't really interested in going to the Emerge or accessing the services that required, and it took a lot of repeat visits from Tara to convince him that it would be a good idea for him to get more care. So it's not always the care team that isn't providing or anticipating or giving the patient options. Sometimes it's the patient, but it's our responsibility to continue to offer those options so that people can make use of them.
Yeah, and I think the other piece I'll just add to that is when Dr. Jenna talks about our responsibilities and making sure that it's available to them. It's also our responsibility not only to sort of keep bringing it up and saying, hey, I think that we could benefit from this service or having this person involved, respecting their decision, respecting the fact that this actually, in fact, may turn out to be a wobbly journey. But we as the healthcare provider should not be the barrier to that. We should not be the barrier to the nice, fluid, circulating wheel that can get us there nicely and sort of clean and expected. But certainly we can respect the process in terms of the people on each of their journey and bring those services in as needed and make sure they're accessible. Okay.
So I just wanted to talk about the team or the service that we're providing. And this is not in any particular order because it's often determined by what the patient's particular needs or goals are at the time. Some of the things that we've identified are things like life planning and community supports. And for example, I'll mention again the New North Palliative Care Network, or perhaps they need something in terms of a lawyer or in order to provide help with a will or help in terms of determining advance directives. Or they haven't really, sometimes when an illness is, it's a sudden onset for a patient, they need some time in order to determine what does the quality of life actually mean for them as they go forward. Financial needs, and this is where I rely so much on our care coordinators and our social workers for determining whether the patient has coverage of medications or if they require help in terms of finances, in terms of the place that they're living. I just had a conversation this week with one of our care coordinators, Alicia, about a patient of ours who's currently living in an environment that maybe isn't appropriate, to see whether there's somewhere else that we can find for that patient to go. We had a situation in the hospital where a patient of ours required cyclocapron, which wasn't covered for him out in the community. And the hospital pharmacy was willing to provide that, to pay for that for the patient when the patient went home for a little while, in order to provide the patient with the opportunity to go home. So it's just a question of anticipating whether the patient is eligible for certain programs. For example, as I mentioned, the equipment pool for an ALS patient, for an end-stage liver disease patient, is that patient actually eligible for transplant or not? And then disease and symptom management, which we all do, whether that's the primary care provider, the palliative service provider, whether that's oncology, nursing, and depending on where that patient is, are they at home? Are they in the hospital? Are they in the hospice? Or are they still undergoing care at an oncology unit? In terms of spiritual care, very important, whether that's chaplaincy, and that's chaplaincy in terms of their denominational involvement, and also in terms of a counseling involvement, and a multidisciplinary spiritual care needs, depending on what the patient needs. In terms of our rehab team, I can't say enough about OT, PT, speech, RT, our nutritionists and our dietitians, and the care that they provide to make our patients' lives easier. Psychological and mental health must be dealt with. Basically, what we need to do is look at that patient and say, in practical terms, what does this patient need for them to enjoy a better quality of life, and then see how we can manage that. And again, I'll mention the word anticipate. So if we know that something's going to change in that patient situation, or if we know a disease and we know what's going to be coming, let's not wait until that happens before we try to put things in place so that the patient has an easier time of it when it does happen. It gives patients comfort knowing that we've already anticipated this, and it gives them a sense of, not the word's not comfort, but just to know that the people that are looking after me know what they need to do. So a sense of a willingness to provide the responsibility to us to be able to deal with their situation.
I think the other piece too that I'll add to that is when we're talking about these multidisciplinary team members, there is sometimes a sort of thinking or maybe a lack of understanding or empathy around the fact that, for example, when we refer OT, PT, SLP, or RT to a patient who very obviously has a very limited life expectancy, and people are looking at that referral saying, okay, well, what are the goals here? Why are we looking at trying to rehab and get this person up and walking and get them doing stairs and all those kinds of things, or getting them to swallow their steak dinner? Well, so it's not just about that piece. It's also about the piece about bringing in those team members to have another honest and very candid conversation that is respectful and talking about, I see that your goals are to do this. Do you understand, or what's your understanding about what your illness is? And given now your new understanding of your illness, what are some different goals that we can come up with that are very realistic and let you know that your quality of life is very important to us? So just because somebody can't do a whole, flight of stairs doesn't mean that they can't have a goal in being able to be ambulatory from their bedroom to the kitchen, to be able to prepare one meal a day, because that gives them a gratifying quality of life. And who better to support that goal setting than the experts who are in physiotherapy as well as occupational therapy? So it only makes sense to have these team members in so that they can help set realistic expectations as well as maintain hope, but maybe transitioning that hope to another element. So that's the other important piece I think about this.
I just realized that one group of people I left out of here, and that's our wound care specialists, who also have a huge impact on our patients' quality of life. So let me not leave them out.
Oh yeah, good one.
Yeah.
And pharmacy as well.
Of course. Yes.
Sorry, pharmacy.
Sorry.
Every time I have to find our mouse, guys, you have to bear with me. There we go. So we're going to talk a little bit about our complex pain, and Dr. Jen's going to get a little bit more detail for that for you.
Right. So if you remember the case that Tara talked about, we know that in complex pain or total pain, you can have pain stemming from multiple sources, and sometimes that pain isn't managed just with using the opioids that we tend to use, and we need to add something on to that. So whether that's adding on adjuvants or whether it's adjusting your opioids to manage the pain better, there are different elements of pain. So whether it's somatic pain related to the actual tumor mass or the metastatic disease, whether it's neurogenic pain, depending on where that tumor is sitting, whether it's psychosocial pain, or whether it's existential distress. And that's why, again, all those spokes of the wheel are so important. Again, in a situation like Jane, the requirement was for some anticipatory management. So what we need to know is that any underlying disease in a patient can result in complex pain. We might look at a disease and be, oh, well, that's just simple. There's only disease in one particular spot, so we're only expecting something there. But we have to take into account the possibility of psychosocial pain or existential distress, and then add that to our total burden of pain, and then try to manage that. So what does the team manage in a situation of complex pain? So pain and symptom management. In Jane's case, her pain, the issue that we had with pain was that her pain was increasing and increasing out in the community. And there wasn't a red flag that went up for quite a while with that to say that, you know what, this patient has a high dose of medication and we're still not managing her pain. So is there something else going on? So that's the important time when a red flag has to go up and somebody needs to ask for help. And whether that pain and symptom management comes from the primary care provider, the nursing, the pharmacist, whether we're using opioids or adjuvants, including things like gabapentinoids, non-steroidals, dexamethasone. And in her case, we actually ended up using ketamine and methadone because that's what was required. She ended up requiring admission to the hospital and a change in her medication protocol, which we did while she was an inpatient. And we used a combination of ketamine and methadone. And eventually she did go home. Her pain was relatively well managed, and then she went to hospice. And we managed her pain at the hospice. But there were a lot of other issues there. Tara talked a bit about the fact that her animals were her children, that she had a very strong spiritual strength as well. And many of those things had to be dealt with as well. In terms of direct patient care and care of the family, we need to coordinate the care. Where is the care required? By whom? What services are required? And then, as I mentioned in the last slide, sometimes the practical things are the things that people need dealt with most urgently, like their finances or social care, housing. Have they had their advance directives? Have they seen their child who they haven't seen for 20 years? Are we able to facilitate something like that? And if we're able to manage each of these, the way we do it has an impact on how the other factors in this case settle as well. So in terms of complex pain and total pain, anticipation is important. It can happen with any patient. And then we've got to try to figure out, if I'm continuing to give somebody an increase in their pain medication and it's really not making a difference. More recently, I read a journal article that was talking about looking at pain and asking the patient whether the pain is bearable. So is your pain 5 out of 10? And do you consider that to be bearable pain? And it's interesting how many patients will say to you, my pain is 5 out of 10, and you're looking at the patient, or 8 out of 10, but the patient looks comfortable. And so that's when that question comes in. Is this bearable pain for you, or is this something where I need to do something? Am I going to overdose this patient if I give them more pain medication? And finally, how does that pain affect your function? So you're saying to me that your pain is 8 out of 10, but I'm here visiting you and you're preparing something in the kitchen. Does the pain actually affect your function? Is this something that I need to do something about? So whether we're dealing with palliative care pain or non-palliative care pain, whether that pain is somatic, related to psychosocial, existential, we've got to figure that out and then use the appropriate resources in order to manage that. And sometimes it might require referral to oncology for radiation, or it might require referral to the social worker or the care coordinator to manage some other issue that we haven't looked at. So just to be aware and to anticipate. I don't know if you want to add to that.
No, I don't think so. I think that for me, and we're going to do a little bit of a summary when you'll see as we get to sort of the end of the slides around sort of some of those things that we saw when we were out visiting these people in the community or in the hospital or in the hospice, that were those sort of spidey senses, red flags that kind of came up for myself or the home care team, the hospice team, or Dr. Jenna. And those were those times that we thought, okay, we need to call in some of those reinforcements because it takes a village. And we'll talk a little bit more about that and about how that kind of comes together. Okay. So I guess actually we'll talk a little bit about that right now. So this was the case of Jane. And when we went out and saw Jane, I was referred from a community perspective, and it's actually my colleague at Home and Community Care who said, hey, Tara, do you mind just going in and sort of seeing this person and giving your 2 cents? You know, the nurses are also looking for some extra help as well. So one of the things that I sort of often encourage is, while the ESAS is a really, really great tool as a basis for understanding, sorry, there's a bit of I think a snowplow going by, so you might hear a bit of noise there. So the ESAS is a really great tool to have people help to objectively identify what their pain scale is. However, it's a bit more than just a rating scale. So oftentimes I see that I go out into the community or even in a hospice and the hospital, and we use the ESAS as a measuring tool. but it's to open the conversation. It's not just about rating those symptoms. It's about having a conversation about, just as to what Dr. Jeanette said, about what does that symptom mean for them? What's the priority, etc. And it's really the basis for a focused and detailed assessment that should sort of kind of be fluid and continue. So what are the patterns? What we saw out in the community with this particular individual was the opioid use and the onset of the severe pain. So typically speaking, this lady would have her opioids adjusted, and then for about 12 to maybe 16 hours later, she would have that improvement in that pain over that period of time, and then her pain would start to escalate again, despite the titrations going up almost on a daily basis. And so while she had a really good 12 to 16 hours, then her entire night and the next following day would be spent sort of attached to that pain pump that she was on and pushing the button. What were the characteristics of the pain? So oftentimes, when we ask those questions about what's your pain, where is it? But what is really, really also important to ask is, what does it feel like? If you could describe it to me and use some of those words about how to describe that pain to somebody, what would you say? Is it sharp? Is it burning? Is it aching? Is it constant? Is it intermittent? Is it only when you move? Does it happen when you take a deep breath? Does it happen when you let your breath out? Those kinds of things. The relationship of anxiety and pain was really, really important for this lady. And despite, I think, the best efforts of the team, because this is a complicated case, I think there was a piece there that even myself did not really appreciate, the anticipatory piece and anxiety around, oh my gosh, my pain is going to increase to a 10 out of 10 if I don't stay ahead of it. So I'm just going to keep pushing this button no matter what, every 20 minutes, so that I don't get to that point again. Because when I do get to that point, it's excruciating and I can't function and I'm crying and I'm curled up into the fetal position. And so because she's had that past experience, now she's anticipating it's happening again. Very, very similar to our chemo patients who have that anticipatory nausea that we often have to treat with some benzodiazepines before they walk into the chemo clinic. They're already feeling nauseous because they're anticipating that nausea is coming. This was very true for Jane when she was out in the community and anticipating her pain coming. Vitals are usually the least important. So I see this happening all the time, and we're guilty of it in every single care setting. And we sort of think, oh gosh, we need to get a baseline vitals. What's her respiratory rate? What's her oxygen saturations? What's her blood pressure and her heart rate? And while those can be very, very important, I am more concerned about, and our palliative care team is more concerned about, and you should be more concerned about having the conversation with the person. What is the most important thing here for us to address? Because if her heart rate is high and her blood pressure is high, there's a reason behind that. And certainly it might be medically related, but it also can be anticipatory anxiety related as well in terms of symptom management. So if we get to the nuts and bolts of what's really happening here, we're probably going to be able to address all these other things that we're traditionally thinking about. Patient and client priority. I'm going to go back up to number 3. If it feels unusual and not right, go with your gut. So I went and I saw this lady, and it was a very humbling moment for me because I had been working in palliative care and pain management for a long time. And I saw these escalating doses of opioids, and I thought, okay, we can do this, we can do this, we can do this. I went home, thought about a plan, talked to the family care provider, and we had a plan. But then after that, I still felt not right. My gut was telling me that something else was going on here, and it didn't sit well with me. And I kept perseverating on it. It kept me up all night. My gut was telling me that there was something not right. So that was when I called the reinforcements in. I called a colleague of mine who has expertise in palliative care and pain and symptom management, who's a physician, has been working many years in palliative care, and said, this is what I'm seeing, this is what I'm feeling, this is the plan we came up with, but it doesn't feel good to me. What do you think about this? And then I got advice from that person. Then there was a conversation then that happened between myself and that palliative care physician, the MRP, to say, okay, we need to go a step further here. So even with people who have been doing this work for a long time, you still need the help. You still need to be able to be humble, make it about the patient and say, okay, I need some reinforcements here. Priority for this lady was to be at home with her husband as support, but required 24/7 care. It took some really great and thorough conversations to convince this lady that we needed to be able to help. And in order to do that, we needed to do a planned admission to the hospital to look at getting methadone and ketamine on board, with the goal of that this is only a temporary solution, that we're going to get you home again. And so making sure that she could have that trust, and that's what our goal was. took a little bit of work, and that's okay because that needs to take work. This last point was really me being the new kid on the block, knowing what you don't know, and that it wasn't about me and bringing in the reinforcements. And again, that this happens all the time for any of us who've been doing this work for a long time. I didn't know some of the people I could reach out to because I was relatively new in the community. So I needed to access those resources that I had to say, okay, I need to get some help. Can you help me get the right person to help me fix this? And I think that's reasonable. Anything I want to add to that? No. Okay. Being cognizant of time. Where are we at for time? Are we doing okay?
11:21.
11:21. Okay.
Maybe we'll move a little faster.
14 minutes.
Yep.
Okay. Okay. Perfect. So we've got our next case here about end-stage liver disease, and Dr. Jen is going to talk a little bit about that in terms of medical management.
Right. So I was going to go into a lot of detail in terms of managing end-stage liver disease, but I think the focus of our conversation changed when Tara and I were talking about this talk, to make it more about, let's look at the case and see where there were issues. So I'll just give you an overview in terms of end-stage liver disease, but I really wanted to talk more about, again, the two things that I mentioned in the other slide, the anticipatory management and what do we manage as a team. So we all know that end-stage liver disease can develop from multiple etiologies. The most common is alcohol, but there's obviously viral, and more recently in the last 10, 15 years, there's obesity with non-alcoholic steatohepatitis. And there are other causes of end-stage liver disease. In order for cancer or something like that to cause end-stage liver disease, you've got to destroy a fair amount of your liver for that to happen. But the common ones are alcohol. And we think that that was the situation with John. So in terms of end-stage liver disease, what do we anticipate? So if we know end-stage liver disease, we know that there are symptoms that need to be dealt with most commonly in almost all patients with ESLD, and that would include pain, fatigue, which is very common, ascites, which is definitely an issue, edema, which was quite significant for John. Many of them will complain about cramping. And then the one that destroys families is hepatic encephalopathy. So if we know that there's a patient who's presenting with end-stage liver disease, we need to anticipate that these symptoms are going to need to be dealt with, even if they're not there at the time. I had a case of a patient with ESLD many years ago, and the biggest issue was the hepatic encephalopathy because she would not sign the documentation to allow her sisters to manage her affairs. And this was devastating for them right up until end of life. They couldn't get her to agree to sign the documentation that would allow them to manage her finances, as well as any other issues that needed to be dealt with. Encephalopathy is something that will develop and it needs to be dealt with. With regard to pain, the fatigue, the ascites, these are things that do tend to happen in almost all end-stage liver disease patients, and we need to be able to make sure that we manage them. If I just talk briefly about pain, we often use opioids. Hydromorphone's the commonest one that we use. It's well tolerated and metabolized well. The question about end-stage liver disease is the dosing and the frequency of the dosing. So because the liver is our organ that manages a lot of our medications, we need to use very small doses, and they're often given very infrequently because they last in the system for a long time. In terms of the ascites, paracentesis is an option, of course. Then there's always knowing that we can use the diuretics, that combination of furosemide and spironolactone, and being aware of it and knowing that if we go too far, we can possibly put the patient into renal failure as well. So there is some expertise required in end-stage liver disease management. There are a lot of articles. There's the textbooks that tell us how to manage it. We just need to anticipate and make sure that we're doing what we need to do. I can't stress enough on the hepatic encephalopathy, and that's something that our home care nurses who are in the home need to keep an eye out for. And the discussion in terms of goals of care, advance directives, power of attorney, wills, all of that has to be done very early on in this disease. Otherwise, it just doesn't get done at all, or it gets done, but in a very unsatisfying way for the patient as well as for the family as well. So as a team, what do we manage in an end-stage liver disease patient? We manage pain and symptoms, as always, the primary care provider, a palliative care physician, nursing, the pharmacist. The doses matter. So what doses of medications are we using? When they have anxiety, we need to use very small doses of lorazepam, again, because they stay in the system for a long time. The pharmacokinetics change with the damage to the liver. The choice of the drug matters. The choice of the route matters. Are we giving it by mouth or are we giving it subcutaneously? And the timing matters as well. The interesting thing about John's case of end-stage liver disease was because he had the bladder cancer before, the team tended to want to focus on the fact that he had the bladder cancer, but the bladder cancer really wasn't the cause of many of his symptoms. It was his end-stage liver disease. And so in terms of managing care, we had to sort of put the bladder cancer in the background because that wasn't what was causing the pain. That wasn't what was causing the ascites. And it was to focus on the end-stage liver disease. And then in terms of direct patient care and care of the family, again, we coordinate the care. Where is it done? By whom? What services are required? He required a lot of help from Tara with regard to agreeing to come to the hospice and then managing whatever finances. He did have some friends. There wasn't a lot of family involved. As Tara mentioned, in terms of housing, he lived in a home where there were really no facilities. So obviously managing his care there would have been very, very difficult. In terms of his advance directives and POA, that was dealt with once he was partially dealt with before he got to the hospice, but then after that, once he was at the hospice. And then again, I'll mention that the way that we manage any of these symptoms, whether it's pain and symptom management, or whether it's the actual direct patient care, has an impact on everything else. As I said, we need to anticipate. So in a situation like this, managing his ascites was a real issue for him because as Tara mentioned right at the beginning, his pain was related not just to his knees, but to his penis. He had significant peripheral edema and ascites, and it was very, very difficult for him.
Okay, so just to give you a little recap of, how this sort of played out and the importance of sort of interdisciplinary, multidisciplinary palliative care teams. The biggest thing for me is sort of as soon as I sort of walked into the home was, oh my goodness, we're going to need some help here. The next biggest thing was, oh my goodness, is he going to be ready to have the help here? It was very, very obvious that this gentleman, who's a lovely guy, had some major trust issues in terms of the healthcare system and had been on his own for about 30, 35 years or so with just himself and his dog. In addition, one of the biggest things I think that helped in this case was the fact that I didn't need to have, in meeting my role, the palliative pain symptom management consultant does not need to have a referral by a healthcare provider. So how I got connected with John was actually through one of his friends, his sort of distant friends that had been sort of precariously sort of involved in his life here or there, depending on what state of health he was in. And it was just sort of through word of mouth that they ended up finding out about my phone number and made a direct referral to myself. And so that was really great because as soon as I called John himself to say, hey, I'm a pain and symptom management nurse and I hear that you're struggling and I'd like to see if I can get you more comfortable. As soon as I said pain management, he was just sort of all for it and invited me into his home, which was really great. Right from the get-go, we spoke to him around getting links created with home and community care. His family doctor, which again was a bit of a strained relationship, not from the perspective of the family doctor, but more from the perspective of the patient himself. And that was really because he had some really challenging dynamics and a challenging history. He had significant trauma as a child growing up. He had a chronic pain issue, which he identified, but had been on opioids for quite a significant period of time, as well as some illicit drug use. There was some concern around diversion. There's some concern around alcohol use, etc. The other piece that was really critical in this was reaching out to a palliative care expert physician around this. And the reason we did that was because the family doctor, although well-intended and really wanted to help this guy, because of the historical nature of the relationship, the patient did not trust the family doctor for no rhyme or reason other than just some of these other factors that had occurred previously in his life. And so he had already sort of written that relationship off. So it was really important to bring in another prescriber that had some really great expertise in palliative care and pain and symptom management, particularly in end-stage liver disease. Education was huge here. to the family and to the client. And remembering his family really wasn't around. He had some distant family that lived in the Aurelia area, but he had not been having conversations with these people for years. The really only contact that he had were some really close friends of his, which he identified as close. Close for you and I might be that we talk to our friends maybe, once or twice a week. Close for him was maybe talking to them once every 6 months. So keeping that in context. The biggest thing for him was the fact that he thought that a lot of these symptoms, as well as his family and friends, were related to, as what Dr. Jenna said, his bladder cancer. And really, that was not the issue whatsoever. It was really this liver failure that was occurring and these sort of preemptive symptoms that had been happening for months, but that he chose that he did not want to investigate further. And so there was a lot of work to be done there, in terms of talking to him around his choices around not seeking out blood work and investigations and those kinds of things, and some of the guilt that he felt with that, that sort of resonated with him. And in addition, the trust that he had in the healthcare system. So it really needed to become a focus around education and what he needed to expect and what to anticipate. The dosing of the medications, his current medications, he was having every 2 hours. And as Dr. Jenna had mentioned, when he had that sort of a significant involvement of end-stage liver disease, we know that actually we can be, despite our best intended efforts of trying to control his pain management, we were actually making things worse by actually increasing the intervals of the medication, the dose, et cetera, and the way that they were prescribed. And to no disrespect of anybody else, because nobody had laid eyes on this guy because he didn't want anybody to come into the home or he didn't want to seek out medical attention. Basic nursing. We needed to just do some basic nursing practice here, talking about bowel and bladder. We forget the pee and poop. They often call me the poop nurse out in the community and at my part-time job at the hospice. So because I'm so concerned about people having poops, it is so vitally important, and especially when you're talking about high ammonia levels with hepatic encephalopathy. This poor guy, because he was quite advanced when I first met him, he definitely was jaundiced, and he also had significant edema that Dr. Jenna was talking about. In addition, because of his hepatic encephalopathy, we'd also often have conversations with him talking about advanced care planning and his disease and what this was going to look like, and he would forget. So, I'd call him 2 days later and we'd have to have the conversation all over again. So it's almost like reliving these conversations over and over again. So trust was a huge thing. His priorities. So meanwhile, I walk into the house and I think, holy smokes, there's so much going on here. I need to get him out of here. I need to get his pain under control. I need him to get some resources. I need to get him this. I need to get him that. That was my agenda. His agenda had nothing to do with that. His agenda for him was that he loved the way that he lived. He had lived this way for 35 years. He didn't want to change it. And we needed to make it real for him in terms of what this was really going to look like. This was not going to be what I would call the palliative care fluff and puff kind of end of life situation. His priority was housing. He was worried about where he was going to live because he couldn't put wood into his stove out in the winter because he wasn't mobile enough to be able to do that. And his family was his dog. What was going to happen to his beautiful dog, who's been his only family for about 8 years, and his sole kind of confidant. This is what really delayed his admission to hospice. He would have qualified for hospice the day that I saw him. But in fact, because he wanted to make sure that his dog was looked after as well as his home, that he took a great amount of pride in, he needed to make sure that that was addressed. He needed to be able to get out to smoke. That was also another priority for him. That had to be his piece, to be able to get outside, have his cigarette or his cannabis, and then be able to come back inside on his own terms when he wanted to, so that he could enjoy that. He'd been doing it for years, and it was something that he needed to be able to look out at the bush. His pain was also his priority. He feels that he had significant chronic pain and now acute on chronic pain related to his disease. And so that needed to be a priority for him as well. It needed to be a priority for us. And he didn't really, at the beginning, wasn't very open to some suggestions in terms of changing around his medication until he could build a trusting relationship with myself and some other staff. Hope and trust. This was also very huge for him. So he had lived in his house, like I said, for 30 years. He wanted to be in his house ongoing. He was agreeable to go to the hospice once I told him about how wonderful the people were there. But he needed to maintain hope that if there was some way or some miracle of hope that he was to improve a little bit and become more independent, that he could have the opportunity to return home if he could. And so there was no way that I was going to take that away from him. And we don't do that as well in palliative care. While we are very realistic and we anticipate what is going to happen, and we're very forthcoming with that information with patients and families, we also maintain a level of hope so that they have something to aspire to. that's realistic. Control. This guy's been in control of his own life for many, many years. And despite the fact that I would love to have got him right in the shower and have a tub bath and get his dressings changed and get him fresh clothing on and clean up his dishes and clean his house for him, he needed to be in control of who came into the home, who did what, his medications, his conversations, and who those conversations were with in terms of his friends and his family, his physical care. It was a hard transition at the beginning for hospice. He was very, very thrilled to be there. But as you know, with particularly some challenging psychosocial needs, you know, our physicians rotate on a weekly basis in the hospice, just like in many healthcare organizations. And for this gent who has trouble building trusting relationships, it needed to be supported that those physicians, as well as the nurses in that particular environment, were all on the same page and had the same goals in mind, and allowed him to have a little bit of control in managing his own end of life situation. And so making sure that we were all on the same page about how we were going to approach this was essential for him to have a successful transition to the hospice, to stay in the hospice, and sort of allow his grief and bereavement process and his loss of control. Is that fair to say that?
Yeah, he
Yeah.
had a difficult time even at the hospice. Even almost towards the end, he kept saying, maybe I should go back to the gastroenterologist and see whether I qualify for a liver transplant. You know, issues with his cannabis and his smoking and being able to get out and have the smoke. But the staff at the hospice did a great job. And as Tara said, we tried to make sure we're all on the same page and try to manage all of his goals that he wanted to achieve.
Okay. Okay, so our amyotrophic lateral sclerosis, or ALS. So Dr. Jenna is going to talk a little bit about that as well. That's our last case.
So ALS, we're going to try to go a little bit faster because I think we're keeping an eye on the time here. 20 minutes.
20 minutes?
Yeah.
Okay.
So I'll go quickly through ALS. You all know ALS. It's a disease of losses. People lose their mobility, their speech, their capacity to eat and drink, their independence, their relationships, and they lose their ability to reach personal fulfillment. And this happens either very suddenly with bulbar ALS or maybe a little bit more slowly with the peripheral, but it does happen. And because it's a disease that's been out in the media so much, once it's diagnosed, once the diagnosis is there, people are aware of what's coming. It is our responsibility to anticipate management again. So what are the things that we're anticipating? As I said, it's a disease of losses. So we know that our patients are going to start experiencing difficulty with swallowing, with dyspnea. They're going to have pain issues. They're going to have mood lability. They're going to have secretions that are going to be a concern, and they're going to have anxiety. It behooves us all to know about these diseases and to know what to expect. Many of our patients, thank goodness, are often referred to the multidisciplinary teams in either Southern Ontario or Ottawa, to the hospitals where they are set up to deal with ALS, and they will often help in terms of both palliative patient management as well as providing support for the things that we think our patient might be requiring as time goes by. This is really the disease that requires multidisciplinary care. All members of the team are required in this disease, whether it's your OT, your RT, your nutritionist, your dietitian, the physician, nursing, and everybody needs to be aware of what this disease can do and what the patient cannot do as this disease progresses, so that we provide support and care. Anxiety is a huge issue in this disease because the patient remains cognitively intact, although there can be some mood lability. And so they're aware of what's going on, and they need to know that the team that surrounds them knows what they're doing and is able to anticipate and provide the services that are required. What do we manage as a team in terms of pain and symptom management? Again, the primary care provider or palliative service provider, nursing and pharmacist. The common drugs that we use include hydromorphone, benzodiazepines, and the anticholinergics for the secretions. BiPAP is essential, and again, as I mentioned previously, should be introduced early and is often done by the team in either Toronto or Ottawa. The feeds are often dealt with early on, again, by that team. Whatever equipment the patient requires, whether it's the wheelchair, whether it's the communication tools that they require, whether there are things required from the ventilator equipment pool. Is this a patient whose goals of care include a tracheostomy, or is this a patient whose goals of care include only BiPAP? Do they want to stay at home? And this is where the direct patient care and care of the family becomes so important, right? So we need our care coordinators, our home care nurses, our PSWs. What are the services that they need? What do they need financially? I have a patient right now in the community who would like to stay home. Her family is young and they work. So perhaps she might need some help with assessing her insurance to see whether there's a possibility of providing an earlier outlay of funds that they can use to provide private home care. So this is the type of thing that we need to be aware of, and we need to anticipate, and we need to provide this opportunity for families so that they feel that we are aware of what's coming and we're able to provide the services that they need. And again, I'll repeat the same thing over again. The way that we manage any one of these situations, whether it's their pain and symptom, whether it's the fact that the patient needs equipment, whether it's the fact that the patient feels they don't want to stay home and they want to go to the hospital, or whether they need us to be there to have a family meeting, the way that we manage each of these has an impact on the rest of the patient's functioning and care as well.
Mhm. So for June out in the community, again, Dr. Jenna talked about this and talked about it with all 3 cases, in fact, but anticipation, anticipation, anticipation. So the patterns for ALS, ongoing weakness, losses. And the other thing I'd like to speak to around this is for the patient, but also for the family, right? So in particular for this lady who is quite high functioning, if you recall, she was an 80-year-old lady who was very, very well, not on any medication and doing quite well prior to this. About 2 days before I had come in, she was still verbal and talking to her family. And by the time that I came in 2 days later, she was now nonverbal. So when you're talking about personal losses, huge for the patient, but also huge for the family. So for those people that were still coming in and trying to say their goodbyes, 2 days ago, they were told that she was talking. Now she's not talking. There was inability to use some communication boards, etc. So talking to the family around that and supporting them around that was really huge. Dyspnea or shortness of breath and anxiety, the relationship between the two and education in terms of the family as well as the patient around this, right? And in terms of one making the other one worse and how we sort of manage that, anticipating that with this particular lady, whenever she would have hygiene care, repositioning, she would have increasing shortness of breath and the anxiety would increase. So talking to the family around pre-medicating, a half an hour to 15 minutes, depending on, what our route of medication, before she had this hygiene care and before we did repositioning, made a huge improvement in terms of her ability to tolerate as well as have anxiety related to hygiene care. Patient and client priorities was wanting to be at home. And the biggest thing for this lady was a fear of suffocating. So unfortunately, this particular lady, if you recall, we brought the BiPAP in, meaning the collective team had brought the BiPAP in, but by the time the BiPAP had actually brought in, she had already progressed quite rapidly in her ALS. And unfortunately, when she started to get the sizing and the fitting for her BiPAP mask, it actually increased her anxiety and increased her sense of being breathless because she had not been used to having a mask on her face and with that sort of pressure and around her head. So in fact, it wasn't helpful at that point. It was actually making the matter worse. So to give you an example, one of those things when we're talking about a definitive diagnosis of ALS, getting RT involved right from the get-go as a multidisciplinary care provider is essential for this patient population. And so I have another person that's actually in the community right now who also has ALS. And interestingly enough, I was chatting with this person on the phone recently, still quite communicative and prefers to be chatting on the phone right now, who had said to me, I'm not ready for the respiratory therapy yet, Tara, and I don't need to have that BiPAP yet. I'm not quite there yet. So we can just put that on hold for now. So I had to do lots of education and say, I respectfully agree with you. You're doing quite well right now. But I can tell you in my experience in working with this population and in terms of your quality of life and pain and symptom management, that even though you don't need this right now, it would be worthwhile to even consider having that team come in, fit you for the mask and putting that mask on every now and then just to acclimatize yourself to it so you get very comfortable with it so that when you do need to use that mask, you're very comfortable with wearing it and it doesn't cause you to feel that you have something trapped on your face, essentially. And so just with that education, he's flipped his frame of thinking and has now decided that, you know what, that's probably a good idea. I'm going to try to do that right now in anticipation of what's to come. So just sort of keep that in mind. And that's kind of a point that we're trying to drive home here. Health human resource use. So frequent and consistent nursing support and approach. So again, in terms of the symptom management, when Dr. Jenna was talking about our typical medications that we use of hydromorphone, benzodiazepine, and anticholinergics, making sure that the healthcare team that's wrapping care around this patient is very well versed in why we use those medications, the frequency of dosing, and their indications, so that we're all on the same page. Respiratory therapy, we've talked about. Home visits. So, and 24/7 access. So they're 24/7 access in terms of our nurses. So if at 2 o'clock in the morning, we're experiencing a sudden onset acute shortness of breath or some sort of distress, they're available to the family. As well as, I would arguably say, for each one of these patient scenarios that we had, home visits by the physician were essential and really, really critical in terms of building relationships, support, recognizing that we were honoring the patient about where they wanted to be at most, in terms of they wanted to be at home. And for them to go out to a visit to see a physician in a clinic was an extensive use of energy and caused them a great amount of fatigue, when their time was better spent being at home with their families and their friends and going through their sort of grief and bereavement. So really critical for that. Anything you want to add to that?
No.
No. Okay.
Okay.
And I think, why does the interdisciplinary and cross-sector team matter? I think we've talked about this a lot.
Yep.
Transitions, communication, access to up-to-date information, particularly for our community partners. You know, when we don't have information at our fingertips from recent hospital stays or at the oncology center, having good communication to let them know what has worked in the past and what has happened, what has transpired in those visits are essential. And then we avoid that whole 2 steps forward, 1 step back for symptom management. Don't want to? Nope. Okay. So we want to give you guys some time to ask questions or make comments. The biggest thing at the end of this that we wanted to chat about too is, how do you get a hold of us? Essentially, I think most of you know that have interacted with me, you can get me on my cell phone. My cell phone number is at the bottom of that referral form right there. Anybody can refer to the palliative pain and symptom management consultant. It could be a volunteer, it could be a patient and a family, and that's the referral form right there, which you can get off of the Northeast Healthline website, in addition through your care coordinators, etc. For our North Bay Regional Hospital palliative care team, variety of reasons that we can get referred in terms of myself as well as the physician team, advanced care planning and goals of care conversations, pain and symptom management consultation, psychosocial support for the patient and the family, also transition care for the most responsible provider for end of life care. And if they have no family doctor, that's one of our big things. If there's patients that are coming into the hospital, they have no family doctor, and you ask yourself this surprise question, would I be surprised if this person was to die in the next 12 months? If you said that you wouldn't be surprised, then that would be a great way to refer to the palliative care service for us to be following and providing support on a multitude of levels. Okay, I think that's probably it. So I think we'll open up to questions. If you guys have any.
So we have some questions in the Q&A here. So the first one from Joyce, where does long-term care fit in the spokes wheel that you were talking about earlier?
So if do you want to bring that spokes thing up again?
Yeah, let me go back here. Let me see if I can do it this way.
We tried to be as comprehensive as possible, but I already mentioned to you that we forgot about it. So but I think where it would fit into would be in our nursing, in terms of home, hospice, hospital, and we should have added long-term care in there as well. Oftentimes our long-term care patients, the physicians who are looking after the patients in those long-term care facilities have a lot of expertise in palliative care. So they don't often ask for assistance from us out in the community. And the long-term care home is often set up to deal with social issues, family issues. They have their rehab teams as part of their team, and oftentimes the patient's spiritual care will be managed depending on what the patient requires in the long-term care facilities. So I didn't leave it out on purpose. I should have put it in there, but a lot of times those facilities are created in such a way that they manage the patient using all of the expertise in this hub.
Awesome. So we have a question from Carl. I think this is in relation to the case about Jane. Did you administer ketamine IV given its lipophilia, rapid dissipation when administered by other routes?
Yeah, so we actually did bring Jane into the hospital and we did IV ketamine. Jane had a PICC line as well as a peripheral IV. And then so we were able to manage to give her, initially we started her with IV ketamine, and then eventually we were able to transition to oral dosing of ketamine for her. So she took ketamine and methadone, and we actually required methadone as well. So she was on a combination of medications.
Awesome. And then just a follow up from Carl. Have heard emerge physicians say that ketamine has often been ignored due to its bad rep as a street drug. Any comments on that?
Yeah, so so there's a lot of protocols out there for ketamine use. Currently at the hospital, at the North Bay Regional Health Center, I'm working with our palliative care pharmacist to create a ketamine protocol for us in the hospital. We've used it on occasion for patients who have severe pain. I remember I had another patient who had a really bad genital wound, and the only way that we could manage her pain before dressings was to give her ketamine. So we do use it, and we are aware of the risk outside. We were very careful with Jane. As I said, she was and Tara explained, she had a very, very supportive husband, and was in a situation where he was able to manage her medication. She had a really good primary nurse who was going in all the time, and we were constantly communicating about her pain and how things were managed. And then once she was in the hospice, obviously there we were able to manage things well. So I do agree, it's definitely a drug that we are careful with, but it works really well for some patients.
I think the other thing too with that, Michaela, is that is the extensive education that's required to still among healthcare providers as well as the general public. And that when we're talking about using it in a palliative care context, the intent of using the ketamine and methadone is a little bit slightly different in terms of the thought process behind it. So just balancing those two and then doing it in a really supervised sort of environment with somebody who's really knowledgeable in that skill set, right? And a good supportive team around that.
And that was one of the reasons that we brought Jane into the hospital, actually, was transitioning her over to the ketamine. We anticipated we might have some issues. And so we admitted her to the hospital so that we could do it on our palliative unit, where we could monitor her more carefully.
Awesome. Perfect. So Heather asked, is ventilation available in the North Bay area for patients who require it for ALS?
I'm not, so just to clarify, are we talking about BiPAP, or are we talking about intubation ventilation? You know, I mean, a lot of that's determined by the patient when they're initially deciding on their goals of care. So BiPAP definitely is. We have a really good RT team in North Bay, and we certainly are able to provide BiPAP. And I have had one patient who elected to go to the hospital. He wanted to have, actually I've had a couple of patients with tracheostomies, which were done early on. You can't leave tracheostomies until too late, but if they're done early on and then the patient decides that they want to go to the hospital and have ventilation by that route, it can be done. Yeah, the North Bay Regional Health Center has the expertise to support that. Yeah.
All right, perfect.
If we were talking about, sorry, Michaela, if we're talking about BiPAP, definitely, like that's definitely an option in the community.
Yeah, Heather just followed up. She was asking about intubation.
Oh, yes. So, and again, that's a conversation. So I'll give you an example. The patient that I had, you know, last year or earlier on in the summer, had elected finally that he was on BiPAP, and he decided that he wanted to go into the hospital and have a tracheostomy done. It was too late by then. Our ENT surgeon saw him and felt that the risk was too high for him. So he wasn't able to do that. And then during his stay there, our conversation, then we reviewed again. He was a gentleman who was very much, again, in control. He wanted to have control of everything that happened in his life. And so the conversation was held with him as to what was important for him. And at that point in time, he decided that that he wanted to see his boys, his 3 sons, and that he had had enough. He was done. And so we helped him with a slow wean by respiratory therapy of his BiPAP while we managed his symptoms with benzodiazepines and opioids, and he passed away peacefully on his own once the BiPAP was removed a short time after that.
All right, awesome. And Anita asked, can we have the referral form emailed to us, please? So we can add that in our conference, the follow-up email, if that's all right.
Sure, we can.
Okay, perfect. Linda asked, when the client wants to pass at home and family can't provide 24-hour care and limited PSW help, DT shortages, any advice how to help with this conversation?
Yeah, so this is not an uncommon conversation at all. We know just from experience that providing end-of-life care at home without a family member being present 24 hours, or at least the patient financially being able to support having a private care provider in place, it's impossible for us to do that because we need somebody there all the time. And with the shortages that we have in terms of bodies, we would not be able to provide that as a home care service, as far as I know. So in that case, we often talk about either when we didn't have the hospice, I would often talk to people about direct admission to the hospital, to the palliative unit. And I have had patients and families who've agreed to that. It's more difficult in this current COVID situation, but I have had patients come into the hospital even now. And then now we have the hospice available. So that's definitely an option. And it is providing a more home-like environment if that's what the family wants. So there are options available. Unfortunately, if we don't have a family member who's able to be there all the time, we just can't provide the quality of care, the excellence in care that would be required for good end-of-life care.
I think the other piece I'll add with that, Michaela, is that majority of the time now, especially in this sort of new COVID context, right, with we're even in bigger health human resource shortage, just for the nature of the situation right now, is most of the time our palliative care service team always talks about a backup plan. And whether we have to enact that backup plan is irregardless. But what that, just talking about the backup plan and having one, even though maybe 1% of the time we have to enact it, it's there. And it also puts that sort of comfort on the patient and the family. Being honest with having the critical conversation, right? In a very respectful, honest way to say, this is what this is going to look like. This is going to be exhausting. This is not a sprint. This is a marathon. This is what you're going to be having to look to do. And we're happy to support you in this. However, you need to know that we put this backup plan in place because there may be a moment where you say that this is enough and we now have everything, all of this sort of background red tape stuff is completed. So then that way we can just transition smoothly. The reality is that sometimes, despite our best efforts, our education and our best advice, people, patients, and families make a choice to maybe put themselves in more of a precarious position that maybe some of us are more comfortable with. But that's the choice, right? That's the journey that they've chose. So we need to support them in that in the best way that we can, while also continuing to provide the advice and the expertise that we're there to provide, right? So,
I mean, one of the messages that I really wanted to have come through here was the fact that we're trying to provide a situation of seamless palliative care in our community. The North Bay Regional Health Center has been very open to providing beds for palliative patients. So if we have an end-of-life patient that the family is not managing, it's easy for direct admits for us to the hospital. If the bed's available, the hospital will make it happen. And now that we have the hospice, the same situation exists there. We've done some almost emergency admissions to the hospice where things weren't happening, and we were able to make it happen with the help of our coordinator, Lindsay, there, and the nursing team there, and just able to make things happen with our home care coordinators filling in the forms as quickly as possible. But again, anticipation is key, as Tara's saying. If you know the patient wants to be at home, but just make sure that there's an understanding that in the event that things start to become difficult, let's try to make sure that we have other things in place so that there isn't a huge pothole, that wheel can still continue to go.
Yeah, for sure. Leah asked, does the North Bay Regional Health Center palliative care team have a social worker on board, and how are they involved? And can a social worker administer the Wong-Baker Faces Pain Scale?
Yeah, so our palliative care team actually currently consists of physicians, as well as Tara, who is our pain and symptom management nurse specialist. And then we access our social workers from the unit wherever the patient is. So we access social work, rehab team, dietitian, speech pathologist, all of that wherever the patient is. So let me give you a background in that we didn't have a hospice. Palliative care has been going on at the North Bay Regional Health Center for all these years, and we've been providing the service wherever the patient is in our hospital, and preferentially moving that patient to the palliative unit if it's possible. So all of our social workers are very well versed in providing the care that's required. Our chaplaincy is second to none in terms of providing the counseling as well as the denominational support or finding the person that the patient requires. And in terms of the Wong Baker PCIES, even our nurses can do that. So our nurses are learning about ESAS and learning how to determine patient pains.
Awesome. Perfect. Then Leah followed up. I wonder if peer support would be beneficial for someone like John, meaning someone who may struggle with trusting hospitals or doctors. Maybe a person who is a little less medical but is familiar with end-stage liver disease could be helpful. Any thoughts?
I love that.
Yeah.
I love that. I think one of the things that makes that a little bit more complicated for John in this particular context was this new COVID world that we live in, which everybody is struggling with right now in terms of that peer support piece, right? John didn't really have the technology to be able to provide that for himself, you know, to be able to reach out to things. So that was one of the things that certainly when he moved to the hospice can help certainly facilitate that because they have the technology and the means for that. I would have loved to have seen that in the community for him, but we just did not have that capacity to do that at that time. And he had he was very ill by the time that I first saw him and was quite deconditioned. And so if we had that bit more time, I think, yes, absolutely, that peer support would have been critical for him.
I'll just add to that. I don't know how much experience people have with end-stage liver disease patients, but if you want to put peer support in place, it has to happen much earlier on, because by the time the patient gets to the point where they're either admitted to the hospital or to the hospice, the encephalopathy plays a significant role in terms of their agreeing or disagreeing. And in terms of John, he had a lot of background issues as well. So I'm not sure. I think it's a great idea. I think it's a great idea for all of our patients to have some sort of peer support that's non-medical. But in end-stage liver disease patients, the issue here really is whether or not they are accepting of it. Sometimes they don't even accept the support from their family members, let alone anybody else.
Yeah, for sure. We have quite a few questions here, and I want to be mindful of everyone's time because it is 12:02. Monica, do you have a suggestion if we should keep going with questions? Maybe we can type them up and give them to Dr. Jenna and Tara and send those out to everyone with the answers next week.
How would you like to do that? Follow up after the session?
I'm totally fine.
I mean, I'm good for another 10 minutes or so if we can answer some of them. And then if we are left with the questions at the end, we could maybe, is that okay? I don't know if people are okay to stay online to listen, but I'm happy to stay for, and Tara is too, so.
Yeah, and if people have to leave to do something, then feel free to go ahead and do that. So, so Norma Jean asked, when is MAID discussed? Who brings it up? Is there a best time or best circumstance?
Oh, good question.
That's a good question. So we've discussed this a lot. So the original, the law says that the patient has to initiate this discussion and that there shouldn't be no barriers for this to happen. And that's essentially what I have been advocating. So if you're asking me if I will bring MAID up and offer it as an option to a patient, personally, as a physician, no. If the patient expresses to me that they wish to consider this as an option, I am happy to refer them to the MAID team. So I don't think, as far as I know, from my understanding, there is no obligation for myself to offer MAID as an option. There is a definite obligation for myself to provide that service and a referral to that service, not to provide the service, but provide a referral to that service should the patient bring that up. And that includes, I just had this discussion with our coordinator at the hospice yesterday, actually. So it doesn't matter whether the patient brings it up to a PSW, to a nurse, to a physician, to Anybody on that care team, to the RT, the OT, anybody on that care team, the chaplain, it's the responsibility of that individual to bring it forward to the physician, who is the most responsible physician for that patient. And then the physician should then move forward with providing the referral to the MAID team. We actually have a team at the North Bay Regional Health Center of 4 physicians who are experienced in MAID, and they are available on call 24/7. So whenever a situation arises, and then in terms of our patient at the hospice, I had the same discussion, which was it doesn't matter who the patient brings that up to, they should be provided with that service, a referral to that service by the most responsible physician.
And Michaela, I guess the other piece to add to that as well is just like Dr. Jenna said, certainly if the patient brings it up in terms of one of my visits, certainly it's my prerogative and my ethical standards that I need to be bringing that to the attention of the most responsible provider to ensure that there's appropriate referrals in place. One of the things that I'd like to stress is that the palliative care team, despite whether or not the patient chooses to have MAID or not, we will continue to follow all the way to end of life, no matter what, still providing quality palliative care, pain and symptom management. That's still part of what we do, despite us not actually providing the MAID service itself. And certainly, the other thing that I always sort of fall back on, because I have seen this quite a bit, and I think it's critical for people to know, is ask the questions as to why is the MAID conversation coming up. So you're asked, I think whoever posed the question was great and actually asked the question, where does MAID sit? I sort of asked the same question back to the patient and the family, if the family is there. Where does MAID sit for you? Why are you bringing this up to me? Because I think it's also important to understand the historical context of that, about why it's coming up, because a lot of the time, people bring up the MAID conversation because they are having unresolved pain and symptom management concerns. And so all the more reason to make sure that this interdisciplinary, multidisciplinary team that we are talking about has been involved in the circle of care, that they have all the right resources while still facilitating the appropriate education around MAID and the appropriate referral. Does that make sense?
Yeah,
okay.
Absolutely. Perfect. And Michelle asked, do you feel that complementary and alternative therapy approaches, for example, Aboriginal healing, Reiki, acupuncture, medication and meditation, visualization, breath work, etc., would be a suitable spoke component?
Ooh,
That's very interesting. Yeah, it probably would be. I think that's probably reasonable. We can add it to that spoke for sure, to that bicycle wheel for sure. It's interesting because I was just having a conversation with a patient a couple of days ago about alternative care, and the patient deals with, I don't know if many people are aware of Dr. Lacey Petrie, one of our oncologists in Sudbury, but she has a really good understanding of herbal management as well. And I think the biggest issue that we would have with that also is it's definitely should be a part of our care of the patient. I don't have any particular concerns about it as long as it doesn't impact on any of the medications or services that we are providing in terms of achieving the patient's goals of care. So I often have patients who are also doing some other type of healing, and that's just fine with me. I don't have any issues with it, and I don't think any other palliative care physicians have any issues with it, provided it doesn't impact something that is working well for the patient.
Mm-hmm. I think the other piece that sort of when I hear that, Michaela, as well, just talking about Reiki therapy, looking at Indigenous cultural beliefs and norms and practices, I often think of that falling into the realm of spiritual care as well. Because for spiritual care, it's so much bigger to me than just having sort of any sort of religious affiliation or typical practices. It's just talking about the whole person. And when you're talking about breathing techniques and Reiki and meditation and those kinds of things, that's very much a spiritual practice for many people. So we could do a little slash mark in spiritual care there and add those pieces in. It fits perfectly on the wheel.
I'll just add that I was saying to Monica when I met her this morning that I was listening to Darren, I think it was at the beginning, who was talking about looking at the care that we give through those lenses, and so much of that, and what Monica said about just being kind whenever we go into our care, whether we're speaking to the patient, to another physician, to somebody else on our team. And that's where I think a lot of that spirituality comes into play, is us exhibiting that same sense of openness and awareness and understanding that different people deal with issues in their life in different ways. And it's not my right or your right to tell anybody how they should deal with it. I'll just share a personal story. I have a cousin who passed away many years ago. She was young, she was in her 40s, she had breast cancer. She drove me crazy at the time because she refused to accept traditional medicine and went and did all these other things. And I think we had a few good, strong discussions, and I was trying to convince her that my way was the right way, but she chose the way that she wanted to go. And I don't know whether traditional medicine would have made a difference or not, but it did drive me crazy at the time, but I've learned from it. So yeah.
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 And then Anna, similar question to Linda's, what type of support would be provided if the client is in a rural area? Would it be them have transitioned to the closest medical or hospital facility or a long-term care with a palliative room?
So it really depends on where they are, and
Yeah.
we live that every day, right? In our communities, we have a lot of family physicians who do excellent palliative care out in the community. Sometimes if a patient lives in an area where it's more difficult to access some of the other services on our wheel and they really need those services, then we might have to look at transfers. And we have had patients who've come to us from other areas where they just weren't able to provide the level of care that the patient required. Maybe not medical care, but some of the other things. For example, the support in the home, or having the access to a dietitian or a speech pathologist, or so that's a really good. We have such a wonderful country, and it's so vast, and there are definitely areas in this country where people are probably going to experience difficulty getting all the areas on this wheel that are needed. And maybe in those situations, and sometimes it can be temporary, they can come to us and we can sort things out, for lack of another way of saying it, and then they can go back once we've sorted things out and tried to manage things. But I myself have had difficulties not that far away, actually, just not that far away from us here in North Bay, where we just don't have the services. We aren't able to provide the personal support. I can think of somebody maybe about 18 months ago. And then a lot of times people have friends or family members that say, oh, I am a PSW, I'll help out, or so it's a really good question. And sometimes we do have to help people access, and that's where the LIN component of our wheel becomes so important, because our care coordinators know all the options that are available and can sometimes help us to navigate what we need to do in order to provide the best care for the patient.
And creativity, right? Creativity in terms of having a case conference. Sometimes it's not a matter of having people tangibly in real time in the home if it's in these isolated communities, but it's having those case conferences to talk about creative solutions that maybe people have not thought about. Because sometimes when you're so invested or in a case for a particular period of time, to look outside the box is more difficult. So just bringing in those resources. I think the other thing that I'm thinking about, when I think it was Anita that you said had this question, is there's lots of people that I see sort of in isolated areas as the palliative pain symptom management consultant. And many of these patients may or may not have a family doctor. And that family doctor, if they do have one, or nurse practitioner, may also not have privileges at the hospital. And so if that's the case, if we're looking to see about somebody just needing some extra pain and symptom management supports, and they need that in sort of an acute care sort of setting like a hospital, to either optimize their care, get them medically managed, and then hopefully get them back home again. There is an option in our North Bay area where we've been very, very fortunate to have the primary care provider have a conversation with our palliative care team and say, hey, I've got to send this person into the hospital. Do you mind looking in on them, being their most responsible care provider while they're in the hospital, because they have a life-limiting progressive illness that they will eventually pass away from. optimize their care a little bit with the goal of going home. Do you mind if we work together on this situation a little bit just to see what we can do here? So that's available. And if people are wondering if their person would qualify for that, by all means, reach out to me on my cell phone or on the referral, and I'm happy to help support in that. We can have a conversation.
Awesome. Perfect. So there's quite a few more questions coming in, so I will compile them and send them off to you. And then when you get a chance to send me the responses, that would be awesome. Yeah, thank you very much for
just to thank everybody for giving us this opportunity and for listening in. It is, again, communication and collaboration is the important thing. Tara's given you her information. I think almost all the care coordinators and many of the nurses have my cell phone number as well. So I'm happy for people to get in touch with me if they have particular concerns or questions about care. We're here as a resource. Please don't hesitate to use us, even if it's just a phone call to say I have a question about something, or can you help me with navigating some part of the system. And we're all learning all the time. So every week, almost every day, I learn something about doing something a different way. So thanks, everybody. Thanks, Michaela.
Yeah, thanks, Michaela.
you.
Bye.
We'll go off to lunch there and reconvene at 1 o'clock. So yeah, have a good lunch and stretch break, everyone, and we'll be back on at 1 o'clock there.
So hello everyone, it's 12:27. Thank you for all of you who were together with us overtime for lunch. We are in lunch break now from 12 to 1. At 1 o'clock, we'll be back with Eugene Dufour talking about grief and bereavement support for healthcare professionals during COVID time. So thank you, enjoy your lunch. Hello, everyone. It's almost 1 o'clock. We will be introducing Eugene to the audience in a few seconds. So I hope you have had a good lunch break and you are now refreshed for an afternoon of support to you, healthcare providers all over the North. Here we are, it's 1 sharp. So Eugene, could you please unmute?
Yep, I'm off mute.
Okay, and have your camera on. So it's a real pleasure to introduce you to Eugene Dufour, who will be conducting our complete afternoon now. Don't forget that there will be at 2:30, right, Eugene?
Yep.
And he will resume at 2:45. The end of the conference, Eugene will be wrapping up at 4:15 maximum, so that the audience has a time to respond to the conference evaluation. There you are. Hi, Eugene.
Hello.
So it's important that you, our participants, respond to the conference evaluation. It will be online. It's very simple, less than a couple of minutes on Zoom. Do not put your webinar off. At 4:15, we are going to bring to screen the evaluation of the conference. And those who respond, we will be raffling a few fabulous prizes for those who respond to the poll. So with no else to say, it's really a pleasure to have you with us, Eugene. And I would like you to introduce yourself to our audience today. Talk a little about yourself, and the floor is yours.
Okay, thank you very much, and thank you for this wonderful invitation. And it's such a timely time with the height of the second wave. And I was at a Zoom meeting with some healthcare officials, and they talked about the third wave, and I almost got sick to my stomach. Just the thought of that, because I'm getting really tired of the second wave. So we'll just talk a bit. The first part will be on kind of self-care, and the second part will be on complicated grief and what we can do around this aspect. So I'm living in Bayfield, Ontario, which is near kind of Goderich on Lake Huron, and it's the sacred land of the Huron in Ojibwe. And so I acknowledge that land. And the reason I acknowledge it is I've done a lot of soul searching. I've lived a privileged life. I'm white, I'm male. I had a chance to go to university. I've never seen poverty. I've never been unemployed. I've never really had any significant trauma. And as a result, I just lived, and again, never seen war. So lived that very privileged life. And so I did my BA in the late 70s and a master's degree in the late 80s. And they were very much focused on social justice courses. And I never heard of the plight of our First Nations people until just recently, when I became interested in the truth and reconciliation. And so my acknowledgement comes as a reminder to me to keep my foot on the pedal, to keep on addressing these issues of systemic racism and just the historical abuse that is going to take years and years to heal. And you know what we're now learning about the residential school system is that what they know of, about 3,000 children died, many of which they never got registered. Families don't know where the child was buried. So from that, I just learned so much about my unconscious bias. And so I acknowledge the plight of our First Nations brothers and sisters, and a continued belief to include our LGBT two-spirited brothers and sisters, that we keep looking at our unconscious bias and making this a welcome community for people to live in. So right after I graduated at university, I was hired by St. Joseph's Health Centre in London, just when the AIDS pandemic hit. And I had 70 young men on my caseload, and 9 months later, I had a new 70 names. We had no antiviral drugs. You had one shot at ICU, which was always a disaster. And it was just devastating for people and for staff. So from there, St. Joe sent me away to do some advanced training on critical incident stress, debriefing. And at that time, it was mostly meant for first responders. And over the 30 years, I've kind of been adapting it to hospice palliative care. So I'll include a lot of kind of the debriefing techniques that we've learned around that. So I worked at Stratford General Hospital, running their palliative care program for 20 years. I was at Canuck Place Children's Hospice for a bit. And then I've been working at a family health team for about 10 years. And just the last 3 years with a palliative care outreach team in Huron and Perth County. So there's about 140 people dying in Huron and Perth County at home. And I get to visit them in their home, do life review, prepare them for that, journey from this life to the next life, however they see that. And it's such beautiful work. I kind of feel guilty for getting paid. So that's sort of the background that I come from, and providing that kind of information and dealing with that aspect. And what had happened is once I got the kind of debriefing experience, a lot of the police officers and the OPP would drive by the hospital and say, "We have to do a death notification. Can you come?" And so I do a lot of death notification training for our police departments throughout the province. And I include that because I've just learned so much about that. And I think that's what my whole focus is before I go into a client's house or room, or before they come into my office, I always ask myself, what am I here to learn? And instead of coming like this, it's like this. And it just, that lifelong learning process is so important in dealing with that aspect. Okay, oh, there we go. So I have no conflict of interest. I'm not sponsored by a drug company. However, I did have some kidney stones a number of years ago, and I got put on some Tylenol 3s to kill the pain, and I liked them. They should make those in a 6-pack. I hear they do, but not that interested. I still have a large mortgage. I live in a trailer park. It overlooks the Bayfield River, so that's the only way I can afford looking over a river. And I have 2 boxes of Kraft Dinner in my pantry. So there's absolutely no conflict of interest. And as you can see, I have a very weird sense of humor. Okay, so this will be the first section around that. I love this quote. "We in the care partnering community frequently encounter people with life-threatening illness at a point when they are no longer who they have been and are not yet reborn into who they will be. We meet them in a place between no longer and not yet." That is very difficult for the people that we walk with, but exceptionally difficult for ourselves. And not too much attention has been put on ourselves that this is a difficult journey. And if one thing the pandemic is, it has highlighted the plight of our PSWs, our nursing staff, our kitchen staff, our cleaning staff, anybody that's in long-term care, retirement homes, hospitals, in the community. This is tough slugging. And especially when you're doing community work and long-term care, they don't long become clients, they become family members because of the times that you spent with them. So we really need to honor the space between no longer and not yet. What I will do is I will take all the pictures out of this presentation and send it to Monica, and then you will get a copy of all of these slides. There's quite a few of them. I don't plan on doing all of them, but I will make sure that you have a copy so that you don't have to write these down in dealing with that. Here's another quote that I love by Parker Palmer. He was a man that's just dedicated his whole life to educating educators. And he says, "One of the hardest things we must do sometimes is to be present to another person's pain without trying to fix it. To simply stand respectfully at the edge of that person's mystery and misery. Wholeness does not mean perfection. It means embracing brokenness as an integral part of life." Misery and mystery. Our society is pretty good at focusing on the misery of the plight of people, especially if they're having life-threatening illness at this time of COVID-19. but we don't spend much time about the mystery. And when I say the word mystery, I mean, how has the misery affected meaning and purpose? And so I'm hoping that this next couple of presentations will be helping all of us to address how do we, the impact of the misery that we witness and that we're experiencing, affect our meaning and purpose as we deal with this many aspects of it. Before we go any farther, it's really important to talk about trauma-informed care, so that it just really provides some really good care for our clients, family members, and ourselves. So much of the stuff that we're talking about is going to trigger past wounds that we may have, and that's really important to be aware of. So if the presentation gets a little too heavy, feel free if you need to take a break. Or if something is triggered, I really invite you to send me an email or give me a call if you just need to talk through it. I think I make that commitment that if anyone's triggered by some of this stuff, that you have someone to talk about that. And I'm home all weekend. I live on my own, so I wouldn't mind the break and the boredom. That's really important. So, even our programs, the more that we can realize the wide impact of trauma, to recognize the signs, and to respond in a way like all about our policies and procedures, but also the way that we provide care, and that we make sure that we don't re-traumatize people. I'll give you an example of how I changed my practice when I worked at the family health team. I have an emergency buzzer, so if ever a patient is out of control, I just press the buzzer and everybody comes running. And I rarely explain that to people because I've changed how I use that buzzer. So when a person comes in that's dealing with the trauma, and it's pretty well all the clients that I would see, I would put the buzzer beside them and say, if you ever feel unsafe, all you need to do is just press that buzzer. And this is what's going to happen. 4 nurses, all of our nurses here are female. All 4 nurses are going to come in. They're going to ask me to leave, and then they're going to talk to you to make sure that you're safe. And I cannot tell you the impact that had in creating safety around that. A simple thing like that. In the 10 years I was there, it was used twice. Once because a woman had a panic attack and she felt that she was going to pass out. So she didn't want to feel unprotected, unconscious. So she wanted other women around. And another had a diabetic reaction around that aspect. So, and then the main thing is that we don't re-traumatize. We don't need the people to retell their story. As long as we're aware that they're dealing with the trauma, that's the important aspect of it. So the components of that trauma-informed care is make sure you're creating a safe environment, supporting and teaching emotional regulation. I'll talk a bit about that later. And the main thing is building relationships and connectedness. And this is where you folks are expert at that. That's sort of a hallmark of hospice palliative care in dealing with that aspect. So these are these kind of resiliencies, the core principles. So one of the techniques I use, for example, is when someone is really struggling, I'll ask them, if there was a wise man, or if it was a woman, if there's a wise woman inside of you, what do you think that they would say in order to get you to cope with this trauma that you're dealing with? And, there's usually a pause, and then eventually they start talking about that wisdom, and then they realize that wisdom comes from in. The other powerful experience I had is about a year ago. A client that I was visiting in her home, she's blind. She's been blind her entire life, and she went to the school for the blind and was horribly sexually abused for numerous years. And she now has advanced bowel cancer, and she wants to let go of that before she dies. And I always have to double check myself, because before I go in, I find myself so angry that at 88 years of age, she needs to do some sexual abuse counseling before she dies. But the instruction she gave me, she goes, my doors works connected to my computer. So all I ask you is you knock and wait, and eventually I'll get the door opened. So I did, and it took quite a while. I was about to pull out my phone and call, but I remembered her saying, just wait. And then when I did get into the room, there was 2 chairs. One that was fairly close to her wheelchair, and one farther away. I think by luck, I chose the farther away, maybe because of the COVID restrictions. I'm not sure. But after about 2 or 3 sessions with her, I was so moved that, why are you trusting me? And she said, well, first of all, you listened about those instructions. And secondly, when you came in, you really respected my safety by sitting farther away around that. And thirdly, I really trust the home care manager and her assistant, and they've been trying to sell me you for about 6 months. So that just reinforms team, and that we really need to focus on the little things that are important around that. So just to tell you another experience that I'm coming back from, I'm just recently back from a compassionate leave program. This is my dad. And so I spent 6 months with him. He was diagnosed with lung cancer. He was 89 years of age, a young 89, still going to the gym, and he couldn't bench press as much weight as he used to. So he thought something was wrong. And I said, Dad, do you think maybe it's because you're 90, 89? No, there's something wrong. And sure enough, he knew his body. He had that. So this was one of his meals that he loved, that pound steak that tastes god awful, but he just loved it. And so having that opportunity to them, just spending a lot of time, we can never underestimate the power of our presence. He wanted to die at home, and I have 3 sisters, and we were going to make that happen. That was so helpful. He had this beautiful patio door that he loved to look out. The cancer spread to his spine and severed his spine the last 8 weeks, so he was paralyzed from the waist down. And he had created this little altar. I'd get up at 5 in the morning, and there he would be, often just thinking, many times crying, and just respecting that space, how important that was for him in dealing with that particular aspect. We did these pictures, that's my 3 sisters and my dad in my hands. I really encourage you, when you're doing work with palliative care patients, to invite them to take pictures of hands. This can be such a great piece of work, of remembering, of legacy work, that's really helpful to do around that particular aspect. And then the reality of after he had died, that the emptiness of what you felt. And my mom died when I was 19, and I was shocked that much of the 6 months working with my dad was a lot of reworking my mom's death, and that was a really good learning lesson. So when we're campaigning people, be aware of past losses that may need to come up, that may need to be reviewed. That's so important in dealing with that aspect. My dad worked for the city hydro, and he was retired 30 years, and we had a steady flow of even current hydro employees coming to visit him. So that was his boots and his helmet that were just such an important part of his life around that. So when we came out of the church after his funeral, there was his hydro workers. They had the 2 trucks and a form of honoring the work that he did, which was an incredible experience. So if you have a loved one that's been diagnosed terminal and you're debating compassionate leave, I really struggled. Like, do I wait and go when I can really do kind of the physical care, or do I go early? Listen to your head and your heart. I went early, and it was the best thing I could have done, because I had 3 or 4 months when he was really feeling good, that we were able to talk about a lot of things. So we know that we grieve in the past, the present, and the future, and so it's important to be aware of our past losses in dealing with that particular aspect. So I got to do this for 6 months, and I felt guilty leaving my team. We had a heavy caseload at that time. I wasn't replaced, but we got to put ourselves first, and we got to put family first. And my team was fabulous in allowing me to do that. Frank Ostastecki has this wonderful book called The 5 Invitations. And they're this. First of all is don't wait. So I think even about our self-care, don't wait. Welcome everything, push away nothing. There were so many times that we wanted to avoid certain issues, and this is the time to pull out all the stops. So that's important. Bring your whole self to the experience. We're a house of 4 rooms, an emotional, a physical, a social, a spiritual. And even if we need to go into all of them, even if it's to air it out or we're not whole. And then find a place to rest in the middle of things. That is so an excellent message for us daily to do, finding that place of retreat. And then cultivate, don't mind. It's just a wonderful approach to take that I'm here to learn, and what can I learn around that particular aspect. So this is my granddaughter, Julia. This is taken a few years ago. And while she was doing this on the floor, I said, Julia, what are you doing? And she goes, I'm French, so I'm a Pepe. She goes, Pepe, I'm practicing to be just like you. So yeah, I'm working on the diet. It's going to take a while. You know, we just weren't prepared for this level of suffering. That whole aspect of what we're seeing around COVID-19. And I've worked with about 30 long-term care facilities throughout Ontario and 5 in English-speaking Quebec, where they've just been so devastated with the losses. And the main thing is that when families would say, the thought of you dying alone haunts me. And that's where we were just working hard to getting the message across that if there's one thing that we were dedicated to doing is making sure people weren't dying alone around that aspect. So we know that we have beautiful deathbed rituals in our hospices, long-term care facilities, retirement homes, even in hospitals. And we were doing these beautiful, rich things. And then COVID-19 hit. And we had these kinds of experiences around that particular aspect. I remember one hospital, right in the early wave, they weren't allowing any clergy person to go into this hospital. And 2 ICU nurses called me and said, we got 4 patients. They want the last rites, the sacrament of the sick, and we can't get their ministers in. What do we do? And I have to know both of them. Both of them were of the Christian faith as well. You know, by right of your baptism, you share in that kind of priestly ministry of Jesus. So I'm going to teach you how to do anointing. Well, we can't do that. I said, yes, you can. And the way you do it is that you're doing it on behalf of the family, on behalf of the clergy that can't be there. And it was just some real powerful experiences that were really helpful. And we just really had to start thinking out of the box around that aspect. I love this quote. When we're tired, we are attacked by ideas we conquered long ago. And again, that is so important to be aware of when we're looking at self-care. That's why it kind of pops up and just sits on our shoulder. So often there's that saying, emotionally I'm done, mentally I'm drained, spiritually I'm dead, but physically I need to smile. I need to keep on going. And I love that other quote, that sleep doesn't help if it's your soul that's tired. And I'll talk a bit more about spiritual care around that particular aspect. So yes, during this presentation, if you have some comments, questions, put them in the message box, and we'll be looking at them, and then we'll be addressing them at the end around that aspect. Pema Chodron is this Buddhist priest that has this retreat center just outside of in Nova Scotia. And she says, the truth you believe and cling to makes you unavailable to hear anything new. And that was so powerful for me because I'm constantly becoming more aware of my unconscious bias. And the more that I do this, the more I have that kind of approach to life learning that's really helpful. I went to one of her retreats at this retreat center. It was an 8-day silent retreat. So they would do like 3 or 4 lectures a day, and the rest was in silence. And then they would structure you to have these periods of meditation. Well, one of the meditation periods was at 4 in the morning. Well, there was no way I was getting up at 4 in the morning to meditate. But I tell you, these little monks, they were determined, and they got you up at 4 in the morning. And I was shocked at how rich that was. And it has to do with the meridians of the body and the chakra centers. And it was another aha moment, because a lot of the bereaved parents I work with, if they couldn't sleep and if they were on sleeping medication, I'd say, well, break your sleep medication in half and take one when you go to bed and one you wake up at 4 o'clock. And now I say to them, if you wake up at 4 o'clock, just set your timer on your phone or on your clock and for an hour, and just do kind of your due diligence and think about your child. And often they will get back to sleep, and it's changed their lives around that whole particular aspect. So this is where that comment of being a house room, a house of 4 rooms. And, unless we go in every room every day, even if it's to keep it aired, we're not a complete person. So the mental room, some type of reading, 15 minutes each day, focused on learning something. The emotional room, monitoring your thoughts and feelings. The spiritual room, being still. And then the physical room, taking care of your body. So the first 3 are, we are people that need to reflect. And fitting that in is so important in dealing with that particular aspect. So just to talk a bit about burnout, secondary trauma, vicarious trauma, and compassion fatigue. So burnout is that term that describes the physical and emotional exhaustion that workers can experience when they have low job satisfaction, feeling powerless or overwhelmed. And that could be just because of the incredible caseload. Secondary trauma is defined as indirect exposure to trauma through a firsthand account. So when you're doing your home visits, when you're working in the hospital, the long-term care in the community, and you see people suffering, that would be indirect exposure. And much of our society says, yeah, but you healthcare providers are trained for this, so this should be a piece of cake. And it just doesn't work that way. So that would be secondary trauma. Now, I thought vicarious trauma was the same as secondary, and it's not. Vicarious trauma, it has a deeper effect where it really creates a profound shift in our worldview in helping professionals. And that's the important aspect of it, is that it's so strong that it's changing how we are and how we view the world, which is really important. And then the final one is that compassion fatigue. And that refers to that profound emotional and physical erosion that takes place when helpers are unable to refuel or to regenerate. And then copied to this would be if about 30% of us have experienced a trauma, whether we've worked it through or have completed the work, and it's really never completed. We always need to go back and review it. So that might be a backdrop of this. But what I really wanted to focus on was compassion fatigue. So here is the description of it. But it's the words that I've put in bold. The most insidious aspect of compassion fatigue is that it attacks the very core of what brought us into this work, our empathy and our compassion. And that's why it's so hard to bounce back from compassion fatigue, because it attacks that real core, the core of who we are. And, we need to be honest with ourselves. This work is not a job. It's a vocation. It's part of our DNA. And so when it attacks the compassion fatigue right at the core of what we do, that's why it can be so devastating around that particular aspect. And here are just some of the symptoms around that. I put in a lot of slides so that you can review them afterwards. So just wanted to talk a bit about the 2 different types of stress. And this very much connects to that aspect of it. So the routine stress, which is like 0 to 6 on the stress scale. And then traumatic stress, which is like 7 to 10. We all have a psychological coping container, and whether your capacity for containing stress is small, medium, or large, everybody has our limit. So the stress goes in here, and then we have that particular limit. Well, traumatic stress or secondary or vicarious stress, it's often too intense to handle. So that goes right to the bottom of the container and kind of stays there and just bubbles away, where we've never been encouraged to deal with that traumatic stress. It's part of your job, the incredible amounts of suffering you witness, and so it just kind of stays there. So what we often do is we compartmentalize for long-term storage. And as a result, it just doesn't heal and it remains painful. And that's what makes that very difficult around that aspect. So with routine stress, with enough time, it usually evaporates. It works its way out, but that traumatic stress is still there, kind of percolating away. So too much stress too soon leads to overspill or loss of containment, feeling overwhelmed. And here's the kicker, is that often this too much routine stress really feels traumatic. And that's when people say they kind of hit the wall around that aspect, which makes it really difficult. So there are a couple things we can do. We can kind of boost our capacity and speed up offloading. So, really good physical care that can be really helpful in dealing with that particular aspect. So when I worked in Stratford, it's an hour to get to Bayfield, and Mitchell, the town of Mitchell is about halfway. So work got me till Mitchell. And then as soon as I hit Mitchell, I'd had to do something very drastically different. So I would, work no longer has me. I would pop in a CD. It was either John Denver or the Doobie Brothers. It depends what mood I was in. I would have to turn it up quite loud just to make sure I get those stories out of my head. And then I start kind of offloading a lot of that, what I've been carrying. And then when I get home, there's this big maple tree just outside my door. And as I walk by, I give it a good whack. And I put everybody, every case, every client, family member on the tree with a promise. I'll pick you up in the morning. I just need to leave you here. And that was a really helpful kind of ritual for me of making that transition from work to home around that. So when I started working virtually, I didn't have that. And soon it was like 7 o'clock at night. I hadn't done any charting. So I reinstituted that at 5 o'clock. I had a little timer that went off, and I would go and I would whack the tree. And I didn't realize I had a neighbor looking. He came over a little worried about me. He said, kind of concerned, I think you're losing it. 5 o'clock, right on the dot, you come out and you whack this tree. I got some big concerns. And so it was just very funny. Then got a chance to explain that ritual. So there's a couple of ways also to heal that, to clean out the container. So I've been very fortunate. I've always worked for an employer that had an employees assistance program. So when I was at Stratford for 17 years, I had the same person twice a year. I would see her whether I felt I needed it or not. And I was amazed at the times that I needed it the most I was not aware of that. And she was able to pick that out. So, using that, our EAPs, getting counseling support is a real sign of strength, not a sign of weakness. And we still need to battle that and share about that. That can be really helpful in dealing with this aspect, because our colleagues can help, but you really need a kind of a familiar stranger that can work with us on some of those issues. This is a very important slide. So many of us have had jobs where we felt like we were rusting out. It was just not challenging. It wasn't using our skills or gifts. And we kind of felt like we were just bored. But then there's that comfort zone. And most of us really work well in that comfort zone. Every once in a while, we get tasked with something that is a bit of a stretch. And that's really good because it gets the creative juices going. It gets some affirmations that, wow, when I'm challenged, I kind of rise, I can do really good. But it's important that you bounce back into the comfort zone. You can't stay in the stretch for 1 year straight. And that's what we've been doing with COVID-19. We've been in the stretch, the strain, and the overwhelmed part of this diagram. And I'm guessing that because of the vaccine difficulty and because of the variants, we're probably in this for another year before people are really feeling safe. So this is even going to be longer. And that's why it's so important that we be very intentional about self-care programs on an individual level, on a team level, and on an organizational level. Because this is what happens. It's this zone of disillusion or delusion, and it's really hard to kind of nail, talk about that, name it, and then do something about it. So this is just a really good slide so that we stay out of burnout. You know, another good analogy is when the power grid is really stressed, so when we have those real high heat waves and there's just not quite enough electricity to go around for the province, they have two choices. They can put an area in blackout so that, let's say, Mississauga is not going to have any electricity for 2 hours. Or they could do what they call a brownout. They reduce the power to everybody across the province to 80%. But what they don't tell us is that that's very hard on our appliances, that the motherboards and all those really tend to fry when you only do 80%. I thought, wow, that's a good metaphor for us, is that when we're stealing energy from one area and putting it to the other, we're not really addressing those particular issues. So in normal stress, you have the event, you kind of reach your peak, and then you have that recovery period. Well, this is what's happening in COVID-19. We're having an event, first wave, second wave, now they're talking about a third wave, waiting for all the vaccine. And then this recovery period then takes much longer. So that's where we're having to be very conscious of how are we going to cope with this recovery period and this around that particular aspect of it. When I did all the debriefings for the nursing homes in the first wave, what the feedback I got was they were already short-staffed, and when the pandemic hit, they lost about 30% of their staff. Many of them felt they had small children or partners that were immunocompromised, and they just couldn't risk doing that work. And again, that was just a really powerful experience of just a system that was so stressed out around that, which really affects our meaning and purpose. So meaning is an internal motivator, where purpose is an external motivator. So for me, like, compassion is a really big internal driver for me. So that gives me a great sense of meaning. And so how do I do that? Interpret that in a purpose. So I volunteer for a food bank in the area. And when I offered, they said, oh, great, you can be on the board. You can do all the public relations. You can teach all about. No, I want to be in the back of the warehouse and I want to pack boxes. That's what's going to give me purpose around that aspect. So meaning is value that we place on things from an internal perspective. And purpose is the value that we receive from an external perspective. So meaning is that internal push, while purpose is the external pull. So my question to you that I'd like you to reflect on the weekend is, how is misery affecting your meaning and purpose? How is the suffering that you're seeing and maybe not having the ability to connect to the mystery of it affecting your meaning and purpose around that aspect? This was a very powerful experience. A debriefing I was asked to do, mom and a daughter. Mom was about 55, daughter was about 26. They were driving in the country. They were going to go shopping, and someone ran a stop sign and hit them broadsided, and they were thrown into this cornfield. So the fire department came. It was a volunteer fire group. So they pulled the 26-year-old out here, and it was a new firefighter that was just been on the force for about 3 or 4 months. He noticed that she had vital signs absence. So he unbuttoned her blouse and started to do chest compressions. When he unbuttoned her blouse, he saw breast pads. And so he then looked back here and saw a baby car seat. So he told his buddies, there could be a baby on board. The 26-year-old mother came to, and she said, yes, she has an 8-month-old at home, but it's at home with her dad. So when I did the debriefing, there was the 30 firefighters that were there, and this guy's wife. And she said, I'm not leaving until you tell them what you're doing. And what he was doing is he was getting up around 2 in the morning and driving out to the cornfield and just kind of sitting there. He wasn't actually going into the cornfield. The wife was worried that he was going out there to search for this baby. So the fire chief said, okay, get in the car, I'm taking to the hospital. I said, well, just wait a minute. Can you just tell me a bit more about it? And what it was is that he had a 4-month-old at home. And this was a huge crisis. His misery was the crisis of meaning and purposes. How am I going to keep this little 4-year-old safe? How about if this happens? The what ifs, the ruminating were just causing him so much suffering. So I said, is there anybody that's kind of working in the same shift as his that can meet him, let's say at Tim Hortons at 2 o'clock in the morning and then drive out to the scene? So 2 of his buddies said, yeah, we'll do that. So for 3 nights, they would meet at Tim Hortons, jump in one truck and just go sit outside the cornfield where this accident taken place. And then the next 3 nights, they would go into Tim Hortons and have a coffee and then go out. And then the next week they were going like at 8 o'clock at night, having a coffee and then just going back home. So what he really needed was to have somebody walk with him to sort out this meaning and purpose around that. And as soon as the community found out what they were doing, the first responders community, when their truck was parked outside the site where the accident happened, an OPP cruiser would just park about 20 feet behind them and just wait, almost like a sentry. And they got so much support from that, around that aspect. So that's a good example of how the suffering we see can really affect our meaning and purpose. I throw this in because you really need to spend some time looking at that. The knowledge of self, recognizing our emotions, the suffering, and here's the answer. It's this human connectedness. It's this connectedness that's going to allow us to reach out from us to soothe the suffering, to be with them in the suffering. So, and I always say to our caregivers, never underestimate the power of your personal presence. People don't need us to do anything or say anything. They just need us to be there, and how important that is. Dr. David Kuhl, palliative care physician in Vancouver, with the hospital system there, says relationships and independency is what people need. A dying person wants a sense of connection to themselves, a connection to those they love and who love them, and a connection to something greater than themselves. And I'll talk a bit about that one later. So my question to you is, as you are witnessing so much suffering, how is that affecting the connection to yourself? How is it affecting the connection between the loved ones and the people that love you? And then we'll talk about our vital breath in a bit. So dealing with normal and traumatic stress, I think it's really important to have a really practical self-care plan. And we need to be intentional about the self-care plan. Like I said, once I started working virtually, I thought, I usually spend about 3 hours on the road a day. And I thought, I'm going to have all this extra time to see people virtually. And next thing you know, it's 7 o'clock at night and I haven't done any charting. So I set the timer on the clock on the stove so that I have to physically get out of this chair and go shut it off. And that's my message, that your day's over. And that's been really helpful around that. So daily assessing your normal and traumatic stress, that can be important. Finding a mentor. I think our nursing groups have been so helpful. The role that you have on mentors, and training people that are coming up in the nursing profession is so important. And therefore also like being a mentor around that. Creating a natural support group. So one thing that our team has done is we pick a journal article. One person is in charge with picking an article no more than a page. And then on Wednesdays at lunchtime, we do a phone call in and just talk about it. And that's been a way of connecting around that aspect. So working on traumatic stress really does need a coach around that. So here's some of the techniques that we can use that are really helpful. So this is called the window of tolerance. And what's great about this is that we all have this window of tolerance, and it's our ability to self-soothe, to regulate our emotions, to be in that comfort zone. But every once in a while, because of a number of things that happen, the pandemic, it throws us up into the fight or flight. The little part of our brain called the amygdala, it's called the emotional hijack. And it's built there as a protection that when you get into fight or flight, all the blood gets taken out of the brain and in the extremities, goes to the heart to get ready for either a good fight or a good flight. So that's what happens when we get hyper aroused. The other response is the freeze or fade. So you faint, a death response, you dissociate, you're just not present around that aspect. So you just feel really disconnected. And what keeps us in our zone of this whole aspect of window of tolerance, it's this stuff here: mindfulness, sympathetic breathing, all those kind of grounding exercises that are so important in dealing with that aspect. And it's that simple, that this mindfulness really keeps us regulated. Just another less busy way of looking at the hyperarousal and hypoarousal and the window of tolerance. So I have about 30 copies of this in my car. I give it to all the clients I work with. This square breathing reprograms, it reboots the brain when it goes into fight or flight. And it regulates us to go back into our window of tolerance. That's why this is so helpful. And where this got developed was with the Navy SEALs and the Canadian Special Forces. So it's backed in all kinds of research where it really reprograms the brain to get out of fight or flight around that. So when you notice in the Navy SEALs movies, when they go and do those rescues and shoot 'em ups, it's 4 paces, stop, 4 paces, stop, 4 paces, because it's all regulated to the 4-4 breathing. And so I've been doing this for a couple of years, and it's now coming natural. So if I get behind a school bus, I immediately stop, and I'm automatically into square breathing instead of getting worried that I'm going to be late for an appointment. So that makes that really helpful in dealing with this, because with the trauma in the brain, so the trauma is dealing with COVID-19, dealing with all the fears that we have. 80% of the nerve fibers go from the body to the brain. And it's 20% go from the brain to the body. That's why it's so important to be aware of what's happening in my body. Why am I feeling so tensed around that? I had a very crazy experience a couple days ago. Somebody called and they asked for my phone number, address and phone number, and I gave them my childhood phone number. I haven't used that phone number in 45 years. Where did that come from? And when I reflected on it, it was pretty close to my dad's birthday. I hadn't been spending much time thinking about him. And it was just kind of a little tap on the shoulder to say, time to remember, and dealing with that aspect. Because when we're in our heads, then we can kind of be in that woundedness where we're kind of numbing. We might be avoiding emotions. You're thinking through. But if we're working it through our body, it's that float of feelings. We're mastering emotions. We're feeling through, not thinking through, and we're really focusing on presence. Not so much worried about what people are thinking, but what I am thinking. That can be really helpful in dealing with that aspect. This is another technique from cognitive behavioral therapy: wise mind, emotion mind, logical mind. And this is another way of describing it. And we use all three. It's important. But if you ever have had an argument with someone who just stays in reasonable mind or in emotional mind, it is very frustrating. So that's where constantly allowing yourself to review it emotionally, rationally, and then go into wise mind. So spend some time looking at this, and there's some number of really good YouTube videos on wise mind and on the window of tolerance that can helpful. Find a hermit spot. So I used to live in St. Mary's, and this is a bridge that was a railway trestle, and the railway sold it for the town of St. Mary's for $1, and a service club made a walkway over it. So I often sit here and reflect, okay, what are the pillars holding me up? What are the pillars supporting my work? What are the pillars supporting my journey through misery and mystery? Do the pillars need to be shored up? Do I need to change the pillars? Again, we're people that need to reflect. That can be really helpful. So it asks us that question, is it a mindful, or are you being mindful? Which is so important around that. Developing some kind of morning ritual of kind of listing your core values, identifying an intention for the day, a daily affirmation. Today, I get to instead of I have to. One thing I will do today just for me is, one thing I'm grateful for, and one thing that caused joy. Spend some time creating your own kind of little morning and evening ritual. This just gives you an idea of what you can put in, which can be really helpful. I had a supervisor say to me once, if you can't say no, how good is your yes? And that really sent me on my journey, because I rarely said no and said yes to everything. And a lot of things were getting watered down. And that really helped me focus around that. So with sympathy is, I see that you are hurt. And many times the work that we do calls for a sympathetic response. When I hear of an earthquake in China, I see that people are hurt. Empathy is, I see that you are hurt and I really do care. But compassion is, I see that you hurt, I care, and I'm called to do something about it. That's what makes the work that we do totally different, is that we are called to do something about the hurt. But there's a cost to that hurt, and that's what we have to be aware of. So sympathy drives disconnection. Empathy kind of fuels it, but compassion creates connection around that. So I rarely, say my deepest sympathies, or that's just not a word that I use helpful around that aspect. So making sure that we got some really good self-care during COVID-19, recognizing and validating the grief around that. I've just been in touch with so many families that had to say goodbye to their loved ones virtually, and how difficult that was, and doing some of that complicated work that is really helpful in dealing that aspect. Recognizing, separating what you can and can't control. So for the first part of the first wave, we were fighting with hospital administrations to, no, you got to let these family members in. And we realized this is the wrong approach. There's not going to be any change here. And so our CMHA went out and bought 100 tablets, Samsungs, like $100 each, and gave them to their clients so that they could communicate. That was something that they could control, that could be really helpful in dealing with that particular aspect. So the 4 quadrants of self-care are, before having kind of a transition to work, during, trying to stay present and grounded, that can be really helpful. Having a mantra. So whenever I'm in a difficult situation, I just have this, you can do this, you can do this. That makes it really helpful. Right after, having kind of that transition to work, and then afterwards. So this kind of 4 quadrants is a good thing to look at in dealing with that aspect. So I'm not your typical male. Power tools scare me. NASCAR makes me dizzy, so I don't watch NASCAR. And I ask for directions. So I built this desk. I had a chance to write a book in palliative care, and this is where I did most of the writing. So I didn't lose any fingers. I did break one golden rule in do it yourself. I cut into the power cord of the circular saw. So I just wasn't paying attention, and it grabs the cord, pulls it out of the extension cord, comes whipping around and nailed me on the head. So I had to get to Clinton and get 4 stitches back home clean up before anybody knows about it. So nobody does know about it. It's our little secret, and we've got to stay there. But this has just been a helpful place just to go and reflect and be there. So again, find a hermit spot. I love the sponge analogy. When you squeeze a sponge, it has that ability to absorb water and squeeze out. But if you leave it in the water too long, it dries up and it loses its ability to do what it's meant to do. So we need to pull ourselves out of the water, out of the intense work that we do, put it aside and really kind of rejuvenate. And more so now that this second wave and the third wave is going to be with us another year around that. You know, some of our nursing staff that are being asked to be deployed back into nursing homes, you know, I'm really telling them, you know, be careful if you're doing a second or third employment that if you step back, it'll challenge other people to do that around that particular aspect. And I love this by Brene Brown. Of all the things trauma takes away from us, the worst is our willingness or even our ability to be vulnerable. There's a reclaiming that has to be happen. And I think this is where, you know, I always say a family member never forgets a nurse that cries. And it's very, very appropriate that we show emotions, that we become vulnerable, because that's often what's going to make really people be able to cope with some of the stuff that they're doing. We had a mom that was dying of stomach cancer. And so we had worked with the family, and this were her two little kids. About 3 years after she died, the little boy developed the same type of stomach cancer. And his great wish was to meet Hulk Hogan. This is a number of years ago. I had no clue who Hulk Hogan was. I thought the WWF was the World Wildlife Federation, and I thought it had to do something with Disney. So we contacted Hulk Hogan's agent, and Hulk Hogan's agent said, "I'm sorry, Hulk Hogan's too busy to deal with this." And we were devastated. But there was a firefighter in Kitchener who used to be a wrestler, and he knew Jake the Snake. I love these names. So Jake the Snake called Hulk Hogan and said, "Oh, I'm going to be in Toronto in 3 weeks. I'll send these family tickets." And so they were staying with the mom and dad, or the grandma and the grandpa. Dad had a complete nervous breakdown and was at Homewood for almost a year after his wife died and when he was diagnosed. So we did some fundraising, got a limousine that took them, these two and the grandmother, to see Hulk Hogan. And they get into the back way so they didn't see the marquee that said that they were going to a wrestling match. And they get into this room, these 4 big bouncers come up and they say, "Are you so and so and so and so?" Little kids are bouncing their heads, and they said, "Okay, come with us." And they bring them in and they get to meet their hero. And you know, he's 6'8", about 380 pounds. I didn't think this was going to really work out, but he was just a gentle giant, and sat down with them and talked with them. And then he said to them, he said, "You know, I'm going to be fighting Sergeant Slaughter." Again, I love the names. "So if I get knocked down, you guys got to yell as loud as you can, get up." So they get, of course, they had ringside seats, and a bunch of us had bought tickets and rented a bus. And so we were up in the nosebleed seats watching this. And so sure enough, in the kind of the last few minutes of the major round, Hulk Hogan suffers a massive blow to the head and is knocked out cold right in the corner where these two are sitting. So they're yelling, "Hulk Hogan, get up." It's the 4 count. It's the 5 count. "Hulk Hogan, get up." It's the 6 count. It's the 7th count. The little guy jumps out of his seat, runs to the ring. He's banging his hands on the ring. "Hulk Hogan, get up." And Hulk Hogan comes to his senses, gives him the thumbs up, goes on to win the match, and restores my belief in WWF. This little guy was so sick, he died 8 days later. And I show this picture because the promoter and his assistant, they're doing what they're trained to do. They'll always look at the camera. But Grandma was kind of standing back here, and she always played the role of the cheerleader through this. And I think he knew he was that sick, and in many ways he was starting to say his goodbyes. But what blew me out of the water was this guy here, that appreciative gaze to Grandma. And so I asked, your appreciative gaze in the work that you do, is the demands of the work, is the the incredible amounts of suffering you see affecting your appreciative gaze, so that we don't turn our head to the cameras, but we look at the clients that we work with in dealing with that aspect. I had, again, a real powerful experience a couple Christmases ago. A 10-year-old boy, an 8-year-old boy, his 10-year-old cousin had died by suicide. So they had told him that he had died, but not how. And this was about 2 days before Christmas. And they were going to wait till after Christmas, but he was starting to have night terrors. And so I got the family into the office and I said, I hear you had, experienced the death of a really person close to you. And so he told me about that. And I said, did you go to the funeral? He said, I did, but I had a really bad cough. And I knew my cough was interrupting everybody from listening to what the minister said. This was an 8-year-old. My ears really perked up when he said that. So I really concentrated on not coughing. And as a result, I didn't hear a thing the minister said. But when we got outside, the snow had just fallen. There's about 4 inches of snow. And I stopped coughing. So I could hear what the minister was saying at the cemetery. And so I just reached over and I made a snowball. I made the bestest snowball ever. And I put all my love and affection in this snowball. I put it on top of the casket because I knew it would melt. It would become part of Joey, and I felt better. We're in the business of making snowballs for our clients and our family members. And sometimes we have to put on gloves, and sometimes we have to take off the protective gear to really provide the emotional and spiritual care that we do to them. But there is that cost of caring. And as long as we're aware of that, as long as we're providing really good self-care to ourselves, to our colleagues, that's what's going to get us through this and dealing with that particular aspect. So let's take a break for about, not a break. Let's ask some questions. I think we're going to try and come out with some themes of the questions, and we'll spend about 15 minutes with talking about some of your concerns. Take it away, Michaela.
If you have questions, there's none right now, just some comments there. But if you have questions, if you can just put them in the Q&A box, and I will pass those on to Eugene.
And is there a theme to the comments?
Oh, just enjoying your presentation, Eugene.
Okay.
I can read one here. Michelle said, this is such a needed thing that we are experiencing now in our organization. Very interested in introducing this to our directors and board. A lot of burnout, not only to the pandemic, but other serious changes in the organization.
And I'd be glad to do that short presentation on compassion, fatigue, and burnout to your organization. So you're right. This is really important stuff around that.
Yeah. Norma Jean just asked, can you both be both hypo and hyper regarding trauma?
That's a really good question, and absolutely. And that's sometimes even harder to deal with because you've got those ranges, and it can happen like within minutes, or it can happen one day I'm feeling really hyper vigilant and in that fight or flight, and then sometimes I'm just flat. And this isn't a symptom of bipolar. This is a symptom of where we're feeling the effects of the work that we're doing. So that's a really good point to be aware. And it's the same thing that gets us out of it: the mindfulness, the square breathing. And when you do the breathing, it's important. I got a little lightheaded doing 4-4. So I started at 2-2 and worked myself way up. So it works.
Awesome. And then there's just a comment here from Villy. I noticed a lot of vicarious trauma with ER nurses that have seen far too much trauma in their careers. Any comments about that?
Yes. And we need to really kind of create this. I'll give a perfect example of what we instituted at Stratford. We had a mom and a dad, and he was 8-year-old boy. Dad was a bit of a workaholic. So he got up one morning and his little guy was having cereal. And he said, take your time because you're not going to school today. I've already called school that you're not going in. I called in sick, and I've called mom in sick. We're going to Stratford. We're going to go shopping in the malls, and then we're going to go catch a movie in the afternoon. Then we're going to go out for dinner. Little guy was thrilled. So as they're walking into the mall, the dad popped in a cough candy, and it must have had 2 wrappers on it. He had taken off the first wrapper, but the second wrapper, as it got warmed, it came off, and he kind of coughed, and it got lodged quite deep, and he passed out. There was 2 ICU nurses that were off shopping that day, continually trying to do the Heimlich maneuver. They couldn't get a clear airway. The ambulance came. The little guy and the mom said, "We're not going without our dad." So they just threw him into the ambulance, and small towns some kind of allow that. And when they got to the hospital, the mom and the little boy said, "No, we're coming into the resuscitation room." And it really was helpful because the doc would say, "Okay, we've tried this and this. I would like to try this. Is this okay?" And it wasn't until they went to intubate him that they found that plastic, pulled it out, and but it was too late. They couldn't restart his heart. And so there would have been 2 docs, 4 nurses, a respiratory tech, and myself in the room. And the little guy kind of got off his mom's lap, and he kind of got us in a circle, and he gave us kind of a group hug, and he said, "Thanks for trying to save my dad." I'm not going to say it elevated us to tears or reduced us to tears. It elevated us to tears. All of us just burst out, had a damn good cry. And then later in the day, I ran into the doc, and I said, "How you doing with the situation this morning?" He said, "Usually I have a horrible headache. I don't." And so that little boy taught us a very important lesson, that after every sudden death, we take a pause, or any type of death. And if you Google on YouTube, the pause, there's a beautiful little video called The Pause on how to do that. And so now whenever there's a code, whether it's successful or unsuccessful, we just do a little 10-minute debrief. Did the crash cart work? Was it well stocked? Physically did it work? Okay, how are you emotionally feeling? Wow, he reminded me so much of my grandfather. This is really, hitting me. And it allows us to get it from here to here, out here, and to reprocess it. So again, we need to be very intentional of doing these mini debriefs regularly. It doesn't have to be for a major catastrophe, but a very significant, any kind of loss, we need to acknowledge it around that particular aspect.
Awesome. Someone asked, how do you recommend debriefing after the death of a particularly close patient in your caseload or a complex death?
If you email me, I've adapted a debriefing process for hospice palliative care. I'd be glad to send that to you, because there's a way of kind of acknowledging it. And it's more than just death rounds. It's saying, okay, let's say it was Joe that died. What was the thing that touched you most about Joe? What was the hardest thing about giving care to Joe? What was the best thing that in giving care? How did it touch you as an individual? How did it affect you as a team? And is there anything we need to change? So that can be helpful. So if you send me an email, I'd be glad to send you that presentation.
Awesome. Perfect. Francine asked, how long should you do the deep breathing or the 4-4 breathing for?
Yeah. Usually 5 repetitions. Thanks for mentioning that. I forgot to say that. Usually 5 repetitions. I sometimes, I try and now incorporate it every hour. So before I do a virtual, I got a little thing there. It says 4-4. So I do it routinely instead of when I get stressed. So the more that we do it routinely, the more we stay in that window of tolerance.
Awesome. Melanie said, not a question, just want to say this information has been really helpful. She appreciates it. The illustration of stress and strain is such an eye opener.
Oh, good.
Erin said, this old emerge nurse appreciated the story. Sometimes our worst days give us our greatest treasures. For sure. Mary asked, Eugene, do you have any books that we can read?
Yeah, sure. And I'll put a resource list of some of the ones that I find really helpful, and I'll make sure I'll give it to Monica and she'll send that out. I meant to do that and didn't get around that because that's an often a request, and that's a good point.
Sounds good. Perfect. Leah said, social worker student here in school, we talked about how the burnout experience or feeling severely stressed has often more to do with the work environment rather than the vicarious trauma from the clients people we work with. How should we approach the wellness talk at work? How do we support wellness while at work without suggesting more bubble baths or getting enough sleep well off work time? And P.S., how do you spice up your craft dinner?
Designer ketchup. um, you bring up a really good point about positive psychology. Now, there is a role for positive psychology, but if it's just stay positive, don't deal with that, that's what gets us in trouble. We need to develop ways. One of the easiest way is the compassion fatigue test. So if you Google that, it'll bring it to you. And it's a kind of a 60 question, and it tells you your compassion satisfaction, your compassion fatigue, and your burnout rate. But it also says your compassion satisfaction. So there's a benefit to it. So I do that every week. You'll also find that there's a computer one that does the tabulating of the scores. It's very easy to do. And so I'm suggesting that to your colleagues to say, let's do this once a week and let's just kind of talk about our scores. And that's a wonderful way of kind of keeping track. And by constantly bringing it up to the team about, so what do you guys do that makes it helpful? How are you dealing with some of the stress around that? So after every debriefing, we come up with a list of what's really helpful. We had one of our nurses say, well, I love Grace on Grace's Anatomy, that she says, well, sometimes with this issue, we just need to dance it out. So she sponsors every Friday at 6:30, Dance It Out. So everyone joins on Zooms, and she plays some music, and they all dance crazy. And they have so much fun, and it's just this half hour of stress relief there. And so it's those kind of things of getting really creative, being intentional about it. When the vicarious trauma kind of is building, it's changing our worldview, reaching out to colleagues or to our EAPs, that can be really helpful.
Yeah, for sure. Henriette said, can you send us the debriefing to all of us?
That's a great idea. That's even much easier. So yeah, I will commit to sending that to Monica, and she can forward it.
Sounds good. Perfect. Amanda's asking if you can post your email address again.
Okay. Yep. It's on the front slide. So when you go back to it, it'll be there. But we'll send that out too.
Sounds good. Norma Jean asked, how do you respond when someone says that they don't want assistance, especially when it's clearly evident that there are needs there?
Yeah. When the student's ready, a teacher will appear. So not being shied away to say that, okay, I offered once, I'm not going to offer again. And then looking for the way that what's the best approach. So, you don't want to wait until they've had a complete breakdown. And it's always best to lead with, I'm really struggling with this, this, and this, instead of saying, I'm worried about you. If we start with how it's affecting us, it then starts to open the door. I'm really struggling with, this particular aspect of it that can be really difficult. I was shocked that during the first wave, after about 3 weeks, I reached into my suit coat pocket and I pulled out a thermometer. I never carry a thermometer. After every interview, I was taking my temperature. I had that, that ruminating fear. And so finally just me, anyone else just darn right fearful about this? And yeah, that was a common theme around that. So I think reaching out by saying, this is where I'm really struggling, it really opens the door instead of coming out first with saying, I'm concerned about you, because it's almost kind of this way.
Yeah. Kelly said, I feel that the self-awareness piece is huge to promote with our caregivers and assisting them in development of a wellness plan. I liked the self-affirmation template you shared. Will it be included in the slides? And
Yes.
I felt a connection to the comment you made around, if you can't say no, then how good is your yes? Quality wins over quantity in my close circle of peers. And then Tammy said, working in community care, we are often left to deal with the various traumas we face on a daily basis on our own. Can you suggest any ways we can debrief solo?
Okay. Yes, and I have a model or a thing to do, and I'll make sure I include that. You know, that's a whole session in itself, and I think you bring it at that really, you know, appropriate. I remember when I started at St. Joe's working on the HIV/AIDS. You know, my supervisor gave me a book, a lined book that said, "I want you to write down the names of all the people that have died, their age, and the date of their death, and bring that in, and we'll review it at supervision." Well, 3 years later, I faithfully brought in this book, and she not once brought it up. So I said to her, okay, wait a minute here. What's this about? And she said, I just needed to make sure that you knew what was on your plate. So I've kept that up. As of yesterday, there was a little over 7,000 names in that book. Now, this is just an average social worker's position. I think you nurses that, you know, work shift work, weekends, would have much more exposure to death. So I think if you were given that opportunity when you started your career, it would be higher than that. And I share that to say, oh wow, we have dealt with a lot of stuff, and that could have an impact. And yeah, it's also incredibly beautiful that we've helped journey with people, but there's a cost to that kind of caring. And that's why I love what people are saying about wellness program. We got to get very intentional. We have to have it multifaceted, that it can apply to many people. And we got to get all kinds of disciplines involved in it.
Yeah, absolutely. Awesome. So that was all the questions in the Q&A. If anyone has more questions, just type them in the Q&A. We can get them answered there before the end of our day. So
I'll turn it over back to Monica.
So Eugene, would you like to say your last words before the break? We still have a few minutes.
Oh, okay. It ends at 12:30? I mean at 2:30?
2:30 would be the interval, unless you would like.
No, okay. The other thing, one of the first time I worked at St. Joe's was, you know, you're hired, here's a pager, you're on call this week. And that week I was called into 4 deaths. They were all after midnight. And so it was the same nurse that was working midnights. And I said I noticed that the nurse, after the families left, she would open up the window. So I thought it was policy, procedure, protocol to air out a room after somebody had died. And then after the second, I thought that doesn't make sense. So I said to the nurse, okay, why do you do this? And she says, well, for many of these patients, I've sat on their bedside for many days, weeks, some, you know, 2 or 3 months. I've really got to know them. I've really got to understand their pain and struggle. And this is just my way of setting them free. I open up the window, I take a deep breath, and I'm thankful for all that I've given them. I breathe that out, and I'm appreciative for all they've given me, and then I set them free. Because I know that damn call bell is going to go in a few minutes, and I don't want to be robbed of that experience. So I think that's what's important, is not being robbed of those particular experiences that can be really helpful in dealing with that particular aspect. You know, we're going to be talking a bit about legacy work as part of the next session. And it was funny with my sister had went and she knew a sewer, and she brought this sewer, one of my dad's shirts. And if you would have known my dad, this was his kind of color and his kind of plaid. He You never seen him without a plaid shirt on. So she made 4 of these bears, one for each of us kids. And this was done while he was still living. And so he knew that it was going to be his way of being with us and how helpful it was in dealing with that aspect. So he even got a chance to sign them around that. So finding rituals, the more rituals we can use to kind of get it from here to here, out here, and to reprocess it can be really helpful in dealing with that particular aspect.
So what would you like to do? A longer interval now until 2:45?
Sure. Or why don't we come back at 20 to 3?
20 to 3 be
Yeah.
it.
Okay.
So, quick coffee, 20 to 3, we are back.
Sounds good. Okay.
give our folks 3 minutes more. Cheers.
Cheers. How did the morning go?
It has been fabulous. Of course, I should not be saying the praises here, but
We'll knock on wood. Yeah.
so far, you guys all rocked it.
Oh, good.
Pallion was great. Dr. Gina and Tara after that were absolutely smashing. They gave a show of expertise and technique on palliative pain and symptom control for liver cancer mostly. And now you see what's happening here.
Oh, yeah.
The comments about your first part of the presentation.
Yeah, it's you can tell you got a special group there.
Yeah, and it's, you know, rivers go to the sea, right?
That's a beautiful saying. Yeah.
So many people out there that are so kind, wanting to do the right thing and studying hard to have all the expertise possible to do the right thing in the right way. And then this happens. It's magic. You and our audience today having a great day.
Oh,
I am
good.
so thankful
Good.
to all of you participants and panelists. It has been memorable for me. I will never forget this presentation.
Wonderful. You made my week.
No, it should be your month. Okay, so 1 minute to go. I am giving the floor back to you. Thank you so very much. And to those of you who are returning to listen to Eugene's wisdom, don't forget that at 4:15, when he wraps up his presentation, there is the conference evaluation. Your opinion is super important to us because we will learn with you how to serve you better in 2022. So please do respond to the evaluation because you will be contributing to make our conference even better next year. Your opinion is important and you are the center of what we do to serve you. So thank you, and back to Eugene.
Great. And again, thanks for Friday afternoon's a tough thing to keep going. So I just really appreciate your time. I show this picture here. It's Sarah. So it's this long-term care facility I worked at, and she was 96 years of age, nonverbal, and she congestive heart failure, and she continually screamed out. And so the nursing staff came up to me and said, could you just try and get her to stop screaming? So I went and sat with her. I pretty well tried everything. And I even started singing, which made the screaming worse, which is understandable. And I was about to leave and I just noticed a tear rolling down her cheek. And I thought, and it just kind of stayed there. I thought, oh, that must be uncomfortable. So I just went and I just kind of wiped it away and she stopped screaming. So I waited a few minutes. It was about 7 minutes. She started screaming again. I just caressed her cheek and she would settle down. So I did that probably every 10 minutes for about 2 hours. And the nursing staff, what'd you do? What did you do? I said, nothing. I said, this is what I did. So I got about 10 or 12 volunteers together, did a little training program. And for about 18 hours a day, we take a 2-hour shift and just gently caress her cheek when she got upset. And it was usually about every 10 minutes. It didn't get any longer or shorter. It was about that time frame. We had no clue what was happening. She had come from a war-torn country in Europe. She immigrated when she was in her 30s, and her family stayed back. She had 3 sisters, and the 3 sisters were coming back to say good. Were coming to Canada to say goodbye to her. They had not been to Canada yet, and so they were like 75 to 89. But they were all well enough to make the trip. So when we met them, first of all, we explained this little program that we were doing in the brushing of the cheek. And she said, they all started laughing. She said, oh, well, we know what that's about. I said, well, what's it about? We're all anxious to hear. She said, well, our little town was invaded by soldiers, and they would often come in and abuse the young girls. So Sarah would put manure on our faces to protect us from the soldiers. And at the end of the day, after the soldiers left, she would wash our faces off, and she would tell funny stories to kind of take away from the indignity of having to wear manure. And I said, oh, well, who wiped off Sarah's manure? And she said, like, who wiped off Sarah's face? And there was a real long pregnant pause. And they said, oh, she didn't wear manure so that she would draw the attention of the soldiers as a way of making sure that we were safe. And I share that story to say, we never know the backstory. We never know the baggage, the experiences that people are caring for. So our excellent and compassionate care, reaching out when sometimes we don't know if it's doing any effect, it is. And just realizing that can be so powerful in dealing with that particular aspect of never underestimating. So when we talk about grief, we very much want it to work this way, but it works this way. We live in a very death and grief denying culture that says, don't talk, don't trust, don't feel, and for gosh sakes, don't change. And it just doesn't work that way. The latest research out is the death of a loved one takes between 2 to 3 years to get over the initial impact, and the death of a child between 3 and 5. When I tell bereaved parents that, they breathe a sigh of relief. They say, it's been 4 years since Johnny died, and I still feel like I'm going crazy. So much of what we do is to normalize this grieving process, and how important that is in kind of dealing with that aspect. Again, this was a really powerful experience. A mom and a dad, and they had a 19-year-old daughter and a 17-year-old daughter. And the 17-year-old had experimented for the first time in his life with some drugs. There was a new drug came out. It was a kind of a modern version of LSD. They put 75 little dots in the back of a credit card, and you just peel off this dot, put it underneath your tongue, and he had a massive reaction and a stroke, and he died. And so just very devastated about that. So when it came up to October, Thanksgiving, they would always go for a walk in the bush, and they found that very helpful, and they did that as a family. So they weren't sure what to do this Thanksgiving. And so I suggested, well, maybe not going to the provincial park that they always go to, but maybe go to a different park. So they decided to do that. The three of them went. And what he did, what the son did, is he would find a special tree, and they would gather around the tree, and they would say what they were thankful for. So they came across a tree, and they weren't sure this is what they wanted to do. But the daughter, she reached into her pocket, she pulled out 2 chocolate chip cookies and put it beside the tree, because he loved chocolate chip cookies. And then she reached in her pocket and she pulled out 2 extra strength Tylenol, because he always had a headache, and she didn't want him to have a headache. And I said to her, man, you nailed this little ritual. And so it's through ritual that we get through the losses that we have. That's why I really encourage us to develop our own little rituals of whether it be, attaching the work we do to a tree, to something, some way of getting it off of us temporarily, makes that really helpful in dealing with that aspect. About a year after his death, I had the parents in my office, and they were feeling really guilty. The urn was still at the funeral home, and it had been a year, and they were feeling horribly guilty. So they asked me, how long can we keep it there? I said, well, I'll call the funeral home and find out if that's okay. So the next day I called the funeral home and I explained the situation. Oh yeah, they can leave it as long as they want. And just to ensure them, we purchased a special vault that no matter what kind of temperature, it would have to be like a nuclear fire to melt this vault, that it will be always safe. We have it recorded in 3 different places, which one is his, and it's labeled so they won't get mixed up. And they can just take as long as they want. And so before I hung up the phone, I said, oh, by the way, how many urns do you have in that vault? And he said, 46. And when I told the family that, again, they breathed a sigh of relief. It's not just us, that this is a normal part. And so what I always say to people, there's no right way or wrong way to grieve. There's just your way. And it's our job to support your way and how helpful that is in dealing with that particular aspect. So this is the helping model. I had an opportunity to go to 9/11 to do some debriefing. I left the day after 9/11 happened. I was there for 10 days. And so this is the model that they did. It's called SSVVPP. So you just, first of all, make sure that the client is feeling safe and secure. You just allow them to ventilate, and then it's your job just to validate, and then you predict and prepare. So I added this other step, that before we do this, we need to go back and first of all retreat and reflect and just say, you know, am I ready to do this type of work, to get involved with this type of client? Where am I at? Do I got the right energy? Is this too close to a personal experience? Do I need to pass off to another one? And it's just a really wonderful model that can be helpful. Every group that was there had to do a debriefing. So the Ohio State dog team was there. So 8 guys with their sniffer dogs. And after 2 days, they realized there'd be no more survivors. So they were going back home, and I did the debriefing for them. So here they are in their room, 8 of them with their 8 dogs. And before I started the briefing, I said, okay, wait a minute here. Like, how do you guys cope with all this? You've just been back from China, a horrible earthquake, and now here. And they said, well, we cope the same way our dogs do. I said, oh, well, how's that? They said, well, after about 2 hours on the site, we put the dogs in the van. There's no windows on the van. And then we go back to the 9/11 site, and we dig a hole in the rubble, and we get one of the firefighters or construction workers in the hole. We got a tarp that looks like rubble. And then we put them in, we put the tarp over it, and then we put enough rubble stones on them that they're pretty uncomfortable, but they can breathe. And then we set the dogs free. Because if the dogs don't experience success every 2 hours, they become despondent, they lose focus, and they become depressed. Oh, wow, you spend that kind of attention to your dogs. What are we doing for ourselves? And that's just been a really good learning lesson for me, is to every once in a while to kind of, you know, what is this work having an effect? Is it, am I losing focus? Am I becoming distracted? Am I becoming depressed? You know, those are all really good questions. And this whole thing of a really good model for us, find a safe place where we feel secure to be able to talk about the things that we experience. Allowing ourselves to ventilate and find somebody that all your job is to do is validate. It's so funny, whenever my youngest daughter calls, she prefaces the call to say, okay, Dad, I just need to talk. I don't need you to fix it. Because usually I'm jumping right into Mr. Dad, fix it. And she goes, I don't need you to fix it. I just need you to listen. And that's so helpful for her to say that around that particular aspect, which is important in dealing with that. So this was a situation where there was 2 cars filled with 6 teenagers in one and 6 teenagers in the other. And they were stopped just outside of Stratford. This is going back 30 years ago. There was flashing lights at the train track, but no arms. So they were just stopped at the flashing lights. And the first car thought it could beat it. So it went through and was hit broadside, where these other 6 teenagers watched. All 6 were ejected from the car, and all 6 were pronounced dead at the scene. So I got the call around midnight. And so there was, you had 6 families that had to come and view the body. And I was just, I didn't have a team yet. So I was just kind of doing this on my own. And I remember it was the 6th one. It was about 4 o'clock in the morning. It was the last family that I needed to view. And I remember just putting my head down, taking a deep breath. Okay, you can do this. You can do this. And so I brought the family in, and the dad immediately said, "That's not my son. He's too short." And I had forgotten to tell him that when he was thrown, he did sort of a half semicircle, and his feet took the brunt of the impact, and they was actually pushed right up into the body cavity. And I forgot to tell him that because I was just so exhausted. And that was a really good lesson about knowing my limits, that after one death notification, you hand it off to another team, and how important that is in dealing with that particular aspect. So look at this model, and especially around the ventilate and validate of how you can find people to do that. I look at this often because this is me here. You got people that are telling this very painful story of suffering, and I'm often I'm looking for the hope. I'm looking to put it in a nice therapeutic story. If there's upset, I'm looking for the redemptive story. And when I'm doing that, I'm not listening to a word he or she is saying. And so this is so important to just really, when you companion, it's about being in the wilderness of the soul with an individual, and you're not responsible to find the way out. So this is so important that I constantly look at in dealing with that aspect. So this is a work from Brene Brown. She talks about the 4 qualities of empathy. So that's one is perspective taking, staying out of judgment, recognizing emotions in other people, and then communicating that awareness. So it's not just recognizing it, wow, this person is really suffering. It's making that extra step, and that's that compassionate care. I see that you hurt, I care, and I'm called to do something about it. I'm just aware that you're really suffering. And then it kind of brings it to surface around that particular aspect. So this is just kind of a prepper to talk about complicated grief. And this is sort of the mandate in what we do in dying and in grief work. It simply comes down sooner or later to how comfortable we are with ourselves, our others, and the whole idea of dying and grief. Because working with the dying and the bereaved often involves more being than doing. So usually at a time of crisis, people will say, just don't stand there, do something. Well, during a hospice, palliative care, during a grief work, it's just don't do something, but stand there. So the doing is kind of the behavior, and the being is being connected to the person's values, belief systems, their assumptions, their worldview, kind of that whole sense of being of what's important to them. So when we look at listening skills, there's that cosmetic listening skills, the conversational, active listening, deep listening. At the beginning of a session, I'll do a little bit of this just to break the ice, a little bit of getting to know them. But I'm really working hard to get to the active and the deep listening. And that's where we're really called to do, and how helpful that is, and looking at which ways that can be helpful. So there's that whole art of joining through active listening. It was so funny. After about 3 weeks of doing the phone calls, I noticed people would be saying to me, hello, are you still there? Are you still there? These are all phone interviews. And I'm thinking to myself, yeah, I'm leaning in. I'm listening. My facial expression, you've got me. And then I'm realizing I got to be much more intentional about being verbal, because they just can't see you around that. So those attending behaviors, when somebody's really struggling, just that little move inward, just to say, you got me from head to toe, and I'm really there. That paraphrasing, so they quite understand. Another technique, and this is where you really have to listen, is if they start crying, and let's say the last word is pain, I always remember the last word. So I let them have a good cry, and then I'll just say pain. or suffering or Joe, whatever the last word was. And it does two things. It puts them back on track, but also says, wow, this person's really listening to me. So that part of paraphrasing is so important. And then kind of reflecting, wow, that was very moving. That really resonated with me. I was really touched by that. And then also that clarifying, making sure I got the story right is so important in dealing with that particular aspect. My dad was getting infusions because the cancer had spread to the bone. So he didn't want to have chemotherapy. So we had finally, he wasn't making it to the bathroom. So he finally allowed us to bring the urinal with us. And my sister would bring a blanket, and he would just have to stand up. She would wrap the blanket around us. I would go inside the blanket with the urinal and help him pee. And so this happened, and there was 10 chairs of people having chemotherapy. So all of a sudden he says, I gotta go pee. So he gets up right away, and my other 3 sisters were there. So they're on the outside with this blanket wrapped around, and I'm underneath. And all of a sudden nurse walks in, she said, what's going on here? And my dad was very mischievous. He said, oh, prayer meeting. So everybody in the room bowed their heads. Of course, I didn't hear that. And all they could hear from me yelling out from the blanket, Dad, would you hold still? You're peeing on my hands. So there's that whole sense of humor of being that presence is helpful. So with the listening skills, focus on listening. Avoid jumping to conclusions. That wait, the pregnant pause. The latest research out is that a person needs to wait 8 to 12 seconds to make a response after a question. Well, for a French Canadian social worker, that's painful to keep my mouth shut that long. But when you think about it, they need to hear the question, formulate a response, and then give it. Now, this is the thing that I continue to struggle with, and this is the thing that is the most important. Trying not to think of a response. Just trust your gut that during that pregnant pause that you're waiting, something will come up. That's important, because when I'm thinking of a response as they're talking, I'm not actively listening. So that can be really helpful in dealing with that. So here are some of the techniques that I find helpful. Can you help me understand? Can you tell me a little bit more about the story? Or, so what you're saying is this, and then I always finish with, do I got that right? So that I'm inviting them to say, no, you messed up. And it's that invitation that can be really helpful, because often they may be intimidated by the healthcare professional that I don't want to correct them. But when we invite them to say, do I got that right? No, you're not, that's not quite what I meant. That makes it really helpful in dealing with that aspect. So the work of Martin and Doka talks about grief styles. So there's the instrumental and the intuitive. So this part you can't quote me on. The instrumental is the male way of grieving. The intuitive is the female. Now, we all have male attributes and, masculine energy and feminine energy, but I always get pounded when I try and explain that, especially to men. So instrumental is a much easier and intuitive. So that instrumental, the focus on thinking, the desire to master feelings, the problem-solving orientation. And some of these are practical at times, are really helpful. But if we just stick in the instrumental and don't get to the intuitive, the experiencing the losses deeply, being expressive, gaining strength from sharing with others, and they're less solving and more dealing with feelings. So really encouraging both the instrumental and the intuitive aspect of grieving. So Ira Byrok has this wonderful book called Dying Well. And he says, a dying person may need to say, I forgive you, forgive me, thank you, I love you, and goodbye. Well, this is also a really good grief model, and it's also a really good legacy to, or a life review. So I kind of have this tattooed on the inside of my eyelids so that I never come in with an agenda. I find that whenever I have an agenda, I miss what the person is saying. So I leave my agenda briefcase outside and the door of a house or a room that I'm going to visit. and I just look for themes. And so often when they're reviewing the relationship, you know, life is often a lot about bumps and bruises. Was there any bumps and bruises in your relationship? And that's a really good phrase, bumps and bruises. It's approachable, it's workable, and it makes the hurt just a little more manageable. Did you get a chance to say thank you? I love you and goodbye. And even if the person has died, and this is where with COVID-19, I'm using this a lot when they weren't be able to be at the bedside, and they can do it after the person has died. That's where, again, we really need to be that kind of creative aspect of it. Again, another really powerful experience. It was a 19-year-old girl was driving home, and someone missed a stop sign, plowed into her, and she was killed, pronounced dead at the scene, and they had to wait for the coroner to come. And the coroner, it was going to be about a 4-hour wait. And the 19-year-old happened to be the daughter of a firefighter from this team. Now, he was coaching a hockey game about an hour away, so he was signed off. He wasn't responding to calls. And so the chief was really struggling of what to do. And finally, he made the call that, okay, we're all going back to the fire hall. They sent 2 firefighters to go pick up the dad, and they would meet with him at the hall. And the guilt, when we did the debrief, the guilt that these firefighters felt of abandoning their colleague's daughter. And what they did is they called in the neighboring fire department to secure the scene, and then they would have to extricate the girl after the coroner was done. And I just said, you did the right thing. You really put your colleague first, and yourselves, you got a chance to prepare on how you're going to support him. So, you know, we can never underestimate those kind of struggles that we have. And so when we look at our own professional work, are there decisions that we made that we second guess? And it's, you know, okay to process them, but realize that at the time and the space that you made those decisions, you did it with the best intention. Is there any life lessons to learn from them? Would I do differently? Well, that's what being a lifelong learner is about in dealing with that particular aspect. We did a second debrief, and the dad wanted to be a part of that. And he was able to say how helpful it was knowing that his guys were there to support him, and that he had just as much faith in the neighboring fire department that had companioned his daughter until the coroner got there in dealing with that particular aspect. Well, let's just talk a bit about spirituality, because this is very important. Often when I say to people, how are you coping with this spiritually? They'll often say, I really don't go to church. About 80% of the population don't have a community that they're participating in. And I'll say, well, that's not really what I meant. Spirit comes from the Latin word breath, and soul comes from an old German term, which means from the depths. So spirituality is your vital breath that comes from the depth of who you are. Let me give you an example. So these pictures here are pictures of the French River. I was working with a firefighter who was diagnosed with advanced bone cancer. So that would have been the secondary spread. I think primary was kidney, and he was palliative. He was born and raised Roman Catholic, but left the church when he was age 16, and it caused a huge rift between his parents. And it was a rift that never really got healed. They continued to be very close, but when religion came up, it was such a sore point around that. So and he loved the French River. Anytime he could spend, he would go there. He would bring friends and family. That was his place to be. So his firefighting buddies had blown up these big pictures of the French River, and they had them posted on the ceilings, on the walls, on the floors. They had a comforter made with the picture of the French River, mugs everything was a French River. And I had worked with him in the hospital, and he wanted to die at home. So when I went to his home and I walked in and saw this incredibly impressive room, I said, oh, This is your chapel. And he just started to cry uncontrollably. And we were able to work and realize that you didn't abandon your parents' faith. You incorporated it, and their teachings about faith and about religion and about God became very nature-based. And your spirituality, your vital breath is all about relationships. And then when we did a family session, he was able to explain that, and it was a huge healing. So I really encourage you, this is not the place, the realm for just spiritual care coordinators or clinicians or clergy. We have a role here to share our vital breath with our clients when it's appropriate, when the timing's right, if they ask, because that's so important in dealing with that particular aspect. I worked with a dad a couple weeks ago whose son died by suicide, and he had mentioned in his intake that he was a very devout Catholic. And so I knew this was percolating on his mind. And without even him saying it, I said, oh, there's one thing I want to say. I said, I have no doubt where your son is. He's sitting right beside Jesus. And that's what he just needed to hear around that, because his old belief, which has since been corrected, is that someone goes immediately to hell if they die by suicide around that. Even our language, committed suicide, we really refrain on using that around that aspect. And it was in a group setting, and the other dad said, he said, well, my son had a temporary lapse of judgment. He was sitting on top of the hood of a car. The guy sped off, he hit his head, and he became brain dead. There was no alcohol involved, just like your son. There was no alcohol involved. It was a temporary lapse of judgment. And I thought, what a beautiful way of putting that it takes away any about shame. And that's one of the things, if we see shame coming up in complicated grief, we really have to help people unpack that. That can be really helpful in dealing with that aspect. So spirituality, your vital breath, seeks connection through belief systems. I really got to get a COVID-19 haircut. Through belief systems and relationships to something beyond or greater than oneself, to find meaning and purpose in one's life. So you folks, this is what you're so good at. Beliefs, supporting people's belief system, non-judgmentally, supporting those relationships on their quest for meaning and purpose. That can be really helpful. So emotional and spiritual care, or that vital breath, the vital breath care, is devote presence, attention, respectful assistance in helping people to discern what is the meaning in their life now in this new environment of pain, and how they seek to live out that meaning as the recovery unfolds. So in complicated grief, this is kind of our mandate. And this is what you folks are really good at presence, at attention, at a respectful assistance. So as you're doing a dressing change, as you're doing a bed bath, or doing any kind of personal care, and that's the advantage you folks have, that the personal care, when you're doing hands-on, you've got that connection that it takes 5 or 10 sessions for me to get where you folks are at if you're doing that hands-on care. That's so important around that. So that respectful assistance, helping people discern, that's a great word. We're in this together to discern. You're not by yourself around that. Again, about meaning in this environment of pain, in a society that says, we don't want to talk about pain. I'm okay to talk about pain. And then as the recovery unfolds, and the focus there is the word recovery, is that whole particular aspect is important in dealing with that aspect. I show this picture. This is so important. I got a chance to, 1972, listen to Elizabeth Kubler-Ross at Cleary Auditorium in Windsor. There's about 3,000 people there. And I'll never forget, she started off saying, how many here are dying? And about 11 people kind of put up their hands. And she started laughing hysterically. She goes, we're all dying. And she told the story that before she came in 1965 to work in Chicago from Europe to work in palliative care. And before that, she went to Auschwitz and Dachau, the concentration camps. And outside of Dachau, people don't know about it because it's so horrible. There was a room that they held the children the night before they were brought into the gas chambers. So this room would, she said, held about 400 kids. They were stripped naked and then put in this room overnight and then brought to the gas chambers the next morning. So when she went in, it's now a site, a respectful site where people can go. She expected to see lots of doom and gloom. Instead, she saw big pictures of butterflies carved into the window, into those clay walls. And that was the hope that she saw during this horrible 8 hours that these young children had. And that's why she brought the butterfly back, and it's often become the international symbol. Also because of her stage theory of grief. But what's really interesting about this is if you see this butterfly really struggling to get out, or even here, if you think it's kind of stuck and you give it a little pull, it will die. It needs the struggle, it needs the suffering of getting out, which allows the fluid to go into the wings, which will allow it to survive, which again is a really good metaphor for me and for us to know that this kind of suffering, we can't take it away. All we can do is witness it, support it, and be with them around that. We don't have to take it away. We don't have to try and fix it, because even when we do try and fix it, that's even more harmful around that particular aspect. So when we talk about suffering, it's such a powerful word, and to see people suffering. So when you break it down, sorrow means like the pain is long acting. So we know that it's going to be for many, many months. It's often unfair around that. There's a lot of fretting, fear, emotional emptiness, and probably the biggest thing is this ruminating that can be so difficult in dealing with that particular aspect. And so breaking that down makes that really helpful in dealing with that aspect. So I got this wonderful story about suffering. An aging Hindu master grew tired of his apprentice complaining, and so one morning sent him for some salt. When the apprentice returned, the master instructed the unhappy young man to put a handful of salt in a glass of water and then drink it. "How does it taste?" the master asked. "Bitter," spit the apprentice. The master chuckled and then asked the young man to take the same handful of salt and put it in the lake. The two walked in silence to the nearby lake, and once the apprentice swirled his handful of salt in the water, the old man said, "Now drink from the lake." As the water dripped down the young man's chin, the master asked, "How does it taste?" "Fresh," remarked the apprentice. "Do you taste the salt?" asked the master. "No," said the young man. At this, the master sat beside this serious young man, who so reminded him of himself, and took his hands, offering this. "The pain of life is pure salt, no more, no less. The amount of pain in life remains the same, exactly the same. But the amount of bitterness we taste depends on the container we put the pain in. So when you are in pain, the only thing you can do is to enlarge your sense of things. Stop being a glass and become a lake." And I think, again, that's a great metaphor. When people are really suffering, my initial reaction is to run. And then it's just through that kind of sympathetic breathing to stay focused, that you're there to help enlarge things for them so that they're not feeling so alone, that the bitterness is not overpowering, and that it is shareable. That can be really helpful. So after that heavy example, this is the desk that I wrote the book in, and this was Julia. She was about 7 months old, and so I sat and I read her the book, and honestly, I'm not lying. At the end of it, she leaned over into my ear and she said, "Pepe, I want to be a hospice palliative care worker." Oh, brought tears to my eyes. This is also a very significant mailbox. So when we created the palliative care unit at Stratford. The nursing staff, I did a lot of training from. So they bought me this country mailbox, and I never brought it home. This is once I left Stratford, I took it with me, but I put it outside my office door, and I never used it as a mailbox. Instead, at the end of the day, I would put everybody I was working with, all the experiences, in that mailbox, and I wouldn't close it, but I'd slam it shut, just to startle me to say, okay, you need to distance yourself from that, and you can pick up the mail in the morning. So again, all those little rituals are so helpful in dealing with that aspect. Let's talk a bit about complicated grief. So these are the components of complicated grief, those intrusive memories, strong pangs of emotion related to the lost relationship, that powerful yearning or wishes that the departed was still present, tense feelings of loneliness and emptiness, recurrent sleep interference and disturbances, and that loss of interest in so many things. Well, when you look at COVID-19, it's pretty comparable, that inability to participate in deathbed rituals, the inability to have regular funerals or memorial services, the constant concern about safety, the spread of infection, working from home, not having the social supports of your work environment, the financial concerns. So I say to people, yeah, we're in the same storm, but we're not in the same boat. I've never missed a paycheck through all the pandemic. I got a pretty nice place to self-isolate. Yeah, is it driving me crazy? It is, but I cannot say that 30% of our of the population is still unemployed. The small businesses that are suffering, they're in a totally different boat than me around that particular aspect. So what we know is that people are isolated from the loved ones before death, not being present during that last 48 hours. We had a palliative care patient we had been working with for a couple of years, and he fell and broke his hip. So he went to hospital to get it pinned just when the outbreak happened. And so the hospital was closed down, and then he developed an infection and was actively dying. They weren't going to pin his hip, and he was going to die. So his wife could come in, but his 4 kids couldn't. They were out in the parking lot. And this is before we were really structured with really good virtual stuff. And the mom had an iPhone, and the 4 kids had Androids, Samsungs. So FaceTime wouldn't work, and they didn't know about all the other apps. So they called me and said, Dad's dying and we can't be a part of it. And so I said, why? So she's got an iPhone and we don't. So I just said, look around in the parking lot. Is there anybody walking by? So there was someone walking by. Ask them if they got an iPhone. And luckily it was a nurse coming off shift, and they explained the situation. And so I gave her the mom's phone number, and she FaceTimed the mom, and she handed over their phone. And for 40 minutes, they sat in the parking lot. Well, this nurse just patiently just supported them without saying anything, and just, take your time, I'm in no hurry. And she didn't go sit in her car. She just stood a few feet away supporting them, and they got a chance. That's how they were able to say goodbye to their dad around that. So that inability to participate in deathbed rituals, the witnessing personal suffering from a distance, that leads to that whole sense of helplessness. The restraints of time, the loss of control and hopelessness, the individual, family, cultural, social, and faith-bound rituals that are hampered. So our neighbor's mom died, and they got 10 kids, and so they had to do 3 different services for like 3 kids at a time in their families, no more than 10 at a time. And the minister was more than glad to do that, but as a family, they couldn't grieve, and that made that really difficult. Witnessing mass suffering adds to the traumatic nature. Like after the first wave, about halfway through, I had to stop watching what was happening in New York City because it was just too much around that. So, curtailing the amount of mass suffering when your receptors are overload, that's important. And then just grieving without my people. We know the best thing is support when you're grieving, and not being able to do that makes that really difficult. So this is probably one of the best places to go for information on complicated grief. And I love their description of grief. It's the response to loss that contains thoughts, behaviors, emotions, and physiological changes. And this is the part I really like. If the loss is permanent, so too is the grief. And that's where that research of death of a loved one being 2 to 3 years, death of a child of 5 just makes so much sense around that particular aspect. So with complicated grief, it's natural to experience acute grief after someone close dies, but that complicated is very different. It's intense and long-lasting form of grief that takes over a person's life. So in the world of psychiatry, there's what they call the Diagnostic Service Manual, DSM, and it's in its 5th edition. And in this edition, they've put in a segment, a diagnosis for complicated grief. I think it's called prolonged grief. About half of the people in the grief researchers were really upset because it's now a diagnosis, and we know grief is a natural response to a loss. So some are really upset that it's been kind of medicalized. However, there's another half that says, well, now that we got a diagnosis, insurance companies can pay for the therapy, and social workers and counselors can bill insurance companies. So I'm not too caught up about that. The fact that it's going to open up more services and therefore maybe more funding research, that's really important around that. So that complicated grief is that form of grief that takes hold of a person's mind and just won't let go. Often people with complicated grief will say they're feeling stuck. And so we don't give the diagnosis of complicated grief until after 6 months, sometimes a year. So we definitely wait that first couple of months. What we know is that it's almost like a general anesthetic comes over people that gets them through the visitation, the funeral services, those first 3 months, and then they sort of hit the wall. And people will talk about that. They kind of hit the wall. But that's just the body's way of protecting itself in dealing with that aspect. So some of the risk factors, so definitely COVID-19 is going to be a big one. So we're really trying to step up the efforts to get more funding for complicated grief, because COVID-19 is going to be a biggie for family members, and it's going to be a big issue for us caregivers. After 2 years of running on a treadmill of seeing so many multiple losses, plus cope with the fear of infection is great. Suicide loss, lack of that kind of support, traumatic childhood experiences, if there was an overly dependent relationship, being many times unprepared, and just lack of resiliency. So there's many different ones. The big ones are if someone has died of a traumatic death, so a car accident, murder, suicide, or the death of a child are the big 4 that included to complicated grief. And then the 4th, 5th one will be people that experience a death because of COVID, and also caregivers. So we kind of look at the circumstances of a loss. Were there any concurrent losses, unresolved loss issues, if there was different aspects of the relationship with the person who died, and that inability to complete those phases of grief around that aspect. So this Catherine Shearer is the one that has created that Center for Complicated Grief. And so she's come up with a screening tool that you can get off the internet. So it'll be in my slides. It's the next slide, and it's something that's really helpful. So you used it with adults bereaved for at least 12 months and children for at least 6. However, you continue to screen during those 6 months or 12 months just to make sure that you've got your antennas up for suicide risks or any mood disorder or anxiety disorder. So those are something that are really important. I often get a lot of questions about antidepressants, and this is a really good question to really work with our clients around that. So many clients who have a grief reaction and are offered antidepressants, they'll experience feeling a bit detached. They start taking the antidepressant and all of a sudden the tears dry up. And it allows them to get back to work. It allows them to function, but it doesn't allow them to do some of the grief work. So I think more and more psychiatrists are becoming really focused on, is this is this grief or is it depression? And sometimes a grief can trigger a clinical depression, and sometimes it's a situational depression that therapy, support groups, working out can be really helpful. The big thing is that when it shuts down emotions, when people don't have that ability to cry, that's what makes it really difficult around that. And I always trust the clients to say, well, what is your body? Have you ever been on antidepressant for? What do you think? Are they good with medication or not around that? In some of the insurance programs, if a doctor recommends an antidepressant and they say, no, that just doesn't work for me, they get discontinued the disability because they're not following physician's directions. And that's not fair, because if people really got to trust their body. So things are starting to get some changes around that makes it helpful. So this is that brief questionnaire. So as you can see, it's really simple. And I've done a couple of things. So if you're going to use this, there's a couple of questions where I use the name John. So you can create this, or you can just download it off the internet and just hand it to people. But when you read question 4, you say looking at pictures or talking about blank, as opposed to are you feeling cut off or distant from people since John died? When you it takes a little more effort to type in the person's name, but it's well worth it. It just makes it much more personalized. So a score of 4 or more may suggest that an individual may have complicated grief. So I find this tool more helpful for the client to say, oh, okay, these symptoms are really quite real, and that makes it really helpful for them around that particular aspect. So probably one of the best brief assessment tools for complicated grief. So these next couple of slides I'll leave with you are around normal grief as opposed to clinical depression. There's just being a lot written about it that can be really helpful. Another way of putting it, again, this is all the work of Ellen Wolfelt. So when we talk about resiliency level, there's that, the level goes up, low or high, the adversity or the decline in people's mood. But I threw this slide in just to show that when you're dealing with complicated grief, first of all, it's the survival, what I call the tea and toast syndrome. If they're eating tea and toast, I don't worry. They're eating something, make sure you put a couple of spoons of sugar in the tea. You're going to get some hydration. You're going to get a little bit of energy. You're getting a little bit of carbohydrates. That's survival. And so those initial few months, it's about survival. And then you'll start to see some of the adaptations. Well, I'm able to sleep a little bit longer. I'm able to eat a bit better. I'm able to make a few more phone calls. I was working with a gentleman the other day, and whenever I called him, the phone goes to the answering machine, and then right before it goes to record your name, he picks up. And it's his wife that has died. They were married 69 years. And so after about 3 times, I said, are you having a hard time getting to the phone? He said, oh no, I sit right by the phone, but every time it rings, I just get a chance to hear her voice. And it just really touched me around that. And I remember saying to him, the 69 years, saying, oh, what a great example, 69 years. And there was that pregnant pause. And I knew I said something wrong. He said, nearly not long enough. And so again, by me focusing on 69 years, it was robbing him of his pain. It didn't matter how long, it was never nearly long enough. So that was adaptations, the recovery. So this is where I love talking about my screw ups, because doing this work for 35 years, it's still a learning experience. There's a woman that he was dying quite actively at home, and we were having a hard time getting nurses in. So they happened to live in Bayfield, so it was on the weekend. So I said, well, I'll do a 4-hour nursing shift. I learned how to access support. I'd been able to sign off on that. So I administered a few doses of dexamethasone because she didn't feel comfortable around that. And so when he died, she talked about, well, how long can the urn be there? And when she said the word urn, I thought it gave me permission to say, well, and the ashes don't need to stay kept at the funeral home till you do something. You can keep the ashes here. And she just looked at me and said, ashes, that's my husband. And luckily I had a really good relationship with her, and that was just another penny dropping into the pond that this is a reality. So, and I usually say the person's name. I usually don't say urn or ashes. So just those important things to remember. This was, again, a really powerful experience. I worked at a long-term care facility. I started there, I think in March. And I read there was about 200 residents, and part of the first week is I just read everybody's chart. And we had a really neat activities director, and she would do the assessment questionnaire of all new residents. And she'd been there quite a while, so she was the one that did all these. And she put in a question: have you ever experienced the death of a child? So I had this rich, rich information. So I was able to pick, there was 12 women that were cognitively able to participate in a group that had all lost a child, and they were willing to meet. And we did it on the Friday before Mother's Day. So I thought it's going to be no more than 45 minutes. I didn't want to tire out the ladies. Well, 2.5 hours later, we were still in that room and they were sharing. And then out of the 12, one died from cancer, one died from a car accident, one died from a farm accident. The rest died from pneumonia. The average age of this group was 93. So antibiotics weren't created when their kids were young. And as a result, many of their kids, if they were ill and got pneumonia, they died. So it was, right at the end, there was that long pregnant pause. And the one that was 96, she said, it's been 72 years since I've talked about my daughter. This is going to be the best Mother's Day ever. Which reminds me that we don't only grieve in the present moment, the past and the future. So we need to go back with our clients and they may need to rework or talk about some of those losses, past, present, and future. And that was really helpful around that aspect. Father's Day came around and I was not as successful with the men. I was able to find 6. And there was no way they were talking about their kids that had died. It flopped. So the next week I met with them and I said, let's just talk about your careers. So 2 were farmers, one was a shoemaker, and a couple other were business people. The guy that was the shoemaker was so funny. I brought in the advertisement from the newspaper that running shoes cost up to $250. He used to sell PF flyers for $250. He couldn't believe that running shoes could be that amount. And so we just talked about the tools they used and working on the farm and on their stores. And then it was, so how are you guys coping here now that you're not on your farms or your stores? And that made the entrance into talking about meaning and purpose around that particular aspect. This is a wonderful tool that I use, and I ask you guys to experiment with it. When somebody's really suffering, say to them, so let's say it's, oh, this suffering's too great. I can't do that. I'll say to them, can I be the container for your suffering? And I ask permission, so that's why I phrase it that way. May I be the container for your suffering? I can't live without John. Can I be the container of your feeling that you can't live without John? And it's a way of being present. So I often then have some type of container that I'll get them to put a stone in or something, and I'll keep it on my office drawer so that they see that it's there and that I will care for it while you continue to do their work. And that's a really great tool. So and whenever I make these kind of suggestions, you'll find your own language, words that work for you that can be really helpful in dealing with that particular aspect. The cartography of grief. This is, again, I print this off, and I print off in color because it is so helpful of reviewing people with grief in kind of a picture form. So you have that cave of safekeeping that sometimes you need to go into that cave to take a vacation from the grief, to take a break, and that's okay around that. They often talk about the waterfall of tears. Most people in the first or second session will apologize for crying. And I'll say, oh, you don't need to apologize. I really see grief or tears as a sign of strength. And often they'll say, well, then I'm really strong. And I'll say, you're absolutely right. So that's the response I get. So that's a really good phrase to use. So as you go through this map of grief, you'll see the mountains of tissues. When I expand that, tissues and issues, that can be really helpful. Every time you'll take a break and you'll see the beauty outlook. And this is where guilt can be addressed, that, oh, I've caught myself laughing and I felt so guilty. And then you can process some of that. That can be really helpful in dealing with that particular aspect. This is the sea serpent of toxic positivity. And that's one of the things that we're seeing that coming out of COVID-19 is this positive psychology, just stay positive. And as a result, people are pushing down the frustrations that they're experiencing, and all that makes that really difficult around it. The unexplored territories. This one I get a lot of mileage. So when I say a lot of mileage, I mean people really resonate this. So people will often know ones that have had chemotherapy, and they talk about chemo fog. I've heard about pregnancy fog, kind of pretty well surgery fog. That's a great term, is that your thinking is going to be a little foggy. And that's just because there are so many things happening, and it takes incredible amounts of energy to deal with this aspect of it. You know, I always say to people, what our minds suppress, our bodies express. So let's take a look at what our bodies are telling us. So that's really good for us as we enter the midway point of the second phase. What are our bodies saying about this incredible workload that we're carrying on in dealing with that aspect? You get to that library of meaning, those opportunities to be able to look at meaning and purpose, the valley of the unexpected. I can remember a lady driving by St. Joe's. I was on my way to work, and all of a sudden I heard a bunch of cars honking their horns. And there was this lady stopped at a light. It was green and she was stopped. And I walked over to the car. I said, are you okay? And she saw the sign for the diabetic center, and her husband had just died a week previously. And he was diabetic. He went to that center, and she saw that sign, and she had a huge grief attack, or a grief spasm is what I call them. And so I said, it's okay. I just want you to keep your foot on the brake, put the car in park, and just slide over. A number of years ago, there were still the bench seats. And I just drove the car over to the side of the road and sat with her for a good couple of hours talking about that, and ended up, because she was a client at St. Joe's, was able to make a referral and continue to see her around that aspect. So you will have those pockets of peace, but those grief landmines, and that's a great way. Grief spasm, grief attacks are really helpful. And and as you're going through this roadmap, it's so important to have those roads of kindness, dealing with that aspect. So grief freezes us in our emotion. So to say somebody, oh, call me anytime, isn't really helpful. What's helpful is to say, I'm coming over Tuesday night to do your laundry. So if you want to separate your delicates that you don't want me to touch, you can sit with me, or you can go watch TV or go to bed early. I'm coming to do your laundry. It's that kind of stuff that makes that really helpful in dealing with that particular aspect. This is another one I use a lot, and it's really helpful, the ball in the box. So you've got life, you've got the loss of grief, and then you got the pain button. And in those early few months, the grief is pretty big, and it is constantly hitting the pain button. It's bouncing around and activating the pain button. But as we experience the loss, the grief gets a little smaller. And I had a bereaved dad tell me, he goes, I love it when people say, hi, Joe, it's good to see you, because my personhood has been affirmed and I feel good. When they say, hi, Joe, how are you? I have to lie, because I feel they really don't want to know. I really want to tell them, but it's not the right setting. So that's really helpful around that. So as that grief ball gets smaller, therefore it doesn't activate the pain button. So I'll often say to bereaved parents tell me that the pain never really goes away, nor do you want it, because it's a reminder of your love for your loved one, but it does soften. And that's a great word to use. The pain does soften, because you're not gonna, because they want that pain there. So to deny them of the pain, but to say that that's softened, those are where you plant those seeds of hope that can be so helpful. What not to say. I know how you feel. So rarely do I talk about my dad's death, unless somebody that says, oh, I don't like talking to counselors. I'll then say, well, you're not only talking to a counselor, but I just come off a compassionate leave program. So I might introduce it there as a way of joining. But in talking about people's pain, I may say, I would never say, I know how you feel because my dad died. I may say, well, when I experienced my dad's death, this is how it hit me. How's it hitting you? So as a way of saying, I have a personal experience here, but never to overshadow that the loss is always there. I did a presentation to the National Veterinarians Association, and it was on grief and pets. It was so neat to do that, because many vets have some pretty good processes in dealing with the grief. And so one guy got up and he said, well, I just tell my staff, it's okay to cry, but if you're outdoing the client, then that's not good. And I thought, well, that's perfect. You're right. You don't want to overshadow the client, but I know when a couple of dogs we put down, our vet was in tears with us, and man, that's a connector. That was really helpful. Not to say time heals all wounds. Focus on your memories. Were you close? All these statements are to make us feel better, the person that's saying them, because we feel so uncomfortable. We don't know what to say. So we say these platitudes. I got this a lot. Were you close? And I would think, well, if I said no, does that make it easier? If I say yes, I could never understand that question. God does not give you more than you can handle. He or she's in heaven. So again, it's that never underestimate the power of your presence that are so important. I want to talk a bit about Alan Wolfman's companioning model, because it is a great grief model that I think frontline palliative care workers can do during the dying process. And there's some really good things that are helpful because you create a safe place for people to embrace their feelings and their profound loss. So that safe place is a cleaned out, compassionate heart. So that's where I always have to do my own work. I have to be aware of any blinders that I have, any unconscious biases, and how important that is in dealing with that particular aspect. my first experience of someone dying from our First Nations. Her mom was dying in the ICU in St. Joe's, and she was from Vancouver Island. And she would come in, it was in the dead of winter, and she would say, "Can I talk to you?" I said, "Sure." She goes, "Well, can we go outside?" And out beside St. Joe's is this really nice park with these incredible willow trees. And she always want to go talk by this willow tree. And I always say, "I got this really nice warm office." And she said, "You don't understand. In my tradition, when I was born, my dad would take the placenta and he hung the placenta on a tree, and it would then deteriorate, become part of that tree, and that became my power tree. And as long as I'm near a tree, because tree roots are all connected through Mother Earth, as long as I'm by a tree, I'm connected to my power tree." And that was such a powerful learning. And I remember their medicine man coming and saying, "Well, we have this medicine that we would like to give her." And she couldn't swallow and stuff like that. So he said, "Could you put it in an IV bag?" And the internist said, "Well, I need to get it tested." So he got it tested, and it was just very harmless stuff that wouldn't interact with the medication they were using. So he said, "Well, I can't really put it in an IV bag, but since it needs to go in her mouth, could we put it on a sponge and rinse her mouth?" So, "Oh, that would be perfect. It needs to be done 3 times a day, and these prayers need to be said." "Oh, can you teach us how to say these prayers? Can you print them off?" It was a beautiful way of St. Joe's meeting First Nations. And when she was actively dying, they wanted to do the burning of the sweetgrass as a rite of purification. And so the internist said, "Well, we can't do it here, but we're going to transfer up to 6th floor. We're going to shut off the smoke detectors. We're going to contact the fire department to tell them what we're doing, and you can do this ritual." Again, the just meeting of that was so powerful in dealing with that particular aspect. So having a cleaned out, compassionate heart is so important. It's the art of bringing comfort to another person by becoming familiar with their story. So that's kind of being understanding their experiences and their needs. So it's the stuff that you're really good at and already, that deep listening, not having an agenda, not worrying about fixing or rescuing. And it's just, again, trust in the other person's process. So that's probably the biggest thing when I'll say to people, you just got to trust the process. It's offer that receptive silence. So whenever I don't know what to say, that's a message to keep my mouth shut. I think that's why God gave me 2 ears and 1 mouth. So important in dealing with that particular aspect. And then just being that fully present with deep concentration and compassionate curiosity is a great way of saying that aspect. This last phrase is really important. Shield yourself with detachment so you can walk intimately with them without taking on their feelings. So at first I thought, oh, detachment's great. You don't have to get involved. And then the next part is to walk intimately. So I think the detachment is so that you can really be present, so that you're not connected or hooked on some issues that you are still working with, but you can be dealing with that. If you have a current loss that you're dealing with or a particular issue, does that mean you have to step away from hospice palliative care? Absolutely not. Life happens to all of us. And as long as we're aware that we're coping with that and that it's not affecting our work, and then relying on our colleagues to be helpful with that. Focusing on those sensory clues. So for example, if a person says, "It was the most beautiful sunset I ever saw," I'll use the word like beautiful. So that's not a good example, but something like, "I hated seeing my mother suffer." And then I would say, "Suffer?" In a tone that's, "Tell me more about that." If they're holding their arms over their stomach, I'll bring that up. Often you will see people when they're talking, if they put their hand on their chest, that means this is coming from the deep heart. And so that's just something that cues me on to, oh, really pay attention to this. And often, and once I build a relationship with them, I'll say, "Do you realize when you talk about your mom, your hand goes over your chest?" And then that often gets into a bit deeper place that can be really helpful. around those aspects. Can you tell me more about your anger? If someone's crying, what are those tears? I wouldn't put it, what are those tears? Can you tell me a bit more about those tears? Can be helpful. Ask cup emptying questions. This is a really good part of companioning. You know, asking, how was that for you? You know, the person says, I'm really worried. Can you tell me about what those worries about? Often remaining silent, or, you know, so what are you unsure of? So that gives them a chance to empty their cup around that. And it's not so much directing it, because they're mentioning it. That can be really helpful. Virtue questions, again, reflection questions. If there's something they're frightening, can you what gives you courage to deal with this? What gives you peace? So using those virtue words can be really helpful around that aspect. Closure, this is something that's been so helpful for me and has really changed my practice. Was it helpful talking about this? Is there anything more clear to you? Or what did you appreciate about our meeting? And usually the next session, people will say, you know, I found it helpful you kind of reviewing with it, because that was the last thing that came into my mind when I left. So I think it's really good. Not only you're asking for an evaluation around that particular aspect. I remember once a young woman came in. She had experienced a stillbirth, and she had one child. She was a single mom, really struggling. And it was at a point in therapy where I didn't want to cancel any appointments. And she was coming in at 2 o'clock. At 1:30, I felt so nauseous. And I thought, well, I've heard of Gravol. I was Gravol naive, never took Gravol in my life. So I took 50 milligram of Gravol. And halfway through the session, my head just snapped. And I caught myself, and I was so embarrassed. And I didn't say anything. I thought, oh, she was turned away. The next session, I came clean. I said, I need to apologize about last session. I was feeling odd. I took some Gravol, and I think my head bobbed. And she goes, oh, thank God you said something. I thought, my problems are so insignificant that the guy's falling asleep on me. So it's so important to come clean. I should have said, we really need to schedule, because I really couldn't be present for her around that. When it was also a really good message that if I make an error, follow up on, talk to people about that are so important. So here's Wolfette's companion model, kind of in one page, which are really good. Being present to another person's pain, it's not about taking it away. Going to the wilderness of the soul with another human being, not thinking you're responsible to finding the way out. Already I'm feeling lighter, because it's a joint journey, and they're going to be relying on some of my experiences, expertise. But as long as I got that compassionate care approach, that's what's important. It's about honoring the spirit, not focusing on the intellect. Listening with the heart, not analyzing with the head, and then bearing witness to the struggles. So the fact that you're there to listen, to provide the care, is so important around that. Walking alongside, not leading or being led. Then there's that gifts of sacred silence. As a professional, we were told early in school that, you know, if there's a period a person isn't saying something, it's your job to say that. Now that's drastically changed now, where it's that sacred silence. It's being sometimes so moved by it. It's so important that being still, it's not that frantic movement forward. So I bulged a couple of discs in my back and a number of years ago. And so I fidget a lot in my chair as just relieving some pain. I tell people in the first session, you're going to notice that I really fidget. It's not you. It's not that I'm bored. That's what's really important around that. Let me just stop here and tell you that story about how I bulged my discs. I got called into a sudden death. It was around 2 a.m. It was a gentleman. I didn't have a medical record, so I knew it was a sudden death out in the community. Family were coming in to view the body and say goodbye. So I came into emerge. They were swapped. So I usually take a nurse with me, and I didn't. My first mistake. So I go up to the morgue. I I take the body out of the morgue room. I unzip the body bag, and it was a gentleman about 35 years of age, and he had some dry blood on his lips. He had a fairly thick beard. So again, I didn't have a medical record. I just thought assumed it was a car accident. I dipped a towel into some water, and I was just going to clean this up. And when I flushed away the blood, well, that was actually the seal that was keeping his mouth closed. What had happened was he was moving a house trailer, and he was underneath it, and the footings gave way, and the house trailer fell on his chest. He was killed instantly. But when I broke that seal, all this blood came shooting out at me because of the pressure of the wound that he had, the crushing injury. So I just cleaned that up the best I could, brought the family in. They said their goodbyes. They went home. I put the body back in the morgue. I went home. End of story. So I thought. 3 months later, I was playing golf with my father-in-law. I played golf with my father-in-law back then twice a year, whether I liked it or not. I didn't like it, not because I don't like my father-in-law. I just am a horrible golfer. And I was going to kill that little ball. And I ended up hitting the ground before the ball did. And I bulged 2 discs in my back. That's when I started to have nightmares and night terrors of that blood shooting out at me. I had suppressed that for 3 months, and I wasn't even aware that I was suppressing that. So the learning lesson there for me was constantly having that opportunity to debrief. So from then on, whenever I did a sudden death call, I would always go by the palliative care unit. They would see me and say, "What are you doing here on a Sunday?" And it gave me a chance to tell the story, to get it from here to here, out here. As healthcare professionals, that shouldn't bother you. That should be a piece of cake, and it doesn't. They have that impact on us around that. Respecting that disorder and confusion, not imposing logic, learning from others, and that compassionate curiosity that's so important in dealing with that aspect. Okay. Again, a really powerful, lucky this happened to me early in my palliative care career. Mom was diagnosed with advanced breast cancer, multi-node involvement. She needed a double mastectomy. And back then there was a three-week admission, and that made it really helpful in dealing with that aspect. So we got to know her for quite a while, and she had an 8-year-old and a 5-year-old, and they decided to tell the 8-year-old that the prognosis was really poor, but not the 5-year-old. And she was starting to act out in school, so they asked me to spend some time with her. So of course, kids don't do really good with big people style of counseling. So I asked her to draw a picture of her family, and that's what she drew. So as you can see, everybody's smiling but her. Mommy doesn't have any arms, and the son is down here. And that was the hope for me, that the fact that the son was there, albeit at the bottom of her life, it was there, and that was the sign of hope. So I talked to her about it, and she goes, "Well, everyone's happy, but I know there's a reason we shouldn't be happy." And then she explained the arm. She goes, "Mommy used to be the bestest hugger, and she doesn't hug me anymore." So I asked, "Well, can we bring this in and explain that to Mommy and Daddy?" And she did. And what the mom didn't realize was she was already starting to shut down. It was too painful to say goodbye to these kids, so she was shutting down, and she didn't want to do that. This little girl had the courage to say, "This is what's happening." And so she said to her, "Well, what is your biggest concern?" The little girl said, "Well, you're not going to be there for my wedding." And I remember going back to the nurse's station saying, "I don't get this. 5 years old, she's worried about her wedding." The nurses whacked me on the side of the head and said, "What's happening in June?" I said, "I don't know what." They said, "Well, Princess Diana's getting married, and every mother and daughter is talking about that." And the mother replied beautifully. She says, "Well, when I get out of hospital, we're going to go out and buy some lace that you're going to incorporate in a dress, and I'm going to pick out some songs." And they had 2 wonderful years of preparing before she died because of the courage of this little girl. So that's where that, we need to make the unspeakable speakable. That can be helpful in dealing with that aspect. These kind of different paradoxes of grief that I just want you to reflect on, that can be really helpful. You know, pain is the agent of change. There's just some really good paradoxes. There's 8 of them that I just wanted you to kind of reflect on around that. This was, again, a really example of presence. Mom and a dad and their 2-year-old, their car broke down on the 401. No, I think it was Highway 8, just outside of Kitchener. And the dad was outside on the phone with the OPP saying, what do we do? And he said, well, we advise that you get your child and your wife out of the car. And just as he said that, this moving van smashed into it. Mom was seriously injured and the 2-year-old was killed, brought to Hamilton Hospital and then to Stratford for recuperation. They only spoke Mandarin. So when I got involved, the translator was there and I said, please tell her that as she talks, when I go like this, it means I understand and I care. So I would go in for about 45 minutes a day and she would talk in Mandarin and I would just occasionally bob my head. I remember going in thinking, is this doing any good? You know, you couldn't evaluate it. And then she had somebody write a letter to say how helpful that presence of just being able to talk to a non-judgmental person, because I couldn't be, I didn't understand the language. So again, just that really good message about the power of our presence that is so important. This is the accident that was those 10 migrant workers just outside of Stratford. They missed a stop sign and a truck driver plowed into it. It just, when you have these big multiple losses, it's just so important to make sure we continue to do multiple debriefings. So we had to do numerous debriefings around this. These are the 2 that survived and still in Canada trying to get treatment and wanting to get permanent residency because they won't be able to get the treatment in Peru and then get their families over around that particular aspect. But a lot of debriefing for the public workers that had to clean up the carnage was really important in dealing with that. The person who died feels alive to us, even though we know they're actually have died. So I'll just leave that for you to reflect on. There's an organization in New Zealand, a bereaved mom who's a photographer, and it's called Write Their Names in the Sand. She may have changed that, but if you get there, it'll bring you to the right site. And what she does is bereaved parents send the name of their loved one, and she sets up this picture and then takes it right before the waves come in and wash it away. It was just incredible. So this was a client of mine who had a 3-day-old that had died. And so she has this about, you know, it's 6 feet by 6 feet above her mantle, and half of her family love it, half of it hate it. But it's just such a powerful image. And I remember calling her saying, man, the work you do is great. She told me the story about one, I think the name was Peter. So they set up all the cameras, they write the name, and all of a sudden this dog comes out of nowhere and footprints all over the name Peter, and they couldn't do it. So they do it again, and sure enough, this golden retriever comes again, walks all over it, and then takes off. So the 3rd time the dog never came, or no, they couldn't do it the 3rd time. So they just sent a picture with the dog prints, and the mom called her back, the photographer said, how did you know we had a golden retriever? Just the intricacies of that are so important. Again, you may wait to be happy again, knowing it's right and fair, but feel guilty. So that survivor's guilt is always a big one. So I got busted a couple years ago. We had Juliet for the weekend, and then we sent her home. And Monday morning, Brittany's getting her ready for school, and she says, Julia, what would you like on your toast? And she said, Smarties. She goes, well, you can't have Smarties on your toast. And she goes, well, Mom, you better get me back to Pepe's. So she's making an appropriate sandwich. And then she says, Julia, I'm really curious. How did Pepe keep those Smarties on the toast? She goes, Nutella. I got double busted. Well, so here's my rationale. As long as she's saying her prayers and you got whole wheat bread, it's only once a month, it's good to go. Wisdom stones. I have about 30 jars of these in the truck, in the car, and I use them a lot. So I'll give a jar of stones to one of our palliative care patients and say, I want you to put all your love and wisdom and affection in these stones, and then hand them out to your loved ones. And this is such a simple ritual, and it is so profound and beautiful. I've had some families make the stones into a nunchuck, and that's meaningful. Usually the kids and the grandkids will walk on the beach at Lake Huron, and we pick up the stones and I varnish them. So it's their way of helping Dad and Pepe. So that's really neat around that. But it's a simple little ritual that's really helpful. I'm working with a young dad who's dying of a neuromuscular disease, and her 8-year-old daughter is going to be going back to school on Monday. And so she's been able to spend all this time with them. And so I had given them some stones that had words on them. And so I asked them to put all this wisdom into the stones and then give her a stone, and she could bring that to school and still feel close. And whenever you feel like you're missing him, you just hold on to one of your stones and know that Daddy's got one of those stones with me. And so does Mommy and Grandpa and Grandpa. So those are really neat little kind of legacies that we can do in dealing with that aspect. So I carry a container like this. I've got 3 on the go, and I leave them with family members. So what I'm doing is really encouraging you to take a risk on having these things of legacies. You can get them all at Mark's or at a dollar store. It's very inexpensive, but really neat. So this is what's included. So the stones, some kits where they can color butterflies. A little 5-year-old lent this to me, that she did this for her mom before she died. So hummingbirds, butterflies, dragonflies are really important. These little glass jars with a paper in them, they can write a message to their loved one that's dying, and that can go into the casket, or they can keep it, or the loved one that's dying can do it. It can reverse many ways that are really helpful around that. This has been really popular, fairy dust. So the loved one puts all their love and affection into the fairy dust, and then they spread it. So one of the little kids said to me, is this biodegradable? And I said, no. So I'm now sourcing sand or seeds, something that will be biodegradable, because you really can't do this in a house. It really makes a mess. You can get these things from Amazon. Again, the dragonfly means you know, making that journey of change. Same with the butterflies. They can come with the chakra colors, but these are loved ones giving them to their kids that they can hang up, that I'll always be there present. So those practical things that can be really helpful. Same with the memory boxes. Always keep those around, where people can create that, a way of getting those memories that can be with them. And it's a way of reviewing that complicated grief that can be helpful. So this is what I did. So this is over to the left of me. My mom loved Lake Huron, and so she would always get these. She built a stone garden, and so I took 6 of them representing, there's 4 kids and Mom and Dad. She loved wood, so I did this live veg, and so it's just a constant reminder for me that I'm kind of surrounded by my sisters, my mom, and my dad. That can be really helpful. So I also encourage you to do some kind of legacy work. That someone asked, you know, how do we keep on going? Well, we have to have our environments. You know, when I think of the LINs and the cubicle cities, you know, making your cubicle that can be helpful in dealing with that aspect. So again, that I am a container is a really good tool. I wanted to throw this in twice just to say it's so helpful. So this is the other one I do. It's a hug blanket. So I got about 30 of these. You can get them at Giant Tiger. They're Canadian made. They usually come on sale for $4 to $6. And all you need is a permanent magic marker. And you get the person that's dying to do a hug blanket for their loved one. So I did one for Julia, just to show that you don't need to be an artist. And it's quite evident I am not an artist. So I'm not sure why I gave elbows on both sides of my arms. I'm not sure why the arms are that long. I surely don't have muscles that big. I've written a book and a bunch of articles. I still don't know how to spell, but I think I nailed the glasses. And so we've just gotten so much mileage out of this, in the sense of people find this so helpful to get connected to their complicated grief around that. So I encourage you to do these for your loved ones, offer to do it for your clients. Incredibly helpful in dealing with that aspect. Darcy Harris and Eunice Gorman, two teachers at University of Western, talk about these things about grief. And it's this one here: initiate rituals where none exist around that. There's just going to be some information on grief and the touchstones of grief, and the 6 needs of grief that I want you to do. And then I just want to end with a story. This is Canuck Place Children's Hospice that I worked at. And this was where the parents stayed. This was where the 14-bed unit is. My office was in one of the turrets here. And it was the first hospice for children in Canada that was developed. So my job was to often go to golf tournaments and receive ridiculously large checks. As you know, I don't really like golf, so I never golfed, but I went to 77 golf tournaments that one summer. And one of them I immediately knew. The guy came up to me, a very famous Canadian Football League player, spent his whole year with the BC Lions, his whole career. And he just retired. He came up to me and said, if there's anything I can do for the hospice, let me know. I said, okay, great. I took his card and went back to the hospice and threw it at my desk. And about 2 weeks later, we had a 14-year-old boy who came with end-stage stomach cancer. He had to take 2 ferries and a plane to get to Vancouver. That's how remote they lived. I walked in, no other children. Parents were going to stay in the apartments for end-of-life care because pain control was a real issue. I walked in, and huge BC Lions fans. They had posters on the walls. They had jerseys hanging. And then they said, because they lived so remote, they never met a BC Lion football player. Oh, I got an idea. So I didn't tell them, called the guy, told him the situation, when can you come? And all of a sudden there was this long pause. He said, well, I was thinking of doing a golf tournament. I don't think I can help a kid that's dying. I said, just come and talk about football. I promise if it gets uncomfortable, I'll get you out. Well, he agreed. We teed up a time that Thursday. I meet him in the parking lot. He gets out of the car empty-handed. No autographed football, no autographed jersey, empty-handed. So I thought. We go up to the room. Of course, I didn't tell the little guy or his parents. And he walks in. Of course, they recognized him right away. He's bouncing off the bed. He knew how to use our conference call system. He called 4 of his buddies back home. You'll never guess who's in my room. So they had a chat, and then he hangs up, and they talked a bit. This guy had won 2 Grey Cup rings with his career with the BC Lions. And all of a sudden the little boy said, the hardest thing about having cancer is that I'll never be able to play football again. And he used the word dying in there, and he had never used the word dying. And all of a sudden, everybody's eyes went to the ground, and I'm about to yank the football player out of the room. And the football player reaches over, and he slips off his Grey Cup ring, and he gives it to the little boy. He says, I want you to hold on to that ring as hard as you can. And when the pain gets too great, you just squeeze it even harder, and you keep it as long as you need to. And when you're done with it, just give it to your mom and dad, and they'll get it back to me. We all have Grey Cup rings. Some of them are bright and shiny on our hands in full display. And some of them are bumped and bruised and scratched in pockets and the bottom of purses or at the bottom of drawers. But we all have Grey Cup rings. And all of you slip off your Grey Cup ring daily. And as long as we're aware of the cost of that caring, as long as we're aware of the cost of slipping off those Grey Cup rings, that's what's going to allow us to continue to provide excellent and compassionate care. So I thank you for this wonderful opportunity, and I'll leave it open to Monica.
Thank you so much. Difficult to talk after this story. I am still moved.
Oh, good.
I can't thank you enough, Eugene, for this inspiring afternoon with you that I know will be lasting in the hearts of all our attendees today from all across the north here in Ontario.
Oh, good.
So, and Michaela will have the conference evaluation soon online.
Yeah.
So we are
So,
open to your last.
Yeah, what I'd like to offer, and we'll talk about this. I was hoping to send you all a book, one of my books, but it's in second printing, so it's not quite available. But what I'd like to do is, I'll leave this up to you, Monica. 2 weeks from now, 3 weeks from now, if you wanted to do a 1.5 hour follow-up session at no cost to review what we've learned, gives you a chance to review the material, and we could just do an 1.5 hour kind of discussion, or I would even also be willing to do the how to create a debriefing program. So that would be, I would love to give that gift to you folks.
Thank you from our heart. I am quite sure that everybody here is saying thank you. And we will follow up with you by email. And if as soon as possible, if we can have this blessing of scheduling the 1.5 hour follow-up, it's an honor, really. Thank you, Eugene.
You're welcome.
You have a wonderful weekend, deserved rest. Thank you for the inspiration. And now, Michaela, I would like to call you for the evaluation of the conference before our friends all go to supper, because everybody must be hungry now.
Yep. So as soon as we end the meeting, you'll get a browser will open up with the conference evaluation in it as soon as we click end here. So it'll just take a couple minutes to fill out if you can do that for us.
Thank you so very much, everybody. It was a pleasure, unforgettable time to be with you all. And we expect you next year on the first Friday of February for the next winter conference. Thank you very much for being with us.
And there's my phone number and email address. Feel free to contact me.
Awesome. Thank you so much, Eugene.
You're welcome.
Bye, everybody. Happy Friday.
And thanks for all your work, Scott. That was great.
Not a problem. Glad I could help.
Can you end it from your end then?
Sorry, what was that, Monica?
Who is ending the webinar so to call the conference evaluation?
I can only leave the meeting. If you press leave, it should go end meeting for all.
I have an end button here. Is that I have to press?
Yes.
Okay. End the meeting for all or leave meeting?
End meeting for all.